Wilkins of 8, mild MR, severe PH. Best strategy for him is going to be what? That's what I'm going to discuss. So this is the case. Dr. Zishan already mentioned that a high gradient of severe critical tight stenosis with severe PH. So we have a three-cornered fight, and you need not guess who's not all the three heroes amongst the three. Who's not hiding his face is Wilkins supposed to be the cardiologist because he doesn't have anything to hide. So he can be open and he can share, so I'm going to discuss. So this is the case.
Why
Dr.
I
Zishan
would
already
suggest and
mentioned that
vouch for BMB. The reason one is just look at the STS scores, how the surgeons interpret their own operative.
So we have a three-cornered
fight. If we were to look at the CMC,
UNC,
or even MD repairs or MDR,
all the three heroes amongst the three, who's not hiding his face is Wilkins supposed to be the
because almost 1 to 1.5%.
Reoperation be open and he wants share for the discuss. So this is the case.
I already mentioned vouch for BMB. The reason one is just in minority how the surgeons interpret their own operative.
So we have a three-cornered fight.
If we were to look at the CMC, UNC, or even MD repairs or MDR,
all the three heroes amongst mortality risk are almost 1 to 1.5%, reoperation rate 5%, morbidity or mortality 11 to 12%, and short stay is in minority of the patient. Long stay hangs to be in 7 to 12% of the patient as calculated by STS version 4. Compare this with BMB. Score less than 8, optimal results would be achieved in more than 90% success, less than 3% complication rate. Compare this with, say, complications here, which is almost 4 times, and 80 to 90% of sustained improvement even during the follow-up of 3 to 7 years. Reason 2 why I vouch for BMV is the guidelines. Look at any guideline, even the appropriate use criteria of 2017, or if you look at the ESC guidelines, all of them, they talk in the ACC guidelines, they talk about in mitral stenosis, it has a class 1A and 1B recommendation, even who are not high risk or who are not candidates for failed previous PBMV. Even then it's 1B. First mention in these guidelines for surgery comes at level 2B. The mitral valve surgery, even when you're planning to do an LA appendage exclusion in severe MS, who have recurrent emboli while receiving anticoagulation also receives 2B. Reason 3 is it's an old data published from GB Pant itself. When they looked at the immediate randomization, and I'm going to talk about Indian patient and hence the Indian data. This is very old patient of Aurora ma'am, which talked about comparing the two, and it found out that the results were as good or even better with BMV with less complication. Internationally, this is one of the paper which actually changed the guidelines. 7-year follow-up, Mohammed bin Farad's paper published in 1998, which looked at 7-year outcome, and there was no early late but mortality or thromboembolism between the 3 groups, but MVA was similar as compared to open surgeries. Residual ASD was in only 2 patients. So my surgeon friends may harp upon creating an ASD. It doesn't last there, which actually is a beneficial thing that you can end up actually going through the PFO in most of them. What about longer duration? 12 years. This is another data from Boletti et al., Long et al. Published when they looked at 912 patients followed for 12 years. Overall survival rate of 20 years was 75%. This is the longest follow-up data that we can talk about. So surgeons can talk about valves lasting forever, which is actually not the truth, which I will again discuss. But the BMVs do last for quite a long while. And this is our own paper published in Indian Heart Journal, where we looked at even redo cases following previous mitral commissurotomy. So where surgeons have done BMV and OMC, or OMC and CMC, even those patients we did end up doing BMVs with fantastic results. Again, you can see Wilkins score was favorable only in 2/3, 68% of the patient, in 31% of the patient, most of these patients, despite having a Wilkins score more than 8 after undergoing CMC, OMC, actually ended up getting fantastic results. This is the reason 6, which is a new data, 2021. What about normal sinus rhythm? This patient is in normal sinus rhythm. AF group had less favorable outcome, but this patient is in sinus rhythm. And hence compared the loop, it all published that the patient who do well on BMV for the rhythm versus say atrial fibrillation, the normal sinus rhythm in this meta-analysis of 6,000 plus patients actually did much better, especially in terms of the valve area. It doesn't mean otherwise, but you can do BMV and AFib as well. But if you have normal sinus rhythm, it's one of the important reasons why you should go ahead and do a BMV. Of course, the lesser complication, out of 12%, my surgeon friends may hop upon you create MRs and I have to rush. No, that's not the case. It's very rare that you get with MR in an improper technique or improper valve. The survival rates in those patients actually who have mild to moderate MR, it's better than compared to those who don't get an MR, because the MR reflects probably a better opening of the valve. So 8 event-free survival, second PBMV heart failure requiring admission was significantly lower in patients who had significant MR post BMV as compared to those did not. This did not mean severe MR, but mild to moderate MRs post BMV are actually good in long-term survival. What about the comparison outcome per se with OMC? Because I have to fight a double corner. You have 2 surgeons punching at my jabs. So I need to be debating that way. So I'm going to take one of them one by one. So PBMV versus OMC, this is a 60 patient data from RISE, where they looked at the bilateral valve area going up from 0.9 to 2.1 as compared to only 2. So which is actually, I'm not saying superior, but surely non-inferior. Actually, probably surgery, people are harping on being non-inferior here. After 3 years, patients with percutaneous had a higher average valve area and a greater likelihood of NYHA functional class as compared to patients who underwent open surgery. Now, there is a problem why the surgeons were wearing a mask, why Batman and Spider-Man had to wear a mask, because you end up replacing one disease with other. This is not what I said. This is what Denton Cooley said, that leaving a prosthetic valve to a patient is replacing one disease with another. And what is that disease? It's a disease of prosthetic valve. What is that? The thrombosis or the bleeding. What is the thrombotic risk in life-threatening complication? 1.8 to 5.7% per year per patient. So that is per patient year, you have very high risk of a patient coming up with a choked valve. And then you will have to actually end up giving a thrombolytic therapy, or maybe you'll have to reopen by doing another surgery. What about bleeding? If the patient is on VKA, 69% of VKA versus 31% on, even if they end up with prosthetic tissue valves. Tissue valve patients, even on aspirin, end up bleeding. 3-month post-operatively, cumulative incidence of the combined endpoint was 9.2% VK, 11% aspirin. No difference observed in thromboembolic. So VK aspirin should have similar event rate of 10% during 3 years, 3 months after MBR in patients without prior AFib. Other my surgeon friends may harp upon is cost. Of course, balloon mitrals, even when you use new balloons, is going to be cheaper than having a replacement or open surgery. And on top of that, mere paas maa hai. So that's the MA card. That's the insurance that the government provides. You inflate the balloon and the balloon valve is actually better because you go fluoroscopically rather than a blind procedure like closed mitral commissurotomy. What about duration of hospitalization? 1 to 2 days. OMC, CMC, MBR, even if you're a fantastic mini thoracotomy surgeon, 5 days. This is the pain, scar, anesthesia. That's all you end up. We just go from the groin. And remember, we are not even puncturing the artery for the sake of procedure. It's just the vein. The anesthesia, of course, we just do under local anesthesia as compared to endotracheal intubation. And this is how we actually have access not only to what we are doing, but also having a fluoroscopic look of inflating the balloon and controlling it and looking out for the procedure perioperatively by echocardiography. So why replace one disease with the another potential one? So the good news is that we have got very few customer complaints, because the bad news is that most of the customers end up getting BMV. So you will have probably in the time of mitral stenosis may not have more patient complaining about valve thrombosis if they end up with getting more BMVs. And with the Joker's quote, with the 3 heroes, I think the villain also has to come in. So whoever fights monster should see to it that in the process, he does not become a monster. When you end up probably treating a disease, you should not replace that disease with another disease, which is a valve. Thank you very much. Over to Chair. Thank you for patient hearing.
That Dr. Kamal Sharma gave, I think I needed a sip of water. So let's go ahead and see. You know, it's very easy for a cardiologist to say that surgeon can do nothing and they are like God. There was a time when cardiac surgeons were treated like God. And now today's cardiologists have come up and started saying, we are God, we can do anything you want. And but they are the judge and the jury themselves. And hence they think that whatever they do is the best. Well, you know, actually, Kamal has forgotten to see what his patient is suffering from. The patient has NYHA class 3. She has got intermittent palpitation, which may be a symbol of which may be underlying atrial fibrillation. And she has got severe pulmonary hypertension. And she has got a Wilkinson score 8, but there is no clot in LA. So let's see what happens. What is the aim of treating any patient with valvular heart disease? Our aim is to neutralize the disease, and survival and quality of life should be same as the age-matched population. I'm not talking of 5 years, 6 years, 7 years. Patient should live as long as any other person lives of that age, and we want to neutralize the disease. How can you neutralize the valvular heart disease? If you get the patient into a normal atrial and ventricular function, there is no rhythm disturbance, and perfectly normal long-term function is what we are aiming at. We're not looking at, she's 30 years old, 33 years old. She's got to live for 80 years. You can't talk of 6, 7 years of stuff and say that's okay. How can we do this? We should get her valve area more than 2 centimeter squares, and we should try to get her back into a permanent sinus rhythm where there is no episode of palpitation at all, and resolve her symptoms. Mitral valve is not a simple thing. It's got chordae, it's got papillary muscle, there are 2 leaflets. I think I would like to invite Kamal one day to the theater and show him how complicated this valve is. Not something just to be blown up with a balloon where you don't know what's being blown up. So if I was a surgeon, what would I do for this patient? I would do a commissured to complete valvotomy. We would ligate the LA appendage. We will go down to see the subvalve, the chordae, split the muscle, split the chordae, remove whatever pathology is there, decalcify the leaflet, do a biatrial maze. And if this patient has got tricuspid regurgitation more than moderate, or if her tricuspid annulus is more than 40, I would also like to repair that. Mind you, this patient got severe pulmonary hypertension and she can have moderate TR. And by all the guidelines, if there is more than moderate TR, when you are addressing mitral stenosis, atrial tricuspid valve repair is must. I have seen more suffering and more misery with tricuspid valve repair than I have seen with primary valvular heart disease. So surgical exposure is wonderful. There's a lot we do on the table. We split the commissure, split the submitral apparatus, split the papillary muscle, split the chordae. We make it absolutely normal, and we put a ring. And what do we get at the end of the day? We get a patient who has a valve that has no mitral regurgitation or maximum mild possible regurgitation. We would aim for an area of more than 2 centimeters and a normal sinus rhythm with an LA appendage that's ligated. So basically, all the pathology has been corrected. So what have the results been? You know, what is the actual survival of a good open mitral repair? 94.6% at 14 years. Sorry, it's not 4 years. And an 83% at 14 years free from reoperation. And there is this particular study by Antunes, who was one of the leaders in valve repair and leaders who promoted valvular heart surgery. He says that there are not one, but so many patients who have, you know, more than 20 years of survival without any reoperation, without a problem. I'm sure all of you have seen a patient of CMC which was done maybe 20, 30 years ago, and still the patient has a valve area of more than 1.7 or 2 centimeters. In this study, he said that most of the patients who had preoperative valve area of 0.99, post-op had areas of 2.88 centimeters square or more, and 37% had more than 3 centimeter valve area. Means that's the normal mitral valve. That's what the surgeons aim for. We don't aim for slipshod or half-hearted jobs where we just blow up a little bit of commission and say, oh, the patient is okay. We look at 98% freedom from reoperation, 98% freedom from mortality. We look at 98% freedom from complications. This is what we aim at. This is what valve areas we look at. More than 2.5, 3 centimeters. Means the valves have to be wonderful. They have to look like brand new valves when you go and repair it. It's not just opening a little bit of commissure that makes a person okay. So let's get that one clear, that surgeons do a very nice job, a complete job. And what if I'm on the table and the valve is not okay? I can just go in and replace it. Not like, you've got a leaking blood into the pericardium where something is punctured, or a severe MR and the patient suffers all night, and in the morning you come and tell me, oh, that patient has got severe MR. Can you do him now? And by the time that patient is dead, it's not like that. We can just go and straight away change the mitral valve and put a new valve. And prosthetic valves, they are wonderful right now. You have an actuarial survival of more than 75% at 15 years. And let me tell you, new valves are on the block. There is a new TRIA valve that's coming, which will not need anticoagulation, and it will last for the patient's life. It will be a game changer as it comes by. So surgeons have not said the last word yet. Let me tell you that. There's a lot that's happening, and there are not one but ample number of trials that show 15 and 20-year data of mitral valve replacement or aortic valve replacement where prosthetic valve patients have done very well. And I'm sure, Kamal, in your OPD, you must be seeing some patients that we operated in 95, 96, when I was at UN Mehta or Institute of Cardiology, and they're still coming back to you for follow-up. So prosthetic valves do well. Not all of them die with thrombosis or problems. That people die. Some patients die. And most of the data everywhere says that definitely repair is better than replacement, but replacement itself is not bad. So what should we do? Repair or blow up the valve? Surgery can neutralize the disease, but can BMV give a better result? Let's see what there is to be said. Now, look at this. You said that the Wilkinson score is 8. What does Wilkinson 8 mean? Let me tell you that Wilkinson is a very vague scoring. Wilkinson score is a very vague thing. It just talks about mobility, thickening, some calcification, something like that. There are 4 criteria, and you just make 8 out of this. But does it look at commissural calcification? No, it does not look at commissural calcification. Does it look, that is the most singularly important thing in a valve. Does it have commissural calcification or not? And there is nothing about that in Wilkins score about commissural calcification. So what are the limitations of Wilkins score? All the cardiologists jump around. Oh, Wilkins score 8, let's do it. It has many limitations. Number 1, it doesn't look at commissural calcification. It's very observer variable. Observer may think this valve leaflet is good. The other one may think it's bad. And I've always seen, even if I show them a report of 8, the cardiologist will say, I'll have a look. Then he goes and have a look. And then he says, no, this one is calcified. This one, the commissurers are not good. Something is wrong. So let me tell you, we are going on a very, very, a score system that is not perfect. It has nothing about it. 8 means nothing according to me. So if you ask me, and again, Wilkins score does not have anything about contraindication. Can you believe a score that there is no contraindication? Anybody, according to this 16 scoring, but the risk is low or the risk is high, go ahead and do a BMV. You don't know what the leaflet is like. You don't know what the commissures are like. Just a little bit leaflet thickness, little bit subvalve fibrosis, and just go and do a BMV. Wilkinson is 8, I am happy. Wilkinson is 9, I am happy. 2 observers, if you send for an echo, both will give you different results on Wilkinson. So that does not mean anything, let me tell you. More than that, does Wilkinson identify the high-risk subsets? No. You just look at Wilkinson, go and do a BMV. No, it's not like that. ACC, AHA, and ESC all have defined certain high-risk criteria. They say whether the anatomy is good or bad, there are certain contraindications to BMV. And in that, they have mentioned atrial fibrillation and severe pulmonary hypertension. This patient has severe pulmonary hypertension, intermittent palpitation, which definitely stands for atrial fibrillation in the developing, means her left atrial appendage is already hypertrophied and she can get into trouble. Now, what is a successful BMV? Have you ever heard what is a successful BMV? A successful BMV is where the valve area becomes double or there is a 50% improved from the previous valve area. Do you know when a cardiologist comes and said, valve fully means from 0.8 he has made it 1.6, and I would like to ask the audience, how many have you seen valve areas post BMV that cross 2 centimeters? In my life, till now, I have not seen one valve that has come with an area of more than 2 centimeters. 1.5 is excellent result. They will write excellent. Mild to moderate MR area or 50% gain from pre-BMV area. Now, what is 50% gain? If it is 0.8 and you make it 1.2, it is still vital stenosis. So this is a very subjective thing. Send me these echoes. I'll have a look and tell you what the real valve area is. So it's that a good BMV, they're scared of MR. So they'll inflate the valve a little, come in, come out. That's how it goes. So that's not the way you treat a patient. And this is totally subjective. Let me point out this paper to Dr. Kamal Sharma. I think you should start looking at commissural area ratio and leaflet displacement. These are better guidance than Wilkins score for a BMV, because this looks at commissural calcification, which is more important. Also, you should have a better look at the submitral valve apparatus, that you carefully, you may open the valve up there, but if the submitral is bad, the patient still does not make it. That's very important. People say commissurotomy outdated. Look, patients have data of 20 years, 30 years, 40 years. This data is up to 30 years, where there is 45.9% survival at 30 years, which is excellent. This particular paper from Antune says OMC remains the best alternative for treatment of all cases of mitral stenosis, independent of degree of pliability. In our experience, the median long-term results are significantly better than those usually reported in PBMC series. And these are all big pioneers. This is from Shiv Kumar Chaudhary, Delhi, where they have seen an average mean area of 2.6 centimeters plus minus 0.6 centimeters, and their long-term follow-up shows excellent survival and good results. You know, many times we wonder, why should BMV not be as good as OMC? I'm sure none of you have gone and read your books of rheumatic heart disease and its pathology after finishing MBBS. Rheumatic heart disease is such that if there is turbulence, if the flow is not good, then recalcification can happen. The main reason, Spencer et al. Have reported, the main reason for better result is reduction in turbulent blood flow created by a widely patent and competent mitral valve, diminishes progressive valve fibrosis, and generally obviates the need for future valve replacement. So surgeons can obviate the need for future valve replacement because we do a complete job, not an incomplete job like our cardiologist does. And you have open mitral data of 18 years, 20 years, for years and years we have data that is excellent. See, they will show
up a little bit, sir.
2 minutes, just 2 minutes. BMV, some data is presented to us, but go and look in general in the data. What is it like? BMV event from survival 69% and freedom from stenosis 71%. Actual survival 56% at 10 years. This is the type of data I came across.
Everything has been said before, but since nobody was listening, it has to be repeated again. This is what Andre Gede said. OMV and CMV are very much alive, extremely relevant and modern. To consider them old-fashioned is wrongly banishing the huge patient population of patients of mitral stenosis either to incomplete treatment, and that is BMV, or unnecessary mitral valve replacement. There is a great place of OMV and CMV in this scenario. Of course, I do admit BMV is a procedure of choice. Isolated, uncomplicated mitral stenosis with very favorable morphology, like nicely pliant, non-calcific valve, minimal subvalvular crowding, consistent sinus rhythm, not intermittent, and no left atrial thrombus. Go ahead, Kamal, do a BMV. But remember what I'm saying. The profile that you have given me is incomplete. There is no mention of rhythm, no mention about LA clots, and there is no mention of tricuspid valve disease. This is exactly what cardiologists do. They ignore rhythm, LA clots, tricuspid valve, just see Wilkinson and blast. They are likely, these patients are likely to be having severe pulmonary hypertension, and therefore they have atrial fibrillation, clots, and tricuspid valve disease, which has not been mentioned in the profile that you have given me. Anil has told you that mitral valve is not just cusp, it is cusp, chordae, papillary muscles, and rheumatic pathology affects everything. Unfortunately, BMV just separates the leaflets. Chordae and papillary muscles are not touched, and they form a formidable part of pathology. This slide shows the progression of a normal valve to calcific valve, stenosis valve, the chordae, normal chordae, and then shortening of chordae, and then crowding and papillary muscles getting attached to the cusp. Tell me how balloon can do anything to this congested chordae and papillary muscles attached to the mitral cusp. It has to be opened up mechanically. At open mitral valvotomy, we use cardiopulmonary bypass, left atrium is open, mitral valve pathology is studied systematically, valve is open at cuspal, chordal, and papillary muscles. That is, if mild to moderate cuspal calcification, cusp can be shaved off, thrombus can be removed, left atrium can be plicated in presence of giant atrium, which we all know. Biatrial maze can be done, left atrial appendage can be excluded, and tricuspid valve is repaired if there is moderate to severe regurgitation. So you treat the patient completely, do not treat just the cusp, which BMV does. This is the technique of mitral valvotomy. These are operative pictures. Anterolateral fused commissures, posterolateral fused commissures are separated. The subvalvular structures are cut, and division of the papillary muscles with pot scissors is done so that mitral valve is competent and yet fully open. What does BMV do? It simply spreads the fused commissures. It does not adequately treat subvalvular crowding, which may form an important part of pathology, and it ignores clots, atrial fibrillation, and tricuspid regurgitation. What are the indications of open mitral valvotomy? Absolute indication: presence of thrombus, atrial fibrillation, subvalvular crowding, calcification, failed BMV, restenosis after BMV, restenosis after CMV, significant aortic stenosis, and mitral stenosis, which can be opened up very easily, moderate to severe tricuspid regurgitation, and large atrium, mild mitral regurgitation. These are the times where open mitral valvotomy will be ideal. Dr. Sampath Kumar's paper has already been referred by Anil. This is a landmark paper which established open mitral valvotomy as a technique which is not relegated to the past. What are the advantages? I mentioned again, but it is important to reiterate. Direct inspection of the valve pathology. There is no procedure, neither BMV nor closed mitral. You see the valve completely and do whatever is necessary. Kamal will just see an image, its image, and then intensification of imagination. But not real picture is seen by any cardiologist. There is careful debridement of calcium deposits, subvalvular structures are separated, and rest of the things I have already mentioned. If valve is bad, in contrast to what was found on echo, valve can be replaced. 30% of patients with isolated mitral stenosis have atrial fibrillation. Stroke and peripheral embolizations are ever-present threats. Atrial fibrillation reduces cardiac output. Tachycardiomyopathy is the end-stage disease, and there is chronic fatigue and cardiac failure. This is the place where the appendage gets clotted, and then the clot spreads into the left atrial body. Incidence of atrial thrombus. 25% of patients with mitral stenosis have atrial thrombus. And routine transesophageal echocardiography will detect many more. It is a major cause of morbidity and mitral stenosis. What can you do on BMV with these clots? I'm told that you give anticoagulation for 3 weeks and then you can do BMV. Now here is what Cardiology Journal of Heart Valve Disease says. Effective resolution and organization of left atrial thrombi needs optimal 6 months. In order to opt for BMV, patients are asked to wait and suffer symptoms and take long-term anticoagulation with its possible complications. Some patients may embolize in spite of anticoagulation during this waiting time. Some patients go into severe symptoms throughout state, needing ICU care while waiting for BMV. While here we have OMV, which is next day procedure, quick, definitive, and removes all clots completely. So don't ask your patients with atrial fibrillation to wait for a long time and then persist with BMV. Offer them quick and effective solution right away. This is how we convert atrial fibrillation into sinus rhythm. All the lesions, left atrial lesions are shown, and left atrial appendage is also excluded. You can see in the figure. And this is right atrial maze. Complete maze gives 70 to 80% of the patients from atrial fibrillation into sinus rhythm. Nothing can be done like this in BMV. Left atrial appendage is excluded. Sometimes in exclusion of left atrial appendage is a hot topic in cardiology. So many devices and procedures have been described, but they ignore the same fact while doing BMV. Why not exclude left atrial appendage? We can do it at the same time when we are doing open mitral valvotomy. There is a comparison between BMV and OMV. OMV gives better long-term hemodynamics and lower rate of restenosis. BMV is a Yes, I agree. BMV is a procedure of choice only in selected patients due to its less invasive nature. This again was quoted by Anil, immediate and long-term results of balloon and surgical closed mitral valvotomy randomized comparative trial. Remember this, 40% of all patients with RHD have MS and MR together. Most of them have symptomatic severe mitral stenosis, but significant mitral regurgitation. For most patients with pre-existing moderate mitral regurgitation, BMV is out of question. It's contraindication. So how many few patients left? 40% patients with mitral regurgitation are out. 25% of atrial fibrillation are out from BMV. 25% of patients with clots on transthoracic echo, they're out for BMV. So just imagine how much is left for BMV. Mitral commissurotomy, a technique outdated. Here is a paper which has studied for over 35 years. This meta-analysis says it's a systematic study of effectiveness of BMV versus closed and open surgical mitral valvotomy. It's a very, very painstaking study over 1974 to 2010. All clinical control trials were compared. Abstracts for major cardiology and cardiac surgery meetings were studied. References also were studied and even corresponded with authors of all relevant research. Very landmark article. And what does it say? Sorry. No difference in mortality. Yes, we admit in BMV there is mortality of 4.13%. In surgery that is 3.24. Fine, we accept. Survival after BMV was significantly lower compared with OMV on long-term risk. Surgery has the inherent superiority over BMV in providing the potential for additional surgical techniques which may improve late survival and restenosis rate. Inherent superiority over BMV. 30 to 50, this is very, very important, Kamal. Listen to us. 30 to 50% of BMV patients develop mitral regurgitation and 4% need immediate surgery. But let's not forget, mitral regurgitation begets mitral regurgitation. If you leave mild mitral regurgitation, oh, that's mild mitral regurgitation. After 3 or 4 or 5 years, it will be severe mitral regurgitation. did not show any significant differences in terms of operative and late mortality and complication. Incidence of late new onset MR and late re-intervention were significantly higher in patients with balloon. Surgery remains the treatment of choice for rheumatic mitral stenosis. Here is another paper. Study of 314 patients. 32 patients had, 32% of the patients had moderate to severe tricuspid regurgitation. And the third point is absolutely important, I have highlighted. Tricuspid regurgitation did not improve in 88% of patients studied. Don't say that this is functional tricuspid regurgitation. We have opened the valve with balloon, tricuspid regurgitation will resolve. No, in 88% it doesn't resolve. TR, functional or organic, must be treated to avoid long-term disease of severe TR and dysfunction of the right ventricle. So 32, another group, 32% are out from BMV. It just takes 10 to 15 minutes to repair tricuspid valve and give patient a symptom-free life for long years. Leaving moderate to severe TR untreated at the first instance when you do BMV is a crime. However tempting, an easy BMV appears based on, into inverted commas, Wilkinson score. Reduced functional capacity, heart failure, massive pedal edema, ascites, hepatic dysfunction, and metabolic consequences are too well known because of severe TR. Anil definitely pointed out to this. Long-term effects of progressive TR are grave. Leave the patient miserable and attempt to correct surgically will have mortality more than 50%. This is how the tricuspid valve is repaired in just 10-15 minutes. A ring is established and that's it. And a long, good life is given to the patient.
I'm requesting you to quickly summarize as the time is running over.
Incidence, prognosis, implications, mechanism, and management. This again is a very, very important article in Cardiology Journal. It says 1/3 of the patients with mitral stenosis have at least moderate tricuspid regurgitation, and all moderate tricuspid regurgitations need treatment. BMV turns a blind eye to significant TR. They just don't look at it. This is what it happens. You leave TR, moderate TR, and over a period of 3 or 4 years, it becomes severe and patient's survival decreases to 50%. And if it is severe, the survival decreases to 40%. So the myth of functional tricuspid regurgitation. Let us all together admit that there is nothing like functional tricuspid regurgitation if the tricuspid annulus is more than 35 or 40 millimeter. And every day, day in and day out with BMV, 50% of the patients will have this TR, which is tricuspid annulus, which will be 35-40 millimeter, and they all will come back after 5 years with gross TR and ascites. Results of repeat surgery are extremely bad, and prophylactic tricuspid regurgitation repair is also now indicated. If the patient has dilated tricuspid annulus, there is no significant TR, but dilated annulus needs repair, cannot be done in BMV. Giant left atrium is common in our country, though literature says it is just 0.3%. And in our country, it is much more than that. 8 centimeter or more anteroposterior diameter of left atrium measured in this axis. And consequences, what are the consequences of giant left atrium? Decreased cardiac output in spite of correcting mitral stenosis.
So we can have discussion, Tushar bhai, now.
Yes, just a second. Yeah, let me complete. In defense of closed mitral valvotomy, this is the procedure, and these are the articles proving, recent articles proving the effectiveness of closed mitral valvotomy. CMV represents a satisfactory technique in terms of lower cost, high efficiency, simplicity, and reproducibility. When compared with balloon, CMV offers a satisfactory technique. It can be done in pregnancy, and we have done even at bedside. This procedure can be done at bedside. OMV and CMV, OMV is far better, but like BMV, CMV also has limitations in long-term results. BMV and CMV, we conclude with the immediate and long-term results of BMV and CMV are same. but CMV results in better long-term survival and fewer valve-related complications as compared to balloon mitral valvotomy. And BMVR and OMV are more or less same, but late results are better with OMV. Do not, this is my message to all of cardiologists, do not just look at the balloonable mitral stenosis as dictated by Wilkinson score. Look at the patient's presentation. Do not do half-hearted treatment at the first instance. This is her only chance of a good life. Complete treatment at one go gives the best short and long-term results. Untreated pathology spoils patient's medical history. But BMV has an excellent role in selected patients. Rheumatic mitral valve disease is a progressive disease. These are the pictures of two grandmothers. The first on left side underwent open mitral valvotomy in 1984. She was the first open heart operation of Gujarat. And in 1904, she underwent mitral valve replacement. She is doing very well. There is another grandmother who underwent closed mitral valvotomy by us 37 years ago, 1985. And everything is good with them. There are no events needing hospitalization. Friends, let me assure you that if you offer these procedures in selected patients, BMV will be out of consideration in more than 30 to 40% of the patients. Thank you very much, Kamal, and all friends, Jignesh, Ladda, Kalpesh, and Prashant, for giving me an opportunity to talk something which I used to talk in 1985. Thank you so much.
We are dealing with a small vessel coronary artery disease, and here the question is whether to go for drug-eluting balloon or a small stent placement. And very important aspect is that whether drug-eluting balloons will stand the test of the time in the long run. Now we have probably longer data. I'll narrate in a few minutes. In 2001, we started with having one stent placement data, and then later on, we had the first data of 2006, where drug-coated balloons were introduced into the therapeutic armamentarium. We have problems with the stent placement, delayed healing, stent thrombosis. Sometimes benign new intimal hyperplasia will be progressing into new atheroma, or sometimes late loss, malposition, and so many things. So stents were posing problems in next few years, and we started scratching our heads to go for new innovations. So what are the challenges we encountered in different scenarios in coronary stent placement? And very important thing came to our mind was small vessel disease. Small vessel disease is defined as less than 2.8 millimeter, and very small vessel disease are between 2 to 2.25 millimeter. Nowadays, 2.25 millimeter stents are very easily available, and as of Southeast Asian countries are there, 40 to 50% of coronary lesions are in small vessel disease, and 30 to 50% of our coronary interventions are being done in small coronary arteries. Female, old age, diabetes, peripheral artery disease, all these things are predisposing factor for our pain in the neck, you know. And so recurrence is also very, very peculiarly high in small vessel disease. Whatever type of stent you use, older generation or a newer generation stents, and the use of drug-eluting stents in small vessel disease was associated with very high risk of MACE and stent thrombosis. This is very peculiar even in diabetes. I'll come to the data later on. So overall picture is that we end up with 3 to 5% of the in-stent restenosis, and that small vessel disease has remained a very peculiar problem in our day-to-day work. Similarly, bifurcation lesions. Whenever you encounter a bifurcation stenosis, side branch involved are very important, and side branch restenosis rate, recurrence rate are very high as compared to the main branch. We have identified that side branch stenosis are to the tunes of 37% in as compared to bare metal stent implantation. So we need to go for a very nice objective, and that data started powering in from 2005 to 2006, and initial evaluation of drug-eluting balloons were tried in stent restenosis, and later on de novo lesions were also being tried. Since 2010, we have got number of trials. In 2012, we got Bello. In 2018, we got Basket Small. In 2018, again, we got Restore SVD China. And almost all these data, apart from initial 2006 and 2010 data, all other data have shown more or less the same MACE rate over a period of 1 year or 3 year duration. So initially, look at the initial data where the trial was abandoned because of poor response to drug-eluting balloon. But then came the Bello trial in 2012, where 182 patients were being evaluated. Really small vessels were evaluated by paclitaxel eluting stents as well as drug-eluting balloon, and you can see the data. The data outcome clearly says that MACE is less with a drug-eluting balloon in small vessel. Target vessel revascularization was also less, and target vessel failure rate is also less. So more or less encouraging data started powering in 2012. This slide is very peculiar from Bello study, that there is a quiescent phase of coronary artery disease after the initial 200 or 250 days of intervention, and that continues for 3 years. So somewhere from 250 days to 1000 days, more or less the quiescent phase of coronary artery disease is there. In that era, you have a very clear-cut advantage of drug-coated balloon. So drug-coated balloon fares well over a period of 3 years' time. Different types of drug-coated balloons are available from different manufacturers. Sometimes they have different concentration of cytotoxic drugs. They have different salt as a medium. They have different particle size. So no single drug-coated balloon is similar to the other one. We got the first very nice data from Restore China. It was probably the best trial we can have. Somewhere around 230 patients were randomized, and 9-month angiographic follow-up was available. 1 year clinical follow-up was available, and this is the baseline characteristics, almost identical to the all groups. And look at the target lesion failure rate and p-value. P-value is non-significant. That means that target lesion failure was more or less equal with the drug-coated balloon as well as our latest generation stent placement. In nutshell, though numerically this looks larger, that the drug-coated balloon was faring bad, but look at the p-values, and the p-values are really non-significant. So the data is equivalent data favoring coated balloon, non-inferior to drug-eluting stents. Restore SVD data was available in October 2019, and it was very clear non-inferiority trial where the latest drug-eluting balloon was drug-eluting stent was used. Data was available angiographic at 9 months and clinical follow-up up to 2 years. Similarly, side branch involvement was also evaluated in different trials. Now we come to the another trial from Switzerland, University of Basel, And this basket small trial was all comer trial. Every patient coming will be randomized. Follow-up was up to 12 months. It is the largest randomized clinical trial with a drug-eluting balloon, 758 patients. And they were first treated with simple balloon, and after pre-dilatation, they were randomized either to get DES or DCB. And what are the results? Majority of patients were randomized after the pre-dilatation. So there was a bias, and one can claim that there was a bias to receive drug-coated balloon. But nevertheless, probability of or definite thrombosis was practically nil in drug-coated balloon. That means that drug-coated balloon has a less immediate risk. Rates of major bleeding are also numerically less. Why less? Because we give antiplatelet agents for 1 month and then we stop it. So what are the messages from basket small trial? There is no permanent implant inside. The results are more or less same as drug-eluting stents. There is an advanced solution for high bleeding risk, upper GI bleed, lower GI bleed, cancers, and there is a promising result where promising results with less number of stent being deployed. 3-year follow-up non-inferiority data is available. You can avoid unnecessary stent. DAPT is only for 1 month. And very important aspect is that late lumen enlargement. When you implant a stent, there is a late lumen loss. Here, because we have released the drug into the tunica intima and tunica media, the tunica media gets remodeling, and this remodeling is so favorable that you will end up in a larger lumen diameter over a longer period of time. This hypothesis has been confirmed in IVA studies also. So basket small 2 study from University of Basel, 3 years follow-up. Look at the data. Drug-coated balloon and drug-eluting stents, both of them are running parallel up to 36 months. That means that major adverse cardiac events are more or less same. So it's non-inferior. Putting a drug-coated balloon is non-inferior. So I would definitely go for non-inferior results of this coated balloon. And look at the different varieties. The latest good quality balloon is Zions, good quality stent is Zion stent. And with the Zion stent, a parallel line comes, and that is drug-coated balloon. That means we have a very similar data for even the latest generation balloons, stents also. And that has been maintained, that good results are maintained up to 3 years of time. I don't go into details of these things because I have to go through various recommendations and guidelines. Consensus guidelines are gradually coming up for small vessels and bifurcation also. A word about drug-coated balloon consensus group. And there are problems with the dosage schedule of different balloons, formulations with different salts, release kinetics are different. So balloons are not equal to each other. Pre-dilatation is always necessary, and then you can randomize to receiving these things. Diffuse long lesions where you cannot have stent more than 48 millimeter size, then you can definitely place a drug-coated balloon and give a good result. Different trials I have already narrated. Small vessel disease is very peculiar in diabetes. We know right from 1998 that whenever we have a small vessel, we have a higher restenosis rate. Late lumen loss of 45% will be very detrimental in a small vessel. Diabetic patients have smaller arteries, that we know. Diabetic patients have very major cardiovascular events, very frequently higher. So we are interested in looking at the results of diabetes and drug-coated balloon, and need for target vessel revascularization was significantly less. Look at this bar graph, very clearly says that this is non-diabetic patients, but this is diabetic patients. And diabetic patients needs over a period of 3 years are equal. And when you see the target vessel revascularization rate, it is really less. That means that we are really justified in using drug-coated balloon. Non-inferior study in diabetic patients, use of DCB in small coronary artery vessels is superior to DES. That is what has been a conclusion in Journal of American College of Cardiology Interventions 2021, the latest data. I have already narrated about class effect for all DCBs cannot be assumed. This is a graphic depiction of granules of salt and drug. So in nutshell, I have enough data to use drug-coated balloon.
Okay, thank you so much, sir. Thank you so much for this opportunity. So my topic is small vessel coronary artery disease. The case in question is this: long diurnal disease in a 46-year-old male, diabetic, hypertensive, and a case of non-ST elevation. So you have faced a real big challenge for me, my dear friends. This is the small vessel disease in form of a sumo wrestler. And this is myself, a drug-eluting stent. I'm really laughing whether I'll be able to defeat this giant or not. Let us see who survives the test of the time. No doubt, small vessel disease, we all know, less than 2.8 or less than 2.75 or less than 3, whatever definition you use, it's fine. And very small vessel disease is 2 to 2.25. Approximately 30 to 40%, 50% of the coronary interventions are in today's small vessel disease. Which substrates, as sir has very nicely highlighted, long lesions, diabetes, hypertension, old age, women, and peripheral arterial disease. These are the substrates, and our patient already has a diabetic and he is a hypertensive. Why it is a challenge? We all know, because of frequent diffuse nature, higher restenosis, as sir highlighted, more chances of dissection and perforation, and obviously thrombosis. You put a small stent, really serious complication. What are the modalities? We know it could be a best medical therapy, a plain Olin balloon angioplasty, BMS, DES, or a DCB or DES. The question that I have been given is to answer DES versus drug coating balloon. The management spectrum, as you just saw, I am not going to repeat that. Functional assessment is very important for small vessel disease because almost 30% of the small vessel stenosis are hemodynamically significant, which are actually angiographically significant, deemed to be angiographically significant. So strongly recommended is to do a functional assessment of these lesions. So the first thing that comes is POBA. POBA is a viable option, probably technically impossible in many of the cases, can increase a risk of a vessel rupture. Not going to discuss much. BMS versus POBA. BMS is definitely better. The meta-analysis in European Heart Journal shows in almost more than 4,000 patients, it decreases the incidence of repeat revascularization. Let us come to the DES, straightforward. Like to the Muteki bar. The first generation DES have significant lower TLR. So there is no doubt that in certain cases, most of the cases, as compared to BMS, sirolimus eluting stents in various trials are far better. Look at the TLR, which goes significantly lower, but definitely at a cost of increasing stent thrombosis. SR Smart, as again highlighted by Sir, Cyber versus Texas, first generation DES, you see, sirolimus is performing better as compared to the paclitaxel. Now look at this. Most of the trials of DCB have been carried out using only paclitaxel eluting stent. So that means the comparator arm showing the equal efficacy or the superiority has been only with paclitaxel, and very few cases, which I'll be highlighting, have shown efficacy comparable to the sirolimus eluting stent. So what is the verdict in first case? First generation DES are better than the BMS, and CES is better than paclitaxel eluting stents in small vessel disease. Whether the diabetes or not, it doesn't matter. What is the problem with first generation? Sustained drug release, higher inflammation, paradoxical vasoconstriction is very, very serious and definitely higher risk of stent thrombosis, as my senior colleague, Dr. Raval, very nicely highlighted. Now come to the second generation tests. Basket small study, as again it was studied well, highlighted well. First generation pairs versus second generation zotralimmus eluting stents. 191 patients, the TVR was significantly low. So second generation stents right from beginning have started showing a better result as compared to the first generation paclitaxel eluting stents. But this is only comparison between DES. Where does DCB come in? Let me come to that. Thin struts versus thick struts. Thin struts are definitely better. What predicts restenosis in a second generation DES? It's a longer lesion length. Our patient has a longer lesion length. That's against going a DES. Has a larger strut thickness. That depends on us which stents we are choosing, and minimal stent lumen diameter. So overall, but the second generation DES are associated with good outcomes and a lower risk of instant restenosis. The various drug-coated balloons are available. Not going into the details because this is out of the question, but we must be aware the commonly available drug-eluting balloons and why paclitaxel has been used because of its high lipophilicity. That is why this volume is used. Repeating the same slide, which is very pertinent and important for me, is the trials comparing DES versus DEP. Now let us go to each trial and see what are the results. The first one is the Picoletto trial. Picoletto trial was the first randomized control trial to compare DCB versus DES in less than 2.75. Stopped prematurely. Why? Because DES was superior. If I am to say DES was superior, that means I won the case. I was superior to my colleague. But there were limitations in that. What were the limitations? First generation balloons, tissue delivery were lows, and very poor lesion preparation, which is very important for a drug coating balloon. So giving a neutral input, these were the major limitations, and that is what led to the underperformance of the drug-coated balloons as compared to DES. Look at this, the maze. It's much lower in the DES as compared with DCB. Then came the Bello trial. Bello, again, it used a mean diameter of 2.15, very small vessel piece, a Falcon balloon versus a Texas DES. The results were almost comparative arm is only paclitaxel eluting stent. Even with paclitaxel eluting stents, the paclitaxel eluting balloon is showing comparable result. Comparable is not superior, but comparable result. That means a possibility that if it would have been compared with the silent eluting stents, the result would have been superior with the drug eluting stent. But this trial concluded that they have similar trends of outcome of MACE as compared to the other one. The basket small study. The basket small study was a small coronary arteries where both these stents were used. Even the paclitaxel as well as the sirolimus eluting stents, both were used, but a very small number. So the results of this particular study again showed similar death MI and TVR in drug-coated balloon group and the drug-eluting stent group, 7.6 versus 7.5. So again, the results were comparable and DCB was non-inferior. Then came the Restore. As sir again highlighted, Restore was paclitaxel coating balloon versus Resolute test. 2.25 to 2.75, and at 1 year they had comparable incidence of target lesion failure. So it was non-inferior. Look at this. Everolimus, Promus, all the Zotra, all the molecules were used and the results were comparable, but not a very high number. Look at this. 114 is not a big number to generate a great data. So what were the problems with all these analyses? Balloon pre-dilatation is essential for DCB, the major role. Only 25% in Picoletto and 96% in Bello underwent it. After successful balloon pre-dilatation, DCB indicated not inferior to new generation DES on cardiac death, MI and TVR. So that is the verdict. So if you prepare a good lesion bed, then probably the comparison or the performance of both is relatively okay. SCAR registry talked much in favor of the drug-eluting stent, talked about the real-world registry, almost 14,000 patients. They said that DES is significantly better as compared to drug-coating balloon as far as the MI, death, and all other outcomes restenosis are concerned. But there are major limitations of this registry. No report on coronary segment, no angiographic follow-up, no lesion data on pre-dilatation. The rate of TLR and TVR in setting of small vessel disease is not detectable. So this is a major limitation. So using this data to win this particular battle is probably inappropriate from my side. What are the drawbacks of drug coating balloon? They are good, but they come with a price with a limitation. Elastic recoil and dissections. That is major. So they may require bailout. 7 to 8% of all the studies are showing that they require a bailout stent. Due to effects of shortened balloon inflation time, it is questioned whether the sufficient drug is delivered or not. Though this is dealt by the second generation drug-coated balloons in a significant way. So, what is my verdict on this particular trials, randomized trials? DCB may perform at least as good as DES, but remember, the comparator arms unfortunately included majorly paclitaxel-eluting stents, and that is why the results of both the groups have shown a comparative outcome. Let me tell you 2 or 3 meta-analysis and the retrospective studies. The Sinaga et al. Study showed no difference in MACE and TLR as compared to DCB and the second generation DES. Again, one of the meta studies by Sim et al. Second generation 2 millimeter only drug-coated balloon versus DES. They had similar TLR and death, and this is the major meta-analysis published in 2018 that outcomes of 7 trials, more than almost 2,000 patients, use of DCB in small vessel disease is comparable outcome when compared with DES as compared to the balloon angioplasty. So this is very important. Look at this. The TLR, the MACE and the binary restenosis all are comparable both with DCB and DES in this meta-analysis. But meta-analysis, have their own limitations. Then the last meta-analysis that came in 2019 was by Lee et al., which again showed newer trials. All these trials were included 3 non-randomized and 3 randomized, that drug-coated balloon strategy is again non-inferior, delivering a good outcome in non-fatal MI and can be recommended as an optimal treatment strategy. Guidelines still are reluctant to include this, but they are there to stay. So what is my verdict? My verdict is a balanced verdict, very clearly. So my case, or if you say a patient has a vessel which is less than 2, I would definitely choose a POBA in that. Probably if I need, I will go for a drug-eluting balloon in this particular case. If the patient has a dissection, always a possibility. If there are flow limited issues which are related, this is always a feasibility in all the spectrum. Everywhere this can be used, but DEB has a role only in less than 2 and 2.25 liters. So when would I choose a DEB? When there is optimal flow after pre-dilatation, I'm good with DEB. No dissection, I'm good with DEB. No residual stenosis, I'm very happy with DEB. TIMI 3, I will go for a DEB. And diameter 2 to 2.5, I'm happy with DEB. But if it ends up in a dissection, if there is a residual stenosis, if a TIMI flow is compromised, and if the diameter is relatively higher, I would choose a DES. What is my verdict? My verdict is this. This is the giant we are dealing with. Remember, if you ask me to defeat this alone with a DES, it's not possible. If Dr. Raval also tries to defeat alone with a DCB, not possible. Together, we can win this battle. That's the message. We have to use both the tools judiciously, because I have firmly lived in my life that all modalities should be used with clinical experience. A fool with a tool is still a fool. So don't be clinically focused that I only have to use this. Have an open mind and you'll get the best one. Thank you, folks. Have a growth mindset and have a great conference. Thank you for this great opportunity. Okay, thank you so
Yeah, hi Mitlesh. So do you have any questions in the chat box?
Sir, I am totally convinced with both the talks, the red corner and the blue corner. And I would like to conclude that whenever there is a dissection or there is a TIMI flow is like, it is not TIMI 3, then we should, if there is a dissection, then we need to put a stent. And if there is no dissection, we are good to go with DEB. So I totally agree with the speakers, and they have made point DEB versus DES. I totally agree with both the speakers. Sir.
Yes, I think it's well summarized. It was best of the one talks that we had from the archives a couple of years back, and that's what we wanted to share with our audiences to prime them up for what's coming up tomorrow for the live sessions. So definitely, we have some live sessions happening in the evening as well. So these are best of the archive, some of the talks, and I think we can move to the next, right?
Yes, sir. Thank you so much, sir. Thank you so much.
Thank you. Looking forward to meet you tomorrow.
Yes.
Bye.
Yes, sir. We'll be there.
RX events, can we move to the next session? So this is a new session that Dr. Rajiv Agrawal is going to talk about. There is an important thing that has emerged of late about residual risk beyond lipids. We have patients who have very well controlled lipids, and still patients do come with a residual risk and occurrence of another event. Dr. Rajiv Agrawal is a good friend of mine. Is at the Department of Cardiology at Jaswant Rai Super Specialty Hospital at Meerut, and is awarded lifetime achievement by the IMA Meerut and Inspiring Doctors India Award, and a very, very good, very well read and prolific speaker. So we'll have Dr. Rajiv Agrawal talking about residual risk.
Good afternoon, ladies and gentlemen. This is Dr. Rajiv Agrawal. Today I'm talking about residual lipid risk beyond LDL. What are the recent evidences? The topic is very contentious because there are so many controversies regarding lipid management beyond LDL. So I'll try to highlight what is the current literature position and how we are placed. This is my very favorite slide. I keep saying that atherosclerosis never sleeps. It creeps while you sleep. And that is another perspective of atherosclerosis, is that it is relentlessly progressive disease over a period of time, and lipid lowering therapy, primarily LDL lowering therapy, we do extremely well for our patient, but still there is a residual risk. And that is why the need for this topic, that what we can do beyond LDL reduction at the moment. All of you must have seen this slide many times. That is how we look at secondary prevention. At extreme left, we have LDL-C reduction paradigm. On extreme right, we have different way of treating diabetes by SGLT2 inhibitors and GLP-1. I have no hesitation in saying that these two extremes are the most established pillars of secondary prevention. We have residual inflammatory risk, which is an accepted risk factor, but tools are very limited. Residual thrombotic risk, where tools are there in terms of prolonged dual antiplatelet therapy or low-dose rivaroxaban. As far as the lipid is concerned, we have two pillars, TG risk reduction and LPA reduction. So my topic confines me to these two pillars, how we are positioned on these two fronts. This is a very provocative, controversial, but very insightful slide, which I keep showing. Is triglyceride correction is a cosmetic correction. It's are positively associated with CV risk in people with diabetes. We understand that elevated remnant cholesterol, plasma TGs, and cardiovascular and non-cardiovascular mortality is important because chylomicron and triglyceride, they go hand in hand, and they are important risk factors for atherosclerosis. CV mortality and other mortality is related with chylomicron remnants, but not the cancer mortality. This is in a nutshell all TG lowering trials so far. Many of you must have seen the presentation of Field and Accord. Field was again a statistically non-significant trial, and the total mortality increased by 19%, but insignificantly. Accord lipid decreased mortality insignificantly by 9%. So none of the trial from the fenofibrate has shown mortality reduction except a subgroup analysis showing CV risk reduction in some specific subgroups. So historically, TG lowering is not giving any outcome benefit. Prominent was a study which was weighted a lot because it was specifically directed to triglyceride. The pemafibrate was used, 10,000 participants, 24 countries. Unfortunately, last year it died because it increased the LDL-C level, whereas ApoB100 was unchanged, and the study was withdrawn and presented as a neutral study. It was not harmful, but it was a neutral study. And it is a summary that ApoB was not reduced and TG was marginally increased, and that was the out. There was no outcome benefit. There was another drug which was from Pfizer, buprenorphine, specifically for TG lowering, and this drug also died and the trial was abandoned in January last year. So in high risk primary secondary prevention patient where you have achieved LDL goal, the recommendation of TG lowering is 2BC. That means it is a very, very weak indication. And this is a recent editorial, fibrates, one more lost paradise in lipid management. So ladies and gentlemen, TG reduction is not really paying in terms of outcome benefit. And I often say the pro-TG community keeps on manipulating data, torture the data, and try to justify its usage. In summary, I'll repeat, TG are very important atherogenic particles, but they are not, when treated, result in outcome benefit. So triglyceride at the moment is a risk marker, not a risk factor. Many of you must be aware about EPA reduce it trial. Many of you confuse it as a TG lowering trial. It's a vascular trial, not a TG lowering trial. It showed enormous advantage. Primary outcome benefit was there. Secondary outcome benefit was there. Mortality reduction was there. Here the EPA was used 2 grams twice a day. And there was relative risk reduction of 25%. Absolute risk reduction was 4.8%, NNT was 21, and TGs were marginally reduced by 20%, CRP was reduced by 40%. And as you know, the entry criteria of high TG and low TG did not make any difference in outcome benefit. So this trial was used, in this trial, TGs were used as a risk marker, and you walk into the trial, but outcomes were not related to TG level. The way we talk, if you have higher LDL, you have higher benefit. So that point was not taken out of this study. That TG was a risk marker, but it was not related to outcome benefit. There were many theories that how the benefits were achieved. The mineral oil, which was used as a placebo, has fallen into controversy. I'll dwell upon that. There are various mechanistic pathways where you understand it is primarily a vascular drug rather than a TG lowering drug. And this is a wonderful slide, if you can retain it, that antiarrhythmic property, TG lowering, heart rate lowering, BP lowering, anti-thrombosis. So there are various mechanistic pathways and their time frames, how they are being affected by EPA. This is Stephen Nissen last year, who talked that the Reduce It trial was positive because the placebo was not placebo. It was a negative placebo. It was not a neutral placebo. So this trial has not gone into 1A recommendation at the moment. It is just landing at 2A and fallen into controversy because of mineral oil negativity. And various inflammatory markers are there, which are increased like CRP, IL-6, ILB. They're increased by placebo. So naturally, the EPA got an advantage over placebo, and the negative placebo made this trial probably very, very strong. Amarin, which made this drug, are losing market, and they have lost already 90% of the EPA market in the United States. So this trial, although looked very positive, a couple of years back, is finding its place and people are finding it difficult to digest in view with this trial. I say Koch's postulate, you are all aware in terms of tuberculosis. I have tried to apply them. TGs are atherogenic. TGs can be effectively reduced. TG reduction do not translate into outcome benefit. That is the problem. LPA is another molecule which you must understand that it is atherogenic and thrombotic. LPA is a risk amplifier. Whatever risk you have, if you have high LPA, it amplifies the risk. It is associated with aortic valve calcification also. We have a drug called pelacarsen for LPA, and it drastically reduces LPA level. And this is the couple of drugs, pelacarsen, olpasiran, and SL360, which are coming up to reduce LPA. But mind it, there is no outcome trial which shows that LPA reduction reduces mortality. So LPA story is high LPA causes atherosclerosis. LPA can be effectively reduced by drugs. LPA reduction reduces atherosclerosis is unknown. So that is a question mark. What is the current perspective? Out of all the risk factors, LDL reduction is the most important risk reduction. And that is what we focus, that in patients who have high TG, high LPA, probably we have to be more aggressive on LDL lowering, and Koch's postulate can easily be translated on LDL lowering. So I'll say once you find high TG at the moment, high LPA, these patients need to be treated with different drugs like oral PCSK9, CTP inhibitor, which are coming up in a big way, and you can have another LDL reduction to the tune of about 45%. And then we have CRISPR technologies, which can result in reduction, deletion of gene, and these problem can be taken forever. This is once and done approach. So this is the future of lipidology. So I'll say LDL today is a clear-cut winner. HDL is loser. Triglycerides are losing. LPA is running in trials, and we do not know the outcome. That is how I look at it. So my presentation is more like CAST, courage, revive, strength, and prominent, which are negative trials. So my presentation is negative. I'm trying to show you that these ways are not working at the moment. Lipidology at the moment is LDL lowering. Let us be artery healers. Let us be taking atherosclerosis, not stenosis. And do not forget that walking is the man's best medicine. Thank you very much.
Dr. Kamal Sharma, interventional cardiologist and associate professor cardiology, senior interventional cardiologist at Ahmedabad. So what we are going to discuss today is an important aspect of delivering life-saving heart failure treatment. We all know that various concepts have emerged, including 4 pillars in managing heart failure, and that's what I'm going to touch upon with specific focus on how this can be applied to the common substrate of our population, especially in the Southeast Asia. Heart failure is a growing public problem with very high morbidity and mortality. It affects almost 64 million people worldwide. The heart failure hospitalization is #1 cause of hospitalization across the world in patients who are more than 65 years of age, which is the aging population epidemiologically across the world. It is also projected to rise by another 50% over the next 25 years, which means it's going to stay as the #1 killer across the world and #1 cause of morbidity and hospitalization. If you look at the mortality, 5-year mortality in a patients of heart failure, despite an ARNI, is now 50%. Mortality significantly increases after each heart failure hospitalization with cumulative effect. This is a chart showing an insidious nature and the insidious start that this problem has from the first symptoms. But as the functional class deteriorates, every hospitalization leads to not only worsening of heart failure, but also increasing heart failure hospitalization and mortality. And this is on top of treatment of heart failure being instigated with each hospitalization and its intensification. If you look at the stage of at-risk patients from progressing from stage B to stage C and D, a lot of refractory heart failure patients at the end of the repeated hospitalization would end up in stage 4 class heart failure. So despite poor prognosis, there is of course lack of urgency from early identification because of multiple reasons at the level of inertia in diagnosis by the treating physicians or the cost of therapy coming in way to the patients actually if they are paying out of pocket to initiate the therapies that have been instigated. Over 40% of heart failure symptoms do occur up to 5 years prior to the diagnosis, and that's one of the reasons why a lot of times the therapy is initiated at late because of late presentation by patients themselves. 75% of those diagnosed with heart failure end up with unplanned heart failure hospitalization, and that's how the first point of contact often is the cause of initiation of these therapies. Guideline directed therapies in heart failure is often suboptimal. That means a lot of these patients may not be initiated on one of the 4 pillars as we understand, and over 30% of mortality is known to occur once a patient is hospitalized for heart failure hospitalization. So what are the guideline recommendations in these patients? The ESC guideline by 2021 recommendations talk about initiating dapagliflozin as one of the cornerstone of therapies for heart failure with reduced ejection fraction. They also talk about ACE, ARB or ARNI and the beta blockers apart from MRA along with loop diuretics, which is only known to reduce symptom class but not improve outcomes in terms of mortality. However, the other class of therapies, including the dapagliflozin, is known to reduce mortality in patients with heart failure. Ejection fraction with less than 35%, with QRS duration which is less than 130, ICD is recommended in ischemic as class 1 and in non-ischemic as class 2 recommendation. EF less more than 35 or device therapy when it's not indicated. If the symptoms persist, these patients can be further added other class of therapies. With however patients with QRS duration more than 130, they end up with CRT, especially as a class 1 therapy if the QRS is more than 150 milliseconds. Coming to the AHA ACC Heart Failure Society of America Heart Failure Guidelines, which now recommend SGLT2 inhibitor as a class 1 therapy in patients with reduced ejection fraction heart failure. When a patient with established heart failure with reduced ejection fraction, it's important to initiate GDMT, and they talk about all the 4 in the same breath, with SGLT2 mentioning it the foremost, along with beta blocker, MRA and ARNI, with level of recommendation class 1 with level of evidence as class A in patients with HFrEF SGLT2 being recommended to reduce heart failure hospitalization and also to reduce cardiovascular mortality irrespective whether the patient has type 2 diabetes or not. Hence, when you look at the European Society guidelines for starting SGLT2 as a component of foundational therapy for all patients with heart failure with reduced ejection fraction, irrespective of patient phenotype, whether the patient is on SGLT2 with diabetes or no diabetes, or whether the patient has a CKD element or patient has been hospitalized or not hospitalized, across the spectrum, the SGLT2 along with beta blockers, ARNI, MRA and diuretics will form the cornerstone across the spectrum for the therapy to be initiated. We have some recommendations for the other, but for irrespective of patient has a bradycardia, tachycardia, hospitalized, non-hospitalized, diabetic, non-diabetic, CKD, non-CKD, across the spectrum, SGLT is one subgroup of drug or one pillar which is given blanketly without any contraindication. Now, this all emanates from the very important trial called DAPA-HF, which looked at DAPA with the trial which was dapagliflozin in prevention of adverse outcomes in heart failure trial. The DAPA-HF trial included 4,744 patients, which included non-diabetic subgroup, which was a bigger subgroup compared to diabetic subgroup. The median follow-up was just 18.2 months because it meant the strong endpoint much early as an anticipated, with 1:1 randomization to DAPA versus placebo on top of standard care of therapy. At baseline, these patients had an NT-proBNP in the range of 1400 plus with ejection fraction mean of 31%, and 55% were without diabetes, with 41% with an EGFR below 60. When you look at the outcomes, you can see as early as 28 days, with a net number to treat being just 21, the curve started diverging and became statistically significant. The composite of primary endpoint of CV death and worsening of heart failure was reduced by CV death or heart failure worsening by 26%, with absolute reduction of nearly 5%, with p-value of 0.0001. CV death was reduced by 18%, again reaching statistical significance, and so was worsening of heart failure with absolute reduction of 3.7%. All of them were independently statistically significant. All-cause mortality was the one important predictor and very important determinant, which was also statistically significant, establishing this therapy as an unchallengeable therapy and a corner and pillar stone for managing heart failure. If you look at the adverse events, all of them were significantly more in placebo arm, primarily driven by volume depletion, driven by mortality, when the adverse event requiring discontinuation was not different between the placebo and the dapagliflozin arm. Now, we know from the empagliflozin trials that it also in Emperor Reduce showed some benefits, but how the two trials are different is what I'm going to summarize in this slide. When you look at the heart failure hospitalization, yes, it's a class effect. You can have reduction in heart failure hospitalization across. But what about death? The CV death, I say, in heart failure, DAPA-HF has turned the tables on empagliflozin. Because the inclusion criteria were very different when you compare EMPA-REG versus declared TIMI. In DAPA-HF versus Emperor Reduce, the difference, despite more stringent criteria of recruitment in Emperor Reduce, the DAPA-HF with a non-inclusion criteria and a broad real-world practice-like scenario was still able to show CV death reduction by 18%, which was statistically significant, which was not the case with empagliflozin. All-cause death reduction was also by 17%, again was not significant in empagliflozin. New onset of diabetes in pre-diabetic population was reduced by 32%, which also was not there, but was only 14%, but not significant in empagliflozin arm. The change in the quality of life score or KCC calculated, DAPA it was 6 with plus 16 versus placebo plus 3.3 plus minus 19.2, with the difference being of 2.8, while in EMPA it was 1.7, and hence calculated at 8 months for the dapagliflozin versus 52 weeks, which is 1 year of EMPA. Still DAPA had a slightly better quality life parameter as compared to EMPA. However, this is like comparing two different trials in a different subset, though we cannot compare them head on, but this is the primary difference. And when a molecule can show a mortality benefit, then there are nothing more stronger in favor of that therapy as compared to the other therapy. What about the cardiorenal complications? When you look, there is a close association between cardiac and renal pathophysiology. Chronic heart failure leads to genetically predisposed patients worsening of the renal function, and this is often driven in huge extent in patients with low cardiac output, with inflammation, arterial calcification and endothelial calcification leading to initiation and worsening of heart, kidney damage. This with the chronic hypoperfusion can lead to CKD and worsening and occurrence of kidney disease, which can further propensate and worsen heart failure because of anemia, metabolic abnormalities and volume overload. Cardiorenal connectors like RAS activation, oxidative stress, inflammation and sympathetic nervous system activation are some of the modulators that affect both individually and independently. The DAPA CKD was one of the largest trials in CKD population, and this is the first and the only SGLT2 for patients with CKD with or without diabetes, which showed that the cardiorenal outcomes were improved, and so was the mortality reduction in the landmark trial. The DAPA CKD at 4,000 plus patients was against the placebo arm, and it showed 39% relative risk reduction in a composite of more than 50% EGFR decline, end-stage kidney disease or renal or CV outcomes, with net number to treat very small of just 19. Remember, in these patients also, 68% were diabetic, while 32% were non-diabetic. All-cause mortality was reduced by 31%, and the kidney outcomes were reduced by 44%, while heart outcomes were reduced by 29%. Hence, this therapy has shown that this is the first and the outcome study to show all-cause mortality being reduced in patients with or without diabetes in a patient who had CKD. Also with DECLARE, when you combine, you can look at the additional benefits that you can derive across the spectrum of diabetic kidney disease patients in terms of event reduction. DAPA-CKD, when you compare with the EMPA-Kidney trials, you had 39% relative risk reduction with a net number to treat just being 19, while EMPA-Kidney had 28% relative risk reduction. When you look at the secondary outcome in DAPA-CKD, all-cause death was 31% relative risk reduction, which was not statistically significant in EMPA-Kidney trial. Composite of CV death and heart failure hospitalization was also significant again in DAPA-CKD, recapitulating and replicating its outcome like DAPA-HF in DAPA-CKD. So do adding therapies of heart failure, reduced ejection fraction treatment and its sequential initiation, do they have an evidence or are they significantly outcome based driven or not? So when you combine the foundational therapy, you can actually extend the life of patients by almost 6 years. When ARNIs had come, people talked about 1 or 2 years. Now, but when combining the ARNI beta blocker MRA and SGLT2, you are adding 6 years to these life, as was documented in this paper by Milton Packer's group. When you look at this therapy, the therapy is from the event-free survival from in patients whose age, when you take off, when these patients are more than already 65 years of age, the survival is more than 6 years. So even younger patients, it may be even more. The limitation, however, is that when you initiate them step by step, you can actually lose out on patients and you don't get benefit of these therapies being initiated with so many titrations and so many follow-ups. Hence, in our part of the world, a lot of these patients do end up getting initiated on multiple pillars at a time. The conventional sequencing of initiating reduced ejection fraction by the order of ACE followed by beta blocker, followed by MRA and ARNI and then SGLT2, hence does not hold true because the therapy that is known to reduce mortality must be initiated very early. So the conventional approach has a problem in delay in starting the demonstrated reduction of mortality within 30 days. Therapies like an SGLT2 being delayed to the fifth pillar is no more acceptable. This assumes that the most effective and well-tolerated treatments were developed first and assumes that the foundational therapies are effective and titrated to the targeted dose. Hence, the new proposal by Milton Packer and McMurray's group is also talking about the new expert proposal of sequencing the heart failure with reduced ejection fraction to be completed in 4 weeks. They talk about adding beta blocker and SGLT2 as the first simultaneous initiation, with ARNI initiated within 1 to 2 weeks and an MRA in another 1 to 2 weeks. However, a lot of times patients are initiated in our part of the practice, all of these therapies at one go, if you can get a compliant patient with no exclusion criteria. And most of these patients do tolerate well. And of course, dapagliflozin does not require any tailoring of the dosage. You start 10 milligrams across the spectrum. You can titrate the rest of the therapies as you may see the patient when you initiate them or on follow-up. So can generics be considered equivalent to the innovator? Now that's the other problem. In our part of the world, it's just the pharmacokinetics which are equated, not the pharmacodynamics to be per se. The original trial is the only molecule, which is the original brand, which is initiated to show mortality reduction or morbidity reduction. The other therapies that are initiated will only look at the serum levels of the molecule being achieved, and that also with a caveat of non-inferiority or bioequivalence, which may vary from the pharmacological serum levels in a range rather than being 100% equivalent to the original brand. The drug development process, as we know, runs from the discovery and preclinical studies to clinical studies from phase 1 and 2, with out of almost 5,000 to 10,000 new chemical entities boiling down to one phase 4 or 1 to 2 drugs after the regulatory review of 1 or to 2 years and post-marketing surveillance for the lifetime. And hence, the India submission of FDA or indigenous submission to European to come into practice as long as around 6 to 10 years before they hit the market. And that's the problem, that the drug development is a long process of 10 to 15 years, amounting to between 800 to almost $2 billion to get a new drug to the market. And hence pharmaceutical equivalence does not mean bioequivalence. And bioequivalence, whether it equates to therapeutic equivalence, is anybody's guess. A mere bioequivalence of a generic may not necessarily lead to same therapeutic effect in pharmacodynamics as the innovator, because what you have tested is only whether the serum levels of the two drugs are equal or not. Without an outcome-based trial, it's just an assumption that if the serum levels are same, the drug may be same. But this is a lot of problem with it. Bioequivalence, as I said, would range for a serum level between 80 to 125%. So a molecule which is 8.1 milligram of dapagliflozin versus some other molecule which is 12.5 milligrams of dapagliflozin would be considered to be bioequivalent for somebody who's taking 10 milligrams if the serum level is in that range. And hence, generic bioavailability may range from minus 20% to plus 25%, which is difficult to measure in a progressive chronic disease like heart failure. So why to take a chance in patients suffering from complex cardio-renal metabolic disorder and you don't know whether you are going to achieve the same bioequivalence or the therapeutic goals that what you target to do. You're not chasing patient to achieve same serum levels, you're chasing the patient to prevent its death or even worse outcomes. So original DAPA does have an elaborate drug development process. BABE studies on sick patients, number of subjects tested are thousands to lakhs. Expedient is globally approved one which can vary from the generics. Source of raw material is single manufacturing unit with efficacy in randomized controlled trials with safety being followed all across despite within vigorous post-marketing surveillance. Compared to innovator statins, the probability of suffering a serious adverse event or CVE for generic was higher by average 31%. This is just one example why bioequivalence may not translate into safety. Looking at the dapagliflozin to transform patient outcome by providing life benefit, hence DAPA is recommended not only as the therapy for reduced ejection fraction, but it's one of the first pillars of GDMT must include based on the DAPA-HF, which significantly showed benefits in primary composite outcome across the subgroup with 18% relative risk reduction in CV death with 17% relative risk reduction in all-cause mortality. DAPA-CKD demonstrated 31% relative risk reduction in all-cause death, and that's the strongest parameter to choose a therapy. If anything can prevent a death, that therapy is heart failure, irrespective of diabetes or not, across the patients of CKD, because the burden is strong. The debate is now switching from what there was once a editorial, shall we add statins to pipeline? Maybe I would say, shall we add SGLT2 to our water pipelines? Because SGLT2s are emerging as therapy across the class in patients with diabetes or without, in patients with CKD or heart failure. And that's what will translate only in a brand or a molecule of the original innovator that has shown mortality outcome reduction. Thank you very much.
Hi, Dr. Rajiv Agrawal. I can see you. Wonderful talk. I think by the time you joined, we started with the other talk. You're muted, Dr. Agrawal. You can unmute. You're muted. You're muted. Please unmute Dr. Rajiv Agrawal, RX Events. I don't think he is able to unmute.
Yeah, but you are ahead of time. You are ahead of time because the session was to start at 2:40. I joined
2:15. You started exactly on time. The session was at 2:15 and you were on time.
So my presentation had been done. I am involved in any kind.
No, it was so. There was a chat box question, so I thought maybe I'll ask you. They were saying, so do you suggest that based on accord, if TG is more than 228, you would still not be chasing TG in a patient with controlled LDL? That was the question.
Yeah, that's a very interesting question. And I think it's a very big emotional question for everyone. And I remember we were together on Sadanand Shetty's group and we had a mutual discussion of this very interesting issue. But let me define TGs today are atherogenic particle. Chylomicron remnants are atherogenic particle. They are important risk marker, no doubt about it. But they are not risk factors because controlling them does not translate any kind of morbidity, mortality advantage. And the current understanding about patients who have high TG is lifestyle modification, looking after thyroid, alcohol abstinence, exercise. If you are more than 500, then on a gastroenterology side, fenofibrate is there for NAFLD and pancreatitis. But on cardiology side, if you are 220 kind of thing, I'll say touch the bottom, because right now we are LDL oriented in terms of lipid lowering. So patients who have residual risk, the only way is go still lower. That is how I look at it. I won't chase TG. I have dwelled upon the problems related to reduce it. Reduce it is not a TG lowering trial. It's a vascular trial. TG was an entry criteria. It was not an exit criteria related to outcome. So it's a vascular trial. And I showed you a slide. Amarin has lost 90% share of its sale after this all controversy. So I'm very provocative, active, extremist, terrorist on LDL front. I'll say right now, TG is a marker. I'm concerned about it, but right now we don't have tools to clinically manage it. That is how I look at it.
True, I agree. LDL has to be the first target, but yes, beyond 250s and maybe 400s, as Dr. Agrawal said, if you have patients, there is a risk of pancreatitis and fatty liver and hepatitis. That's more likely as compared to an acute coronary event being precipitated. But yes, TG does reflect the kind of LDL that you're dealing with. It reflects a large
dense LDL. So clearance is poorer in those situations. So that is another problem, that small dense LDL particles, they will not be caught by LDL receptor the way they catch the routine LDL.
Yes, that three-dimension that you brought out is so important. Lock and key hypothesis, yes. As we say. Every key, if it's too big for the lock, it's not, though it's big, it will not fit into that lock. And the same is the concept that I covered upon the generics and the stereochemics about the DAPA, etc. But again, there is a question in chat box asking me to comment on difference between DAPA and EMPA in heart failure versus ASCVD. I think that talk is there already scheduled. But I usually say a lot of times the outcomes, as Dr. Agrawal was also saying, if you beat the data enough, it will speak out something. So I think same has happened also is to how what you want to shoot will show the beauty. That's the other aspect. If I look prettier from the front rather than long nose from the side, I will picture it from the front. So that also is the other beauty of designing clinical trial. So how the trials were designed, actually, I would say Astra people were smart enough to learn their lessons from the EMPA-REG versus DELIVER versus the trial design from the EMPA-REG, and then they didn't do the mistake with Declare TIMI what they did, and they actually included all group comers in DAPA-HF and came out with better outcomes. But yes, heart failures, mortality reduction with DAPA, ASCVD, mortality reduction, beyond heart failure reduction in EMPA-REG. Overall, you can choose between the two, but make sure that you do put the SGLT2, and a cardiologist should learn SGLT2 as much as he should know cardiology. Dr. Rajiv Agrawal, any comments on your final take-homes that you want to say about your lipid talk that you had?
I'll say be obsessed about lipid. Hello, Praveen. Be obsessed about LDL. The bottom, sooner you touch bottom, better you are. Deeper you touch bottom, better you are. Only thing I want to add is, suppose you are giving X dose to a patient and his LDL touches to 15, 20. I'll say he's a hyper responder, and there is no concept of down regulating the lipid lowering therapy. That should be the biggest carry home. That patient is lucky that your statin agitamide combination is working like PCSK9 or inclisiran. So there is no reason that you should down regulate your therapy. There is no concept like this. So The another thing which I want to emphasize in one line, the side effects are related to statin dosage, not to LDL. So 20 LDL is fine. There is no problem with 20 LDL. The new onset hyperglycemia, the cognitive disorder, the muscle disorders, whatever you know, they are more statin dosage related than the LDL level. So you have to disconnect that the side effects are not LDL related, and 20 LDL is not a bad thing. It's a good thing. He's a lucky guy. Longer he lives, better he will be. So these two final comments I want.
Yeah, I completely agree to your comments, and I think lower is better, but how you achieve it probably also matters with the recent controversy arising around PCSK9. So that's matter of time. Again, as you said, again in your talk, how the 90% stocks went down for one of the companies when they were chasing TG. So let's look at that. Thank you very much, Dr.
Pleasure,
We'll move to the next session, and we have Dr. Dharmesh Solanki talking about. Can we have the next session, please?
क्वाड वाला चाहिए जो नॉर्मल होता है. नॉर्मल कोई भी नहीं
वो इनके पास नीचे होगा. मीरा,
हेलो, hello.
You are audible. You are audible.
Okay, so should I start my presentation? So I have to start the screen sharing, but I cannot start because the other participant is sharing.
I think we can have Dr. Praveen Chandra's talk then first. Yeah, Dr. Chandra, you can go live. RX Events, please allow Dr. Praveen Chandra to be the host.
I can't. So they have to stop. Now it is better. Now it is better. Is it okay? Can you see my screen? Yeah. Is it okay? Can you see my screen? Hello?
Praveen, you are both audible and visible. Perfect.
Okay, so I'm starting my presentation. So basically today I'm going to share with you a new concept of doing angioplasties with either no contrast or low contrast or very low contrast. And that actually uses different technologies like OCT, IVUS and IFR for these procedures. So the objective will be to discuss these possibilities. How do we approach these patients? Who are these patients who need this? And basically, how do we use these technologies like IVUS physiology, which is FFR, and also OCT imaging? So normally, up till now, we have been doing angioplasties based on angiographic pictures like this. And this is an angiographic image. Certainly, we'll need one angiographic image as an angiographic evaluation. But after that, once the visualization is complete in these patients, fundamentally, we do not link our angioplasty to angiography. And then we all do it through the guidance of these imaging tools without contrast administration. And basically, this basically helps us in treating very complex patients, high-risk patients, and the liberal use of contrast medium, which we used to do in angioplasty, is completely minimized. And in these situations, we do not do any intracoronary injections to find out at every step. So these long procedures also who are needing too much contrast, so we can basically do them without these angiographic imaging. And so this is also known as ULC PCI, and certainly people may think that the precision of PCI will be low, but basically in this the precision is complete, and we are able to see complications. We are able to see the outcomes once we have done the imaging through IVUS catheter and additional guide wires, and using the the markers, radiopaque markers of these equipments at every stage. So those people who do not perform IVUS or who do not perform OCT or physiology, then it becomes difficult. So one has to, every interventional cardiologist who wants to perform ULC PCI has to become conversant and has to start using these imaging technologies for doing this kind of a state-of-the-art PCI. And basically, the focus is then placed on how to use them optimally. So who are those patients? Basically, those patients who have chronic kidney disease, acute kidney injury during acute MI, cardiogenic shock. Then sometimes patients have bad coronary dissections and don't want to inject too much contrast. Then spontaneous coronary dissections, CTOs, where we are doing ADR or CAR technique, and of course complex long PCI procedures. Also, it is very helpful to use low contrast PCI, because one of the complications of angioplasty is acute kidney injury, and this is what we are trying to avoid. And in chronic kidney diseases, like you see here in this patient, there is always these patients are complex patients, just to show that they have more calcification, they have more complex disease, and to give less contrast. And that's why many times we were trying to avoid doing interventions in these patients. And they are, and of course, these patients were then either left alone or would go to surgery with certainly higher risks of having renal failure. So there we can use this method. And just to show you that contrast-induced nephropathy is a reality, and we see that with increasing use of contrast. As you start increasing the use of contrast volume, the AKI rate or the acute kidney injury rate goes up. And this leads to poor outcomes in patients where you do interventions. And of course, there is no alternative as yet to the contrast, and there is no other drug which we can use in place of contrast to visualize the arteries. So that is why we have to risk either dilute this same contrast sometimes to see that, or one of the formulas which I also use almost on a daily basis is that if the patient has how much GFR. So if the GFR of the patient is 30, then my maximum limit is 30, no more than that, because that is one of the kind of advices which we take and give to those patients where the kidney insufficiency is there, and we reduce the contrast intake in these patients. And the GFR calculation is very, very important. That's why. And in patients with cardiogenic shock, again, these patients, when they undergo intervention, again, they also develop this complication of kidney injury because of the hypoperfusion during the instability of hemodynamic. And then in those patients also, reducing the contrast material is very, very much recommended. And that is why we use more imaging in those patients than less imaging. And earlier, our habit used to be that do not use imaging, just try to do the procedure with contrast, and that led to more damage to the whole hemodynamics, to the kidneys, and so on and so forth. Then in patients, as I was telling you about coronary dissections, in those patients where there is a false lumen, if you keep injecting too much contrast, you extend the dissections, and that leads to worsening of the scenario and accelerates the vessel occlusion. So that is why in these patients, using low contrast is always a good idea. In CTO patients, in patients with ADR, again, we rely on IVUS imaging in these kind of patients. And then, of course, in complex long interventions where you are spending too much time, do not spend too much time. So that does not mean that if you are doing a long procedure, you spend 500 ml of contrast. So your procedure is successful, but the patient will not have good outcomes. So this kind of a situation, and how do we do that? Also in imaging and in physiology, we have, this is co-registration of IFFR, and you can see here, as you can see that this is IFR co-registration, which we do routinely to find out which lesion to treat, which lesion to leave, for how long the stent has to be. Everything can be decided by this IFR co-registration. There is no need to keep injecting dye in these kind of patients. And that is why these challenges of the routine PCI are kind of obviated by adoption of ULC PCI. So, as you already understand that the challenges of ULC PCI for the operator is that he has to engage the guiding catheter, know when the guiding catheter is engaged, because our habit is to engage the guiding catheter and give contrast. We don't do that anymore. We now understand how do we do it, then navigate the guide wires through vessels without putting contrast in that. identification and location of target lesion by the help of IVUS and FFR, ensuring performance balloon dilatation stent deployment at target location, again by the help of imaging and FFR. For all these steps, there is no contrast used. And assessing also, final also stenting, assessment of stenting and looking for complications and managing them is all assisted by the help of imaging and physiology. So the final results, so sometimes as I'm telling you that in only when we have used only 3 to 5 ml of contrast in a full angioplasty, where 2 or 3 stents were used, was to just document the final outcome. That's all. Otherwise, sometimes we don't even do that. So basically, what you require is a little bit of skills, which you already have, but you have to just make the mindset change, use of IVUS, use of IFR, and also use of OCT sometimes with the use of saline. So in OCT, we don't use contrast, we use saline with a 50 ml syringe, and it really works very well. So at all stages, as you can see, we can just do that without using any contrast. And then these are the, the various things you can learn about. If you guide catheter is engaged in RC, and if you inject saline, there is a T-wave inversion. You know where the guiding catheter is. It is already engaged. Looking at the pressure waveforms, you will know what exactly is happening. So basically, we do that, very, carefully. And sometimes if you have to inject contrast for a distal wire location, we use 50% diluted contrast. And with a higher frame rate, you can see the vessel better with less contrast. Then navigation of guide wires, again, we do with the help of stored angiography. So if there is an angiogram which was done earlier, you use the same images. So we keep looking at the same images, and on the real-time fluoroscopy, we can match it as to where the wire is going. And then identifying the target flow limiting stenosis by doing a pullback IFR is also very helpful. As you can see in this patient, we can find out where the jump is happening. And then using the additional guide wires and also the additional markers like calcification, etc., can be used to correlate with the site of stenting or the positioning of the stents. So we use this eagle eye IVUS in ULC PCI very, very commonly. Record positions of the various balloon, or also record the position of IVUS catheter, because it has markers. As you can see here, there is a marker 1, 2, 3, and 4. So these are 10 millimeter distance markers which can tell us how long the stent has to be, or how long the the dilatation has to happen, and then comparing it with the IVUS images makes the decision very, very simple. So it's just kind of training yourself to do that. And here you can see the very complex case like this angulated lesion. We are comparing with the previous images and trying to do with the help of IVUS. So that is quite possible. Using stent boost also is a helpful thing. During the stenting, we can check whether the stent is expanded or not, whether the second stent is overlapping properly or not. All this can be done without any contrast injection. And then complication management is also very easy. We can check, and at the end, if you really want, you can do a diluted contrast injection to check whether there is any slow flow, etc., or not. So these are some 2 cases which I'm going to share with you. And this is a patient where there was an initial angiogram which was done, showed RCA, which is non-critical, and LED showed tight stenosis here. And at the distal end, there was a thrombus, which we detected by the help of doing and this patient had a creatinine of 1.4 or something. And we didn't want to increase any contrast injections. So we did that with the help of, first the balloon dilate here, then doing a laser, followed by OCT using a saline contrast, and then followed by cutting balloon at the proximal end. And all this was done through imaging, and then followed by drug-eluting. So no stent, drug-eluting balloons, laser, and cutting balloon, and this angioplasty is done. And in the end, I think we took 1 shot, and that's all. So this is the only shot we take, just 3 ml contrast, and rest everything is done through imaging. So this is, kind of treatment which we can offer to our patients and do not want to give any injury to the kidneys. So this is, pre-laser, post-laser, and then the final IVUS. So many times we don't even take the final contrast injection, especially if we are doing a no contrast PDCA. And this is a patient where no contrast was given. Right artery was very bad disease. Patient was rejected from surgery, had also severe MR, for which we did a mitra clip, which is also a non-contrast procedure. And here you can see we are using these landmarks like calcification, the side wire, to know where we have to dilate this vessel. And no injection is being given, just the dilatations based on the IVUS. And this is, you can see the IVUS catheter telling us how long the treatment has to be, then checking the final results on the IVUS, and then doing this kissing inflation. This is a double balloon bifurcation technique which is being done in this patient. And you will realize that all this is done through the, and this is the final injection. Only one injection, 3 ml injection, and everything is done. So what ULC PCI means is that it is a low, ultra low contrast, or a low contrast, or no contrast. And you need IVUS, FFR, OCT. And for those patients who have kidney injury, acute or chronic cardiogenic shock, ADR, all these patients can now be effectively treated by using minimal contrast. So thank you very much for your kind attention. Maybe if you have any questions.
Thank you, Dr. Chandra. Wonderful case presentation. We know it's the best to learn it from the masters. I think you've demonstrated how perfectly a zero contrast PCI can be done. There's a question. Is zero contrast by definition actually zero? Or as you mentioned that there can be a couple of shots which would actually qualify anything like up to 20 ml of contrast as an equivalent of what you call as a zero contrast?
Yeah, very good question, Dr. Kamal. As I was telling you, we divide our procedures in 3 categories. And no contrast means no contrast, zero. And in those patients where we want to give only one injection, that is ultra low contrast, which is less than 5 ml contrast, only one shot. That is diluted 5 ml injection in the end. And then low contrast means we give one injection in the beginning, one in the middle, and one in the end. And generally these patients are who have a GFR of less than 30. So, or less than 20. So we just want to give 15 to 20 ml or 30 ml contrast. So that is how we have performed this. And we have seen good outcomes, no complications. So it works. But we have to plan. We cannot do these procedures as ad hoc procedures.
Correct.
Sometimes I have done angioplasties on these patients who have come with the angiography from outside. So we load the images and we keep looking at the images and do the procedure without contrast this time. So the images from angiography are used.
Is the wiring done imaging guiding? The branch wiring, I mean. When you have to put wires to define the lesion, the side branch wiring, you would keep doing that with, just without contrast and just as a go wherever it goes, or is it imaging guiding?
No. So it is all done without contrast. We use the same images as I was telling you. We use the angiographic image, which was taken earlier. And based on that, we do it. And then we do the imaging to find out, to see how the bifurcation is and everything else. So which I can, sometimes just tell you in detail, but we can assess everything with just imaging. That's quite good.
Thank you, Dr. Chandra, for a wonderful talk. It was very enlightening for our audiences. These were a couple of questions in the chat box, which I asked you. Thank you very much. Always a pleasure to have you on CardioCon. This is your second consecutive year. Looking forward to have you in-person meeting next year, hopefully.
Yeah, sure.
Thank you. Bye-bye.
Okay, thank you very much.
So now we move to the next session, and that is on impact of oral semaglutide on CV risk factors in type 2 diabetes by Dr. Dharmesh Solanki.
Hello everyone, I am Dr. Dharmesh Solanki, cardiologist from Wockhardt Hospital, Rajkot, and today I am going to talk in next 10 minutes about the oral semaglutides, CV risk factors and cardiovascular prospectus. So these are my financial disclosure. So why cardiologist is in between these diabetic drugs? And this is the answer. If you look at the lifespan, after the age of 60 in a non-diabetic patients, which we call nearly in India is around 75 years. But when the patient becomes diabetic, the lifespan reduces by 6 years. And when there is an associated cardiovascular risk factor or a cardiovascular disease, the mortality increases or lifespan reduces by 12 years. And that is why we cardiologists are here in between the diabetes and the patients. If I wanted to explain you the basics of the macrovascular, we call macrovascular and microvascular complication of diabetes, and cardiovascular complications are a macrovascular complication. It starts with the central obesity, then it results in insulin resistance. This results in pro-inflammations. There is an increase in the lipids, there is an increase in the blood pressure, and there is an increase in the glucose. Then there are non-modifiable risk factors associated like genetic predisposition, age. As the age advances, the prevalence of diabetes is increases, and external risk factors like smoking. And these all complex of puzzles results in type 2 diabetes or a macrovascular complication of diabetes. And just merely controlling the sugar will not help in preventing or treating these macrovascular complications of diabetes. So one need to remember that we need to address all these starting from obesity, insulin resistance, inflammation, hypertension, and dyslipidemia as well. So today's topic is on the GLP. You all know the mechanism of actions, and I am not going into the details of that. GLP-1 analog has a proven cardiovascular benefits. It is highly effectively reducing HbA1c, and not only HbA1c, it reduces the weight, inflammatory markers, it reduces the LDL sugar, it reduces the blood pressure, and hence it results in cardiovascular benefits. Let us see into the clinical prospectus trial, what the trial is to say. The Pioneer program is with the oral semaglutides, and there are Pioneer 1 to 10 trials, and these trials has been conducted against its active competitor. Active competitor means it has been compared against the SGLT2, DPP, subcutaneous GLP, metformin, sulfonylurea, pioglitazone, insulin, and so forth. So it gives you an extensive idea that how these drugs has been placed against this active competitor in terms of reduction in weight, reduction in HbA1c, and cardiovascular benefit. Particularly Pioneer 6 study, which is a CV safety data, is also proved % relative more reduction in weight at the end of 1 year as compared to the empagliflozin. Not only weight reduction, it reduces the weight circumference also, which is again a very important cardiovascular risk factor marker. So waist to hip ratio or waist circumference reduces more by 45% as compared to empagliflozin, or absolute reduction in nearly 4.7 centimeter as compared to the empagliflozin, which is very significant in a patients with type 2 diabetes mellitus. Not only it reduces the weight, it results in reduction in the blood pressure. It reduces the systolic blood pressure by 5 millimeter of mercury. And if you look at the various data, that reduction in 10 millimeter of mercury in a type 2 diabetic patients reduces the cardiovascular and other complications of diabetes, particularly any complication related to diabetes reduces by 11%, myocardial infarction by 11%, death resulting in 16% or 10% in the microvascular complication. So it reduces the blood pressure. Again, going to the other aspect of the pleiotropic effects, it reduces the hsCRP, which is a systemic inflammatory markers. So if you look in comparison with the placebo, it reduces statistically significant at the half-year interval, and at the 1 year interval, the empagliflozin versus oral semaglutides, there is a 37% reduction in hsCRP as compared to the empagliflozin, which is statistically significant. So it reduces the inflammation as well. And if you look at the coronary interventions trial, so various trials and the data has proposed that reduction in 4 millimeter of mercury reduces 12.5% prevalence of coronary artery disease. which in our patients reduces 5 millimeter mercury. 1 millimole reduction in LDL results in 8.2, and 0.9% reduction in HbA1c results in 2.9% reduction with the established coronary artery disease whose age is more than 60, or patients who has a one cardiovascular risk factor with the age more than 60. Type 2 diabetes mellitus, very significantly high follow-up of almost 99.7%. And if you, though it has failed to prove on the superiority, but there is a non-inferiority statistically significant reduction. If you look at the each hard endpoint, the MACE is statistically significant, CV death is statistically significant, all-cause mortality is statistically significant. So these all overall favors in a semaglutide oral preparation as compared to the placebo. Now, this semaglutide oral from Pioneer 6 has been compared with the Sustain 6. This Sustain 6 is a subcutaneous injection of semaglutide. It is not available currently in India. It is once in a week dose to be given subcutaneously, and if they have proven the superiority as compared to the placebo. And if you compare both the data of Sustain 6 and Pioneer 6, which is hand in hand similar, and when both are been combinedly joined, it further reduces the risk of cardiovascular death, MI and stroke by 24%, which is a superior reduction as compared to the placebo. So where we put SGLT2 and where we put GLP, GLP-1 can be given in any patients of diabetes, irrespective of their starting age. Any risk factor, associated risk factor like obesity, hypertension, dyslipidemia, GLP-1 will be the drug of choice. When patient has established coronary atherosclerotic coronary artery disease, it is type 1A indication for patients with the diabetes, while SGLT2 has a type 1AB indication in patients with the heart failure. So coming to again where I have started, let us understand this puzzle again, whether GLP-1 has addressed all this. It has addressed obesity, it has addressed insulin resistance, it has addressed inflammation, it has addressed hypertension, it has addressed dyslipidemia, and most importantly, it has addressed the glucose. So way go forward to prevent the cardiovascular complication if the one drug which has a pleiotropic effects in a patient with a type 2 diabetes mellitus is GLP-1. And I want to give a one-line message is GLP-1 is to be started as soon as possible in a patients with type 2 diabetes mellitus, to be up titrated to the maximum tolerated dose, and to be considered in each and every patient, whether patient has established coronary artery disease or at a high risk of patients, a high risk of developing coronary artery disease, should be given GLP-1. Thank you for your patience listening.
Thank you, Dharmesh, for a wonderful talk. And I think we have strong CVOT trials now emerging with data from the semaglutide. Now we move to the next session, which is on another important therapy, selexipag, which is a newer therapy in management of pulmonary arterial hypertension. We had important trials, and we listened to Dr. Kalpesh and Sora talk about selexipag in management of pulmonary arterial hypertension.
Good morning, everyone. So today we are going to discuss about the management of pulmonary hypertension. What is new in the management of pulmonary artery hypertension, and what its implication for clinical practice. So just we'll go through the brief in pulmonary hypertension. It is a major contributor to the right heart failure, as we are knowing. And if you look at the 80% of population with pulmonary hypertension, is from the developing countries. The major prevalence and incidence is noticed in the Southeast countries as compared to the Western countries. So if you look at in India, the annual incidence of pulmonary hypertension in Kerala registry, it was 48 per million adult population. Now come to the updated definition for pulmonary hypertension. In 2015, ESC and ERS guidelines, which for the pulmonary hypertension, they have characterized the mean pulmonary artery pressure more than 25 to define the pulmonary artery hypertension. But in recent guidelines, they have changed to the more than 20 millimeter of mercury mean pulmonary artery pressures to diagnose the pulmonary hypertension. It can be pre-capillary pulmonary hypertension if pulmonary artery pressure mean more than 20 and pulmonary wedge pressure less than 50 and PVR more than 2 Wood units. If it is post-capillary pulmonary hypertension, then pulmonary wedge pressure more than 50 and PVR less than 2 Wood units. Now comes to the evaluation of the PH treatment. There is a significant progression in treatments. If you look at the 20 years and 30 years ago, there was no treatment for pulmonary artery hypertension. And today there are the 13 treatments for the pulmonary artery hypertension options are available. And definitely that has changed the era which was shown in the review registries that over the period of time, the established treatment has drastically improved the survival from the 3 years to the 9 years after the diagnosis of pulmonary artery hypertension. And we know that the key pathways involved in pathogenesis of the PH is endothelin pathways, which causes the vasodilatation and antiproliferation. So we have a stimulant of these two pathways, which is helpful in the treatment of pulmonary artery hypertension. Now, these are the most 8 determinants of the prognosis of the PH. First is progression of symptoms. Second is syncope. Third is Bruce functional class. Fourth is 6-minute walking distance test or exercise testing. Fifth is natriuretic peptides imaging, including echocardiography and cardiac MRI, and hemodynamic about the right heart catheterization and right heart failure. So these are the 8 determinants of the progression of the pulmonary artery hypertension. And this is the treatment chart algorithm for the pulmonary hypertension. What this is, treat the PH patient as much as you can do aggressively as possible. So suppose the patients who comes to the clinic when the PH is confirmed by expert center, mainly by the right heart catheterizations, you can give some general use, some supportive treatment. Then these patients are for the vasoreactive tests, only for the idiopathic, hereditary, and drug-induced pulmonary artery hypertension. If vasoreactive is confirmed, then these patients can be treated with the CCD, calcium channel blocker. Suppose patient is non-vasoreactive, then you have to classify whether it is low, intermediate, or high risk. If it is low risk, you can give the residual role of the initial monotherapy, either with endothelin receptor antagonist or PDE inhibitors. But if patient suppose in intermediate risk or high risk, definitely you have to start the initial oral combination therapy. After the 3-6 months, you have to reassess the patients. If still patient is falling into intermediate or high risk, you have to give the triple sequential combination therapy. Still patient is not responding, you can maximize the medical therapy and you can give an option for the lung transplantation. So this is the algorithm. The most important things start with the oral combination therapy. If you look at the ERS-PAC guidelines 2015, the recommendation for the initial combination therapy is class 1A in patients who is having a functional class 3. And class 1 recommendation for patients with PH, it's embrisatan and tadalafil combinations. Other ERA plus PDE5 inhibitors, they have a class 2A recommendations. So it is important to initiate the combination therapy, specifically embrisatan with tadalafil, as in functional class 3, it has a proven role and it delays the progression and it improves the symptoms of the pulmonary hypertension. Now, which was the trial which has shown that ambition trial, they have shown that initial combination therapy with embrisatan and tadalafil significantly reduced the risk of the clinical failure by 50% as compared to the pooled monotherapy with either agents. So if you give the combination therapy and you compare the individual molecular with the pooled monotherapy, the advantage is more with the combination therapy. It will reduce the clinical failure by 50%. This was the another repair study which has studied the mesistatin and PDE5 inhibitor which has shown over the period of 26, it reduced the RE size, it increased the LV size, and it moves the septal from left to right, which reflecting decreasing right heart side pressures. Now, what are the challenges in management of pulmonary hypertension? As we are knowing that once the patient having a PH, it is always progressive and it is associated with high mortality and morbidity despite of available treatment. As we know that PH is incurable disease, it progresses silently even if patient feels fine with therapy. This is the 3 registry, Triton study, Seraphim study, and Ambition study, which has shown that 20 to 32% of progressions despite of dual PH therapy. So what are the options we have once the patient's on oral combination therapy? So this is the new molecule which ERS and ESC guidance recommends the selexipag add-on therapy on background of the combination treatments, specifically patients who's having an initial, intermediate or high risk. So these are the patients will get the benefit of the triple sequential combination therapy. So how will you classify the patients with the low, intermediate and high risk? So this was published in 2015, which ERS and EST guidelines has classified into 3 strata: low, intermediate, high risk, based on the risk assessment, which involves these are the 8 components. But this is very cumbersome. You cannot apply for the routine clinical practice. And so what they have changed, they have simplified the 4 strata risk assessment tool, which is newer one, which was published in 2022 ERS ESC guidance. They have just take a determinants of the point Wolf's function class, 6-minute walking distance test, and BNP or NT-proBNP. So it will classify it into 4 assigned point, 1, 2, 3, and 4, depending on the low risk, intermediate, high risk, or high risk. So what is the advantage of this 4 strata risk assessment tool? It is compared with the 3 strata model. The 4 strata model is more sensitive to changes in risk from the baseline to follow, and these changes were associated with the changes in long-term mortality risk. The main advantage of this is better discrimination between the intermediate risk group. It will classify intermediate low risk and intermediate high risk, which helps the guide to therapeutic decision making. So now come to the Griffons trial. What we are going to discuss about the selexipag. This is a Griffon trial which is recently published, which have studies the treatment need or patients who's already on the endothelin receptor antagonist and phosphodiester 5 inhibitor combination or monotherapy. So they have studied the 1156 patients and they were randomized into 1:1 ratio. The 50% of patients has received the selexipag from 200 to 1600 microgram twice a daily dose as compared with the placebo. The primary endpoint was time to first morbidity and mortality event. They have studied the disease progressions, hospitalization for PH worsening, and worsening of PH and all-cause death. If you look at the patient's profile, the etiology of PH, in which 58% was having an idiopathic or hereditary PH, 29% of patients was having a CTD, means connective tissue disorder related PH, and 10% of patients having a congenital heart disease related PH, and whose function class was at baseline was class 2 and class 3 in majority of patients. It was multi-center double-blind randomized trial, and there were almost 32 persons was on only phosphodiester inhibitor and 15% was endothelin receptor antagonist. So this was the baseline patient's profile. What they have shown that selexipag reduced the risk of morbidity and mortality by 40%. If you look at the bar diagram, the overall proportion of patients was lower found in triple combination therapy was 27% as compared to the dual anti-therapy, anti-PH therapy, which was 41%. So there is overall 40 6% risk reduction, and p-value was very significant, and hazardous ratio was favorable for the selexipag. Not only that, it also reduced the hospitalization and death due to the pH worsening by 30%. So this hospitalization was lower in selexipag group as compared to the placebo. It also improves the 6-minute walking distances from the baseline to 26 weeks. So at the end of 20 weeks, the 26-week therapy, the improvement of the 6-minute walking distance was changed up to the 12 meters in selexipag group. And this is about the patients who is having a connective tissue disorder with the pH. There is a 41% reduction in events in terms of mortality and morbidity if patient is treated with selexipag with the combination of the anti-PAH. So systemic sclerosis, SLE, multi-connective tissue disorders, in which if you treat with the triple combination therapy, definitely patients have a more advantage of the selexipag in background therapy of the anti-PH therapy. So depend on that, the ERS ECSC guidelines recommending the triple combination therapy or triple sequential combination therapy for PH in patients who's having a functional class 3. The selexipag with ERA or PDS inhibitor is class 1 recommendation. So when we should add the selexipag and when we'll get the maximum impact in clinical outcome. So this was the study when you add before the 6 months of the diagnosis of the pH, and if you treat after the 6 months of the diagnosis. So patients who has received the selexipag within the 6 months of the diagnosis of pulmonary hypertension, they have shown that there is a much more risk reduction by 55% as compared if you treat the patients with the selexipag after the 6 months of the diagnosis. So it is very important to initiate the selexipag therapy as early as possible in after the diagnosis of pulmonary hypertension. And this is also seen that treatment effect is greater when initiated early in the course of the disease. So if you look at the patients who is having a functional class 2, they will definitely get more benefit of the selexipag therapy in background of the other anti-pulmonary anti-PH therapy. So what is the treatment impact of selexipag when used as an upfront triple combination therapy? So this was a Triton study where they have studied the upfront triple combination therapy with selexipag. Means one patient will receive triple combination directly and one patient will receive the double combinations. And if you look at the bar diagram, that first disease progression event and all disease progression event was quite lower in patients who has received the triple oral combination therapy. The worsening of the pH, hospitalization for worsening of pH, and initiation of prostacyclin for pH and all-cause deaths was lower in patients who has been treated with the triple combination therapy. So initial triple therapy adds the incremental benefit over initial double therapy for the further delaying disease progression. So in high risk of patients, definitely triple combination therapy is very much beneficial. And this is the case report which has been published in European Heart Journal in 2020. And this is under combination of therapy. Selexipag, macitentan, and sildenafil has shown that there is a significant hemodynamic improvement in terms of cardiac MRI, where there is a improvement in RV ejection fraction and there is an improvement in RV systolic volume index. And maximal advantage dose when you treat with this patient with the high dose. Almost 64% of patients receive the high dose, means 2000 microgram per day. And they have shown there is a significant improvement in pro-BNP levels, WHO functional class, and the mean pulmonary artery pressures. So these are the other medicines which are available to treat the patients with the high risk pH. When the patient is not responding with either ERA or phosphodiesterase inhibitor, this is epoprostenol, we can use IV. This is the allopros, verapros, and treprostinil, which has inhalation and sub-Q and IV administrations. And last is Selexipag, which is available in the oral form. The maximum advantage which is available in oral form, so patient's compliance will be good, and compared to the other therapy, it is cheaper. What is the benefit of using Selexipag? Because it is a highly selective IP prostacyclin receptor agonist. So it has, the metabolite has a higher affinity for the IP receptor compared to the prostacyclin receptors. So it is associated with the fewer adverse effect as compared to the other prostanoids. And as we know that this headache, diarrhea, nausea, and pain enjoy this common side effect with the prostacyclin therapy. But once the patient's on the Selexipag therapy, the maintenance dose will have a less side effect as compared to the initiation of therapy. So maintenance dose is highest tolerated by the patients. So comes to the key message to the use of Selexipag. It is a novel, orally available, and highly selective IP receptor agonist. There is a significant risk reduction noticed in death and complication related to the pH by 40%. It reduces the stress on the heart by reducing the NT-proBNP level, improves the 6-minute walking test and Wood's functional class, achieves the low risk status mortality from intermediate risk. So early initiation with Selexipag has a greater impact on reducing pH progression, hospitalization, and reduction in NT-proBNP. It is safe and well tolerated. Thank you.
So we had a wonderful talk on the recent advances in management of pulmonary hypertension with therapy in Selexipag. Let's move to the next talk, and this is on DEB nanotechnology in PCI by Dr. Apurva Vasavada. We already had Dr. Praveen Chandra speak ahead of Dr. Kalpesh on zero contrast PCI before this. So over to Dr. Apurva Vasavada for nanotechnology in PCI, in drug-eluting balloon.
Hi, very good afternoon to all of you. Today I have been given the task of discussing the new entrant into the field of PCI, that is drug-coated balloons. So we'll discuss where it stands in the current PCI scenario. So the PCI has evolved, evolution started from plain old balloon angioplasty from 1977 onwards, went on to BMS, then on to DES, first, second and third generation DES, and ultimately led to bioresorbable scaffold, which has been partially given up and may come back soon. But we'll discuss how this evolution has taken place and where does the DCB fit into the situation. So POBA started in 1977. Acute closure caused by dissections still was 5 to 10%, giving sleepless nights to the operator and risk to the patient. And the restenosis was 25 to 40%, mainly due to inadequate MLA achieved, medial dissection, negative remodeling, and neointimal tissue proliferation. This led to discovery, or rather invention, of BMS, which was initially used as bailout to save from acute closure. Then it went into provisional BMS use and ultimately used to a near default use of BMS because the results were comparatively better than the plain old balloon angioplasty. But still, there was acute closure due to stent thrombosis 1 to 2%, even late sometimes, and ISR remained up to 15 to 30% depending on the lesion treated. And the variety of lesion that could be treated was still relatively limited because of the high restenosis rates in complex forms of lesions. So this was more limited to type A and type B1 lesions. Then the PCI evolved rapidly once the DES was put into the market because of use in wider range of lesions. But still there are some shortcomings because you are living in metal and therefore you need DAPT for 3 months to up to 12 months or longer even in some patients. HBR patient, there is high bleeding risk patients, and those patients who require urgent surgery or there is planned surgery after the PCI could land into trouble because you have to stop the DAPT and the metal inside may not be endothelized and you can get stent thrombosis. There were issues of delivery in tortuous calcified vessels where the polymer can get stripped off or the stent itself can get damaged. Changing the artery architecture and motility, because you put a long stent in a tortuous vessel, the motility and the architecture changes and that can lead to long-term harm. CABG sites were nullified. For example, covering the mid and distal LAD can lead to future possibility of lima being nullified. Bifurcation stenting led to side branch issues. In very small vessels, the stents themselves, because of the strut thickness, would act as space occupying lesions. And if there is a late loss, the late loss will affect the small vessels much more than a bigger vessel. The no reflow risk with post dilatation, especially in ACS STEMI patients where there is soft lipid plaque and thrombus, was a major issue with stent, and the stent results were more dependent on good post dilatation, and post dilatation aggressively in these situations would lead to no reflow. Late malapposition causing stent thrombosis was an issue, and ultimately, if there was an instant restenosis either with BMS or DS, and it led to a lot of trouble, and repeat treatment is relatively difficult and requires more inputs. And ISR and MACE were still not eliminated totally. So 2 to 15%, depending on the lesion, the ISR and MACE still remains even with DES use. But of course, because the usage is now gone up to many of the type C lesions, and therefore the chances of MACE are going to be higher. So where does the DCB slot in? See, POBA basically causes neoenthemal proliferation and negative remodeling, which leads to restenosis. Both these are slow processes, and they require rapid tissue reuptake of the drug from the balloon, and as well as prolonged persistence of the drug in the lesion tissue. And paclitaxel was initially found to be more suited. It is a cytotoxic drug, but the absorption is faster and tissue persistence is more. There was a putative advantage of positive remodeling. This was seen in peripheral vessel balloon angioplasty with DCB paclitaxel, but the red flag of toxicity and increased mortality was found in peripheral arterial disease. The studies of paclitaxel drug-coated balloons in coronaries have not found the same increased mortality, but this is a question mark still on paclitaxel. The sirolimus has a problem that all limus molecules are having a poor uptake in the tissue from the balloon, and the persistence is also poor. So this requires a spatial coating technique and carrier molecules to get the limus into the tissue from the balloon. And this technology is now, this is evolving, and many of the players are in the market with limus. The advantage of limus being that it is less toxic, and if it persists long term, it has been proven to be better in drug-eluting stents, and probably will prove to be better with DCB also. Now, what is the technical issue with DCB? If you can consider that DS, all DS are not same because different molecules used, different platforms are used. Similarly, all DCBs are also not the same. So there is no class effect because the pharmacokinetics and pharmacodynamics vary with the delivery systems and the molecule used. So you have to select the DCB, and according to the trial data, you have to use the DCB in certain situations. The whole field of DCB indications is still evolving, and certain things are established, certain things are still in the process. What are the advantages of DCB or BMS or DS? There is homogeneous drug delivery into the vessel wall. If you are putting a drug-eluting stent, the delivery is only at the sites where the stent metal is coming into contact with the vessel wall, and then there is diffusion of the drug into the vessel wall. So homogeneous delivery in the vessel wall, and immediate drug release without use of polymer. So you are avoiding a polymer. You are avoiding any metal in the artery, so that long-term issues of stent thrombosis, malapposition are removed, and the architecture of the vessel is maintained. The option of using drug-coated balloon either alone or in combination with the proximal DS and distal DEV is a good option. There is no specific training required. There is no specific criteria of achieving the optimal stenting. Here, the balloon itself is used, and this is the basic process of angioplasty. The potential of reducing the antiplatelet therapy to almost 1 month or less, and if required in HBR patients or in urgent surgeries or planned surgeries after angioplasty, you can stop the antiplatelet agent easily without chances of acute closure of the vessel. Event rates are comparatively low, and similar efficacy outcomes are seen in certain subsets of lesions, not in all subsets, which we'll discuss further. And the most important thing is in patients with recurrent instant restenosis, say previous BMS or DS, the implantation of a new DS will result in multiple metal layers, onion skin phenomenon, and these patients are at high risk of additional recurrences or even stent thrombosis, and therefore probably DCB might be an advantage in these patients. Before going into the indications for DCB, we'll discuss what is the difference in the technique usage of DCB. Very important is that optimal lesion preparation is must. Just like in patients with bioresorbable scaffolds, like Absorb, we used to do perfect lesion preparation. Here also it is very important. Sizing of the reference diameter post nitroglycerin into the coronary with or without imaging is important. Before opening and the DCB for usage, confirm that optimal predilation is taken place. So your predile balloon should be checked in orthogonal views and make sure that it is 1:1 expansion is there. The residual lesion should be less than 30%. There should be no type C or higher dissection. TIMI3 flow should be established and confirmed before you open the DCB and insert it. And the next step to be more sure is leave a pressure wire inside, and the resting PDP or DFR should be more than 0.9 or the FFR should be more than 0.8. It should be checked at least 5 to 10 minutes after your last balloon inflation. And once you are sure that all these 4 criteria of less than 30% residual, no high dissection, TIMI3 flow, and your DFR more than confirmed, then you can go for usage of DCB. Also make sure that the DCB can be delivered quickly and easily to the lesion. And the transit time from the 2E burst, the Y connector to the lesion should be minimized. So make sure that you use all necessary tricks before inserting the DCB. This can be judged by the previous balloon delivery that you found to be difficult. Then you can use better guiding support, buddy wires, guideline extension, or better lesion preparation before opening the DCB and inserting it. Make sure you don't touch the balloon surface with wet gloves because the drug can dissipate from wetting of the drug. If the delivery fails for some reason or the other, then it is better to discard the balloon and use a new one because the drug will have significantly eluted in the blood and the tissue. Inflate the balloon, ensuring the proper length and diameter of the balloon selection, and inflate for at least 60 seconds and even longer if the patient tolerates better. Now we'll come to the indications. First, we'll talk about DCB in in-stent restenosis, which is more or less a good established indication of a DCB at present moment. ISR, the technique of re-PCI involves almost a mandatory use of imaging because you have to find out whether there is any mechanical cause like a fracture of the stent or under expansion or malposition of stent which has led to the ISR. Once you have taken care of that mechanical the complication of the stent, then you can use DCB in some of the patient. So make sure you detect and manage the mechanical issue by whatever treatment modalities that is required, whether it is rotablator, IVL, high pressure balloons, or cutting balloon. Make sure there is no geographic miss of the previous stent, and then tackle that. If there is a stent fracture, of course, you will do another stent. Here, DCB cannot be used. ISR of BMS is different from ISR of DS. In BMS ISR, usually there is only neoendodermal proliferation, and the data from various studies shows that DCB is clearly better than DS and at least as good, and therefore it is established as a class 1 indication in BMS ISR. Now, unfortunately or fortunately, BMS ISR nowadays are not going to be seen because almost last 10 to 15 years we are already using DS, and therefore in our setup this is rarely seen.
Hello friends, welcome. Hello friends. Welcome to CardioCon 2023. Today I am going to discuss a topic which is really life-threatening and require immediate
good strategy in selected patients probably. So the summary is DCB only PCI is very promising. Fourth revolution in coronary interventions probably, opening new horizons. The indications may be small vessels, ISR stent delivery, or ISR or stent delivery failure, branch lesions with smaller vessels like OMs diagnosed, PDA, PLV, true bifurcations with long side branch lesions or complex side branch ISR difficult to treat with DS. Bifurcation lesion, you can use DS main branch and DCB side branch strategy. Long segment CTOs, long DCB or focal stent with or without focal stenting can be used. High bleeding risk patients, planned surgery immediately after PCI, you can use DCB. Of course, peripheral vascular disease, it is FDA approved already from 2016. It is nowadays being used in erectile dysfunction also, not our field, of course. So these are the possible indications for DCB. Thank you.
So after that wonderful talk, we have now Dr. Mukesh Ladda talking about one of the important methodology and important consideration for management of pulmonary embolism. How we manage thrombolysis in an acute pulmonary embolism. It's not just the hemodynamic unstable, but even high risk without cardiac decompensation patients also have an indication. He is an interventional cardiologist at SAL. Over to Dr. Mukesh.
Today, hello friends. Welcome to CardioCon 2023. Today, I'm going to discuss a topic which is really life-threatening and require immediate decision in terms of diagnosis and the management, and that is the diagnosis and the management of acute massive pulmonary embolism. Venous thromboembolism affect nearly 10 million people every year worldwide. And most significant subtypes are DVT and pulmonary embolism. DVT means the blood clot in the leg veins, and the pulmonary embolism when that leg veins clot migrate and travel to the heart and goes into the pulmonary artery, that is a pulmonary embolism. There are a number of risk factors predisposed to pulmonary embolism. This is a long list: the surgery, trauma, immobility, cancer. These are the main risk factors: pregnancy, obesity, iatrogenic like CVP line incision, stroke, fracture. These are the main risk factors which we see in our clinical practice. By 3 months, 14% of the patient with proximal DVT and 18% with PE will have died. It is more than a cancer and the traffic accident. The clinical presentation: in symptomatic DVT, approximately two-thirds of patients present with symptoms, and almost 1/3 patient present with symptoms in PE. Most patients with VTE may have both DVT and PE. Almost 50% of patients with proximal DVT, even though they don't have any symptoms of PE, but in the lung scan, we can find out that these patients have PE evidence. This is called as silent PE. Annual incidence of pulmonary embolism ranges between 23 to 69 cases per lakh, and it is responsible almost 15% of the hospital death and 30% of the pregnancy and delivery death. Nearly 10% of patients who die of PE do so within 1 hour of onset of symptoms. So the time is also important. The decision making is also important because really high mortality rate. Most of the time, there is no specific sign and symptoms because these are not sensitive enough. The clinical suspicions largely remain unconfirmed due to the high mortality rate, and the silent P is also responsible, which is present almost in 50% of the DVT cases. Classification of P: massive, submassive, and low risk. If patient present with acute pulmonary embolism with sustained hypotension, blood pressure less than 90 for 15 minutes, or require inotropic support, pulselessness, profound bradycardia, and shock, considered massive P. Submassive P, blood pressure should be more than 90, but there is evidence of right ventricular dysfunction. And the low risk acute P, absence of clinical markers of adverse prognosis, that is related to massive and submassive P. Now, the indicator of RV dysfunction, the RV dilatation, elevated BNP and anti-pro-BNP, ECG changes like right bundle branch block, and typically T-wave inversion in the first V1 to V3 leads. Indicator of myocardial necrosis, as in coronary, like elevated troponin. So massive pulmonary embolism is the result of hypercoagulable state. If we go with Virchow triad, there is disruption of the hemostatic balance, thrombin activation, formation of the thrombus, ultimately blockage of the vein, that is DVT. And that embolization of that clot goes to the lungs and the formation of pulmonary embolism. If patient is hemodynamically unstable, that causes acute massive pulmonary embolism. So in pathophysiology, there is obstruction of the flow through the main pulmonary artery, increase afterload in the ventricle. In addition, there is mechanical obstruction of the RV, release of vasoactive mediator, thromboxane A2, serotonin, and resulted in pulmonary vasoconstriction, increased pulmonary vascular resistance. Resultant increase in RV wall tension, displacement of the interventricular septum to the left, and impaired left ventricular filling, and if untreated, RV outflow obstruction. So the final goal in the management of P, there should be prevention of the death, reduce the chances of recurrent embolic event, and minimize the long-term morbidity. So first step, we have to suspect, because there is history and clinical scenario is very important. If any suspicion is there are certain criteria like Geneva and Wells rule can use and clarify that, and then diagnostic workup like D-dimer, ECG, echo, and then lastly CT pulmonary angio. After that, risk stratification, either patient is hemodynamically stable or not, RV dysfunction is there, and troponin levels. And after that, patient should be treated according to the risk stratification with anticoagulation and thrombolytic agent. Now coming to the case scenario, a 57-year-old male smoker, no significant past medical history, presented to the emergency department complaining of severe shortness of breath, and he reported that as he reached down to pick something, he suddenly was not able to catch his breath, felt lightheaded, and collapsed to the floor without any loss of consciousness. The associated symptoms included chest pain that was worse on the inspiration and diaphoresis. This is the classical typical history of acute pulmonary embolism. And initial assessment in the emergency department revealed blood pressure of 80 mmHg. He was in shock, heart rate of 132 beat per minute, tachycardia, and the respiratory rate of 40 per minute, tachypnea with an oxygen saturation of 80 breathing air. Pulmonary finding consisted of bilateral crackles at the bases, and his extremities were cool and cyanotic with weak peripheral pulses. Electrocardiogram shows sinus tachycardia. So this was the typical clinical scenario of pulmonary embolism. Now coming to the symptoms, usually these are non-specific, severe dyspnea at rest, syncope, and even cardiac arrest, maybe past medical history related to thromboembolism, tachycardia, tachypnea, hypotension, cyanosis, and there may be evidence of RV dysfunction, include distended neck veins, parasternal heave, accentuated pulmonary artery pulsation. And sometimes when you are suspecting, not sure about the pulmonary embolism, there are certain criteria like Geneva rules and the Wells rule may help in diagnosis or in suspicion of pulmonary embolism. In Wells score, there are certain points like history of previous P, heart rate more than 100, surgery in last 4 weeks, hemoptysis, active cancer, signs of DVT, and there should not be any alternative diagnosis of P. And each point, if it is present, given one score, and if that scores more than 2, then there is high risk of pulmonary embolism. Similarly, similar kind of score, other than the one more criteria they added, that age more than 65 in Geneva, and if it scores more than 3 or more, then chances of P are very high. So now coming to the diagnosis, we should send D-dimer in each and every suspected patient of P, ECG for the right ventricular overload. X-ray mostly don't get any specific findings. Yeah, echo and drop-I and BNP definitely may help. And lastly, the gold standard is CT pulmonary angio. and for the Doppler of the leg veins to find out the cause and source of the emboli. Now coming to the algorithm to diagnose the P. Once you suspected P on the basis of symptoms like dyspnea, chest pain, cough, syncope, and ordered chest X-ray, ECG, routine lab, D-dimer, and anti-pro-BNP. After that, you have to stratify the risk. If patient is in shock, pulseless, heart rate 40, if yes, then send the patient for CT, pulmonary angio. If it is positive, then treat as a massive pulmonary embolism. Or if CT pulmonary angio is not possible, then do echo. If you get findings of pulmonary embolism like RARV dilatations or in echo, then consider P and treat accordingly. If no, then negative. And if you are not suspecting, if you are suspecting but non-high risk P, like patient is not in shock, then assess clinical probability simplified Geneva score. If it is more than 2, then treat a considered P and send the patient for CT pulmonary angio. If score is less than 2, then pulmonary embolism exclusion score. If it is there, then send the D-dimer. If it is positive, then again same way, advise CT pulmonary angio, and on the basis of finding, consider P. So this is the algorithm in diagnosis of pulmonary embolism. If patient is in shock, hypotension, it is high risk, and if it is not, then no risk. So shock is the criteria of high and no risk. In high risk category, hemodynamic instability is the only criteria. Other parameter like RV dysfunction, troponin positive, or anti-proBNP raised, all these fit into the intermediate category. And excluding all these things and suspecting pulmonary embolism, then it is a low risk pulmonary embolism. Now coming to the pulmonary embolism severity index. There are certain criteria, parameters like age, male, cancer, chronic heart failure, chronic pulmonary disease, pulse rate more than 110, BP less than 100, respiratory rate more than 30, temperature, altered mental status, saturation. According to that, if 0.0, there is 1% mortality risk. If point is more than 1, then more than 10% mortality in first 30 days. So this is the risk stratification criteria on basis of embolism severity index. Now coming to the treatment part, immediately patient should be on unfractionated heparin if it is a high risk patient, and then fibrinolysis is the should be done immediately. Low molecular weight heparin, yes, there is a role of low molecular heparin in intermediate to low risk category. And catheter directed thrombolysis rarely used. Surgical thrombectomy once fibrinolysis fails. An IVC filter for when patient is contraindicated for anticoagulation. Anticoagulation in high risk P, anticoagulation with unfractionated heparin should be started without any delay. LMWH and fondaparinux is recommended for non-high risk P, as I told. And unfractionated heparin should be continued for at least 5 days, may be replaced by vitamin K antagonist only when targeted INR level achieved 2 consecutive days. Anticoagulation should be started at the earliest for the patient with intermediate or high clinical probability of P and having no contraindication to anticoagulation. Thrombolysis in acute P. The faster improvement in pulmonary obstruction, PA pressure, pulmonary vascular resistance in patient with P compared with unfractionated heparin alone. The improvement are accompanied by a reduction in RV dilatation on echocardiography. The greatest benefit observed when treatment is initiated within 48 hours of symptoms onset. Even though thrombolysis can be done till 14 days. A meta-analysis of thrombolysis trial that included patients with high-risk P indicated a significant reduction in combined outcome of mortality and recurrent P. Now the thrombolytic agent only 3 agents are recommended, that altiplase, streptokinase, and urokinase. RTPA dose is 100 milligram over 2 hours. Streptokinase 2.5 lakh bolus followed by 1 lakh infusion for 24 hours. And urokinase 4400 international unit per kg as a loading dose and followed by 4400 international unit per kg per hour for 24 hours. So according to the guideline, it is recommended that anticoagulation with unfractionated heparin, that is the class 1 indication, systemic thrombolytic therapy in high risk P class 1, and surgical pulmonary embolectomy if thrombolysis failed, class 1 indication. Now coming to the altiplase, a thrombolytic agent, a recombinant human tissue type plasminogen activator that activate plasminogen directly to plasmin, lysfibrin as well as fibrinogen. It is approved for use in acute ischemic stroke, pulmonary embolism, and MI. The dose usually in more than 65 kg, total 100 milligram among them, and 10 milligram is given as a bolus and 90 milligram as an infusion. There are certain contraindication in any kind of thrombolytic therapy. Same is applicable here also. Now coming to the clinical evidence of altiplase in acute P. You can see there is it significantly lower the mortality compared to the heparin alone therapy in massive P, and that is the massive advantage. The efficacy of systemic thrombolysis that shows that P mortality and death that is statistically significant in terms of systemic thrombolysis compared to not thrombolysis, and it is more safe. When you compare with LT and tenecteplase and other thrombolytic agent, there is major bleeding and the intracranial bleeding or less with altiplase. So altiplase is more safe and effective in pulmonary embolism. The benefit of thrombolysis in pulmonary embolism, that is the PAMS2 trial, 36 patients with acute PE randomized in one group is received RTP and another one heparin alone, and the follow-up immediately after termination of study that showed reduction of the angiographic severity of PE and reduction of mean pulmonary artery pressure from 30 to 21 and increase in cardiac index from 2.1 to 2.4. Now, altiplase versus heparin in acute PE, and in this trial, more than 100 patients. And first group RTP was given, in the second heparin alone. The randomized double-blind trial that shows in the RTPA group, improvement of the RV function, reduction of the RV dimension, improvement of the pulmonary perfusion, and there is no PE recurrence. So in thrombolysis really help acutely as well as long-term benefit. The randomized control trial of RTPA versus urokinase, and that is a clot lysis at 2 hours, two principal endpoints, clot lysis at 2 hours as assessed by angiography, and the perfusion defect with the perfusion lung scanning. By 2 hours, 80% of RPA treated patients show clot lysis compared with 48% of urokinase treated patients. An improvement in lung scan reperfusion at 24 hours was identical in both the treatment group. So again, RTP is better in that terms. Effect of urokinase versus RTPA on total pulmonary resistance in acute massive pulmonary embolism. After 2 hours, total pulmonary resistance decreased by 22%, and in altiplase it is 36. So almost statistically, significant difference is there. The continuous monitoring of the pulmonary arterial pressure, cardiac index, and total pulmonary resistance reveal that these variables improve faster in altiplase group with persistently significant intergroup differences from 30 minutes to 4 hours. Now the third comparison between altiplase and the streptokinase, and that shows that there is an improvement in the right ejection fraction evolution and improvement in the pulmonary vascular resistance compared to the altiplase. So to summarize, one should suspect the P, that is the most earliest and important thing. Once you suspect if any likelihood of P, take the help of Geneva rule or Wells rule, and then start doing a diagnostic workup like the D-dimer, ECG, CTPA, lastly before echo, after echo, and finally the risk stratification. Is patient is hemodynamically stable, RV dysfunction is there, troponin levels are increased or not, and after that treat accordingly with anticoagulation, thrombolytic therapy, and last option is the surgical thrombectomy. Thank you so much.
Thank you, Dr. Mukesh, for that talk. So that brings us to the last lecture. We are slightly behind schedule. So I'd have directly invite Dr. Chirag Sheth to speak on HD IVUS rather than take any questions. Over to Dr. Chirag. Dr. Chirag Sheth is an interventional cardiologist and he's talking on high definition IVUS.
Good evening, everyone, and attendees and the chairpersons at this meeting, CardioCon 2023. At the outset, let me congratulate Dr. Kamal Sharma and the organizing team for inviting me for this talk. Moving forward, the title of the talk is about the high definition intravascular ultrasound. As we know, the intravascular ultrasound, the sound-based imaging modality, the in vivo clinical use has been described from 1988. The system involves a catheter mounted with piezoelectric crystalline transducer, which generates the sound waves, and there is a differential reflection of sound waves, which are generated cross-sectional 360 degrees of grayscale images of vascular structure. Ever since its inception over the last 2 decades, there has been several data, both from randomized clinical trial as well as registries, about its impact during the angioplasty. Namely, some of the large clinical studies like IVUS XPL, Ultimate, CTO IVUS, and several others which are comparing with optical coherence tomography, including Illumian 3, Opinion, and ROC2. In all of these studies, the impact of coronary imaging over precision angioplasty has been found to be profound. If we simply examine the 5-year follow-up of IVUS XPL randomized clinical trial, the MACE rates have been significantly affected in a positive direction with the use of coronary imaging, and the impact has been seen as early as less than 1 year, has remained significantly diverging as far as the outcomes are concerned between 1 and 5 years, and at the end of 5 years as well. As is clearly seen in this Kaplan-Meier estimates of occurrence of primary endpoint for all patients and for patients who underwent intravascular ultrasound-guided stent implantation, one can clearly see the curves diverging and continue to diverge over a 5-year follow-up as far as the major adverse coronary events are concerned. The conclusions from IVUS XPL clearly say that with the use of IVUS guidance, there is 50% relative risk reduction as far as the MACE rates are concerned, and curves continue to diverge between 1 and 5 years. So there has been sustained clinical benefit of image guidance, not only in short term, but also in the intermediate to long term. It also underlined the fact that impact of IVUS is not only use dependent, but what the decision as a clinician one makes and improves as far as precision in the steps of performing angioplasty. That matters more, simply rather than the use itself is concerned. Based on this kind of clinical data, the ACC/AHA guidelines have designated coronary imaging with intravascular ultrasound as a class 2A indication for use in patients for optimizing the stent implantation with PCI, as well as to assess the severity and optimize the treatment of unprotected left vein disease. Now, going forward about the high definition intravascular ultrasound. The intravascular ultrasound imaging modality actually involves coronary imaging catheter, which has been provided with a piezoelectric crystalline transducer. Now, this transducer in HD IVUS has been provided now with a 60 megahertz of advanced composite transducer. And what it does is that the 60 megahertz transducer allows wider tissue band, band of the sounds transmitted, and that leads to a much better image resolution. With a similar degree of vessel penetration, the clarity as far as the vascular structure is concerned, the imaging of vascular structure is concerned, has been tremendously improved. If you see in this chart that with the help of 60 megahertz of high definition intravascular ultrasound signals, the axial and lateral resolution is tremendously improved, and it almost matches to the infrared-based optical coherence tomography. The soft tissue penetration improves, and a vessel as large as 6 millimeter can be easily evaluated with the use of HDIVs. We just look into some of the images which are being generated with HDIVs. One can clearly see that with the 60 megahertz coronary imaging catheter, it provides much crisper images in comparison to 40 megahertz coronary imaging catheter. Both axial as well as lateral resolution improves. As far as the stent visibility is concerned, naturally with the help of 60 megahertz catheter, it shows a much clearer resolution confirmation of adequate stent expansion and apposition to the vessel was as seen in these images. The upper sets of images are comparison of visibility of the stent compared to 40 megahertz versus 60 megahertz. And in the lower two images, what we can see here is a side branch origin, and one can clearly see even the adequacy of the side branch ostium and jailed wire in the side branch. With the help of 60 megahertz HDIVs catheter, one can comfortably visualize a large vessels as large as 6 millimeter without sacrificing the image quality. So this picture clearly shows the clarity of the image as far as the large vessel is concerned. And that gives an additional comfort as far as evaluation of the large vessels like left main coronary artery or ectatic coronary artery or positively remodeled vessels assessment, making it much more precise. If you see the comparative assessment with OCT, here there is there are these two images are showing comparison between HDIVs derived image versus OCT derived image, and one can see that the determination of intimal thickness is almost equivalent as far as OCT is concerned and HDIVs is concerned. And this also shows adequacy of the side branch ostia, which can be evaluated easily even with the HDIVs. These are some of the other examples of 60 megahertz images derived from HDIVs. And here is the image which clearly shows the malepposed stent struts between 9 o'clock and 12 o'clock position. Even smaller degrees of malepposition also can be evaluated much more reliably with HDIVs. These are some of the co-registered HDIVs images with optical coherence tomographic images of native and stented coronary artery segments. And one can see not only healthy vessel, but fibrous plaque, a lipidic plaque, the stent struts evaluation when there is malepposition of the stent struts, the calcium behind the surface of the stent struts, as well as the age dissections. They can be reliably inferred, detected with the help of HDIVs. The detection of vulnerable plaque, wherein detection of a thin crepe fibroatheroma has been an important component as far as the assessment of vulnerable plaque is concerned. And HDIVs reliably detects even the thin crepe fibroatheromas with a necrotic core. This is a comparative images showing OCT image versus the HDIVs generated images. Detection of calcification, as we know that the calcium does not allow ultrasound waves to travel far, and therefore the tissues behind the calcific plaque cannot be reliably seen. However, with the help of HDIVs, we can differentially see calcium located near intima and calcium located near the adventitia. Of course, the tissues behind the heavily calcific plaque, a thick plate of calcium, may not be adequately seen. However, the reverberations of the calcium indirectly suggests that yes, the calcium has been superficial. Of course, the thickness of calcium cannot be reliably assessed with the ultrasound, intravascular imaging, with the IVs. However, to a great extent, as far as treatment decisions are being taken, IVs also helps in reliably choosing your tools, how you go ahead with the plaque modification. Extent of plaque burden as judged by IVs is also comparable and reliably assessed as compared to the OCT. Here we can see a significant plaque burden from 9 o'clock to 4 o'clock position, and heavily lipidic plaque is seen over here. Stent strut malepposition between 4 o'clock and 6 o'clock position, again seen reliably with HDIVs, and the images are almost comparable to the CT. And similarly, the extent of malepposed stent and under expansion also can be reliably assessed with HDIVs. Coming to neoatherosclerosis, these are comparative images of assessment of neoatherosclerotic tissue with HDIVUS versus OCT. And one can clearly see in image A dash here, twin layers of stent struts showing stent fracture. Here we can see adequate stent expansion, but there is calcification within the neoatherosclerosis from 1 o'clock to 5 o'clock position. And here one can see a lipidic plaque rupture within the neoatherosclerotic lesions. If we talk about instant restenosis, definitely the optical coherence tomography scores over the HDIVUS, except for the instant restenotic lesions. Majority of other complications can be reliably still detected efficiently with the help of HDIVUS. Image is clearly showing in the intramural hematoma, the component of the intramyocardial bridge, and even the large coronary aneurysm. They all can be detected very easily with the help of HDIVUS. Based on this precision of imaging that as an operator one tends to get access to, if we look into the IVUS 1, 2, 3 essentials, which is based on the pre-stent workflow where we need to establish lesion length and define landing zones, we need to assess plaque morphology and measure the vessel size, and the post-stent workflow wherein we need to look for geographic miss, edge dissection, we need to check for maleposition, and also look for optimal stent expansion. In all of these steps, both pre and post stent workflow, the IVUS has been an essential tool, especially the HDIVUS. If we look into the similarities and differences, there is a very popular slide which shows differences and similarities between IVUS and OCT. And except for tissue protrusions to the stent struts, stent maleposition, some areas wherein the stent edge dissection may be suboptimal, and assessment of neoatherosclerosis, except some of these aspects which are very well assessed with OCT much more reliably as compared to the IVUS. In rest of all parameters, if we see, definitely the intravascular ultrasound with the HD IVUS scores and is comparable to the OCT. So IVUS or OCT, that question always arises as far as employing the coronary imaging in PCI is concerned. So I would say that the better resolution of 10 to 20 microns and intimal surface details at times favors use of OCT. But if you look into the assessment of large vessels like left main, ostial disease, diffuse disease, wherein vessel sizing is very important, and here one needs a better penetration of ultrasound waves to assess them, and therefore in such scenarios the intravascular ultrasound with HDIVUS will score over OCT. If you have to assess stent and under expansion, both imaging modalities are almost equivalent as far as HDIVUS and OCT is concerned. But if you want to assess plaque volume, morphology, and residual plaque burden at stent edges, and when we look for vessel sizing, definitely IVUS scores over OCT. For assessment of calcium, maleposition, and stent fracture, OCT may have a little more edge over IVUS. And assessment of patients with ISR, especially the residual plaque burden at stent edges, and those patients we have impaired GFR, IVUS will have a little edge over optical coherence tomography. As far as neoatherosclerosis is concerned, yes, definitely the OCT will be a better tool as compared to the HDIVUS. Barring all these differences, it is safe to conclude that HDIVUS is essential for certain clinical subgroups. Most importantly, the left main disease, ostial disease, diffuse coronary atherosclerotic burden, those patients with the chronic total occlusion with a proximal cap ambiguity, where deciding the false lumen and true lumen is important, and proximal cap puncture when it is technically demanding. In all those situations, HDIVUS is an essential important tool for the procedural success. And of course, the importance in preserving the contrast load in patients with CKD and in patients with LV dysfunction cannot be overemphasized. So I think in these clinical scenarios, the HDIVUS is going to score over optical coherence tomography and is going to be an essential tool as far as precision angioplasty is concerned. Thank you for the patient hearing.
Sir, you are mute.
So that was the last session before we actually have best intervention case. So we'll have some cases being presented, and then we'll be going globally live across the world for the case-based debates that we do, and the real CardioCon then begins as well. So we'll now have my best intervention case, and the first case is by Dr. Mukesh, mini crush bifurcation angioplasty.
Welcome to CardioCon 2023. I am going to discuss a case of bifurcation angioplasty. In my selective case, this is the mini crushed bifurcation coronary angioplasty. Yeah. Now coming to the case scenario, a 59-year-old gentleman presented with acute coronary syndrome, history of chest pains in 5 days, and he is hypertensive, no history of diabetes, no addictions. Troponin was negative, and ECG showed STT depression in the precordial leads. Echo done, that was showing RWMA in the LAD territory, with the ejection fraction was around 45. Now coming to the angio, there is a very critical stenosis in the proximal LAD across the diagonal, and ostial diagonal was also very tight. So I can say there is, according to the Medina classification, it is a 1-1-1 kind of bifurcation lesions. Other vessels like RC and circumflex were normal. Now coming to the strategy part, what should be done for this patient? We have in coronary angioplasty, in this patient particularly, we have two options. Either we should go for provisional, and the second option is the dedicated double vessel angioplasty, complex angioplasty. Now, before going to that, am I thinking about the simple that provisional stenting or dedicated bifurcation angioplasty? Because does this side branch really need a stent or the protection? Before going to this, we should remember that if the side branch is large enough, or if the side branch comes from the main branch with some acute angle, or if the narrowing, if the side branch is very difficult to be wired, and if the patient is very sick and the side branch appears to be relatively important, in all these categories, we have to think about the bifurcation angioplasty, because the side branch is really important. Because like in this case, in my case, coming in this category, and that shows that 50 to 20% chances of the side branch closure after PCI, maybe because of the spasm, dissection on the plaque shift, but 20% is the big number. So I have selected to do mini crest bifurcation angioplasty. These are the overview of the bifurcation angioplasty, mini crush bifurcation angioplasty, which I am going to show you in a step-by-step manner, and later on I will discuss again same slide. Now I selected a femoral root and chosen a 7 French EBU, selected filter FC wire, and patient was loaded with ticagrelor and the heparin. Now both dilated with 2O balloon, LED first, and after that the diagonal. And this is the pre-dilatation view, but you can see the diagonal ostium is not open yet. So I have taken a bigger balloon, 2.75 into 15, and opened the diagonal ostia well. This is the result after the pre-dilatation of both the vessels. Now coming to the important part, chosen a 2 stent, LED and diagonal, both the stent parked in the respective vessels. LED stent was 3.5 into 18 size, and the diagonal was 2.75 into 18 mm. Now, first I deploy the diagonal stent. I kept a 2 mm stud inside the main vessels in the LED and deploy the diagonal stent almost at 12 atmosphere. After that, I remove diagonal stent balloon and wire all together. Now I have seen that there was no edge dissection or any perforation in the stented vessel. Now coming to the LED part, the diagonal stent was crushed with LED stent, and that was 3.5 into 18 stent, which was deployed at 12 atmosphere. So this was the result after deployment of both the stent, and you can see some residual stenosis there in the diagonal part. So it was first post-dilated with bigger balloon, even though the stent size was 2.75, but I have taken a 3O balloon and post-dilated well. And LED also post-dilated with 3.5 into 10 balloon. And this is the after post-dilatation of both the vessels. Now coming to the final part, that is the final kissing balloon that I have done with 3.5 and 2.75 balloon. And this is the result after the kissing balloon. You can see beautifully open both these stent. And this is the stent view, stent boost images that you can see both the new carina and both the stent proposed very well. And the final, this is the final result after pot. So it was really a good result after dedicated bifurcation angioplasty. So now coming to the whatever I have done, I would like to summarize and explain to you guys so that we can recall what are the steps of the mini crush. After pre-dilatation in both the vessels, I have part both the stent in the respective vessels. This is the A. After that, diagonal stent was deployed. I kept 2-3 studs inside the main vessels and deployed the diagonal stent. In the C, diagonal wire and balloon was removed. In the D, the diagonal stent was crushed with the LED stent. And in the E, the LED was diagonal was rewired. And in the F, diagonal was post-dilated well. In the G, the final kissing balloon. And lastly, this is the final result. So these are the steps of the mini crush, which one can easily remember. Now conclusion. The mini crush technique may be considered a very good refinement of the crush technique. And I was an OCT. I would be happy to do. I was any imaging, but unfortunately that was not there. But really it showed a good result, shown good excellent result in these studies. The application of this technique in the clinical setting of bifurcation lesions proved to be very promising. And the multiple techniques have been developed to effectively treat bifurcation lesions. And each has unique advantage and disadvantage. But I would like to say that you become a master in one technique and rest things will fall automatically. Thank you so much.
So that was the wonderful demonstration of mini crush by Dr. Mukesh Ladda, step by step, simple things. That's why people have moved to doing mini crush more rather than Coulee or a DK crush. Mini crush is easier to do and much long-term results are still being talked about. The DK crush 5 study actually showed better outcomes with DK crush, but then people are talking about mini crush, nano crush, micro crush. With the variations of my mini crush basically. So now we move to the next session where we have another case presented by Dr. Kalpesh Ansora. He's showing a coronary bed preparation with OPN balloon in young coronary artery disease. Over to Dr. Kalpesh.
Hello everyone, myself Dr. Kalpesh Ansora. I'm intervention cardiologist at Sal Hospital, Ahmedabad. So here we are going to discuss about my best intervention case. As all intervention cardiologists are doing the interventions and at one time difficulty in challenging case, we always face the situations. So here we'll discuss about which was the case which I have done a few months back. He was a young boy, 34 years male, and he has presented with the chest pain on exertion since 15 days on and off. We took the ECG, there was no significant STT changes in ECG, and he is having a sinus rhythm. But he had a strong family history of CAD. His father and elder brother had a coronary artery disease, and he has died because of CAD. We performed the echo, which was ejection fraction was 60%. There was no RWF LV. Cholesterol was 140 and LDL was 95. So there was no dyslipidemia and lipid profile. We did the homocysteine, which was more than 50. So he's been diagnosed as a hyperhomocystinemia. We took him for CAG because of the classical angina pain and exertional chest pain. And then we have planned for coronary angiography as he had a significant history of the family history of CAD. The LMCA lesion was normal, LAD lesion was eccentric 80 to 95%, and there was an ostial 80% lesion in diagonal. The rest of the vessels was normal. Here, the angiography picture you can see. In first scenography, there was a tight 85 to 90% eccentric, which was squarely fibrotic in nature, significant lesion in LAD. And in diagonal, it was small to medium-sized vessels. There was ostium involvement of diagonal vessel, which was 80%. So we thought about this is the case of simple angioplasty because the diagonal origin is so far from the lesion. So we have not planned for the bifurcations considered as a bifurcation lesion. So we took him for the PTCA stent to LAD and balloon dilatation to the diagonal. If needs, we'll do the provisional stenting. This was the pre-IOSN we did. It was showing significant narrowing of the coronary blood vessel LAD lesion, and there is the eccentric plaque in mid part of LAD, which was fibrotic in nature. So we have decided to do first PTCA wiring with the Fielder FC routine workhorse wire. We did the wiring and we pre-dilated with 2.5 15 millimeter NC track balloon. As we were knowing that it was fibrotic in nature, so we did the we had go ahead with the more aggressive dilatations to match the exactly size of the vessels and pre-dilatation balloon. But after that, we have noticed that the patients had a chest pain after dilating the main LAD lesion. When we checked, there was significant narrowing, or there was a plaque shift in diagonal vessels. So patient had a chest pain on table, and there is small fall on blood pressure, and there was a significant changes in ECG. So what we have done, we have wired the diagonal vessels also, and we have dilated with 1.5 with a 10 millimeter of semi-compliant balloon, and we re-established the flow in diagonal vessels. Here you can see there was a dissection in mid LAD lesion. So itself is showing that still the plaque has not that much modified with even NC balloon. So again, we took another NC track balloon. This was the 3.5 15 millimeter NC track balloon. We have tried to dilate it as maximum pressure 22 atmosphere, but the waste was not disappearing. So there was tight fibrotic lesion. And as we all know, that if you leave this kind of vessel and if you put a stent, there is a high chances of the stent thrombosis as well as the in-stent restenosis in future, and stent remains underexpanded. So there was a dissection, and there was the lesion was not modified and not break with the NC track balloon. So what is next? So we thought of the doing rotablation, but patient had already had a dissection in mid LAD. The rotablation was not available at that time. So the second, we thought of the IVL balloon, but the patients having some financial concerns, we cannot use the IVL balloon. Then we took the OPN balloon, as we know that this is the high pressure balloon. Commonly we use the OPN balloon in a post PTCA after stenting for the post dilatation to expand the stent. But in this case, because of the fibrotic nature of plaque, we have used this 3.5 10 milliliter balloon, OPN balloon, to break this fibrotic lesion. We have dilated up to 30 millimeter of atmosphere, 30 millimeter atmosphere, but still we could not able to break the lesion. But same time, patient again had a chest pain, and he started having a fall in blood pressures, and there was some ECG changes. So when I checked the angio, there was a long dissection from mid LAD to the distal part of LAD. So I thought to put a stent directly into the LAD and then see what happens. So that time I could not able to save the cine angiography of that dissected part. So we directly took the stent that was 3.5 into 40 millimeter SR summit. So you can see here there is a nasty dissection in the mid part of the LAD, which was flow limiting. We deployed the stent at 14 atmosphere. That was 3.5 into 40 millimeter. After that, the patients stabilized as the flow is re-established. But we have noticed that the stent has not expanded at the tight mid LAD part where the lesion was tight. So again, we have decided to post dilate with the same OPN balloon, which was available, which has been used with the pre-dilatation. So 3.5 into 10 millimeter dilated with 35 atmosphere. So again, repeatedly, we have given almost 3 to 4 times dilatation up to 35 atmosphere, and we have went to up to 40 millimeter. But still there was some residual expansion, under expansion in mid-LAD part we have noticed. So after this dilatation, we have asked for the IVUS run, because if there is under expansion, we can go more aggressively. So after that, we did the IVUS. So this is the before angiography, before IVUS run. This was the results post dilatations. There was some residual amount of the under expansion of stent at mid part, but overall flow was good. Expansion, diagonal flow was good, and diagonal lesion was not that much significant. Then we did the IVUS run. This is IVUS run, which was showing a good expanded stent at mid LAD, and there was the good apposition with the vessel wall. There was some amount of the under expansion in mid part. Here we can see. Otherwise, the stent was well apposed and well expanded throughout the vessel. So this was IVUS run. The stent was good. There was no residual dissection, and then this was the final shot we took. And so ultimately we did the PTC stenting, and we have pre-dilated with the OPN balloon pre and post. So take-home message is always use IVUS imaging or OCT imaging to decide the morphology of leg, so you can plan for the bed preparation before stenting. And OPN balloon, we know that it's high pressure balloon and it's unique technology, that twin layer technology used to break fibrotic lesion, and also useful for the post dilatation in under expanded stent to prevent the further mesh and the in-stent restenosis in future. Thank you.
So that was a good demonstration of use of high pressure balloon technique for dilatation and bed preparation. So age may be very deceptive. You may have a lesion which may not be so easy to give, and your NC balloons may not be adequate enough to prepare. So after that, I now invite Dr. Jignesh Patel. He is an interventional cardiologist at Sal Hospital. He is going to demonstrate his case of long segment RCA CT or PCI transradially done. Over to Dr. Jignesh.
Hello everyone, I am Dr. Jignesh Patel, practicing at the Sal Hospital, Ahmedabad as an interventional cardiologist. So as a toughest case, I am going to present the very bad looking CTO lesion PCI through the radial route. This is really very tough for me because this case I did in my first year of the interventional cardiology practice at the Sal Hospital. So I am presenting this today. This is the patient profile. Patient was a 66-year male patient having history of the infeasible MI around 5 years back. Now he came with the symptoms of rest angina, and echo was showing the severe LV dysfunction with the infraposterior hypokinesia. And we did an angiography which showed the double vessel disease. Circumflex was non-dominant, showing 80% lesion at the origin of OM, and dominant RCA showed 80% lesion at the proximal part, followed by the long segment CTO from mid to distal RCA up to the crux. And the distal RCA, PDA, PLV was filling by retrograde collaterals from the septals of the LAD. So this was the case scenario, and I will go through the angiographic videos. So this is the left system. Left angiogram, left corner is showing some minor disease at the proximal LAD, and circumflex is non-dominant. And it shows there is some around 40-50% lesion at the proximal part of the circumflex, followed by there is some diffuse plaque before the OM, followed by the critical 80% lesion just at the origin of the OM. This is the circumflex artery, and LAD is showing some minor disease at the proximal part. Now coming to the right coronary angiography, here you can see that RCA has some around 80% lesion at the proximal part, followed by long segment CTO right from the mid segment just at the origin of the RV branch. Such kind of the CTO lesion are really very difficult to negotiate because the CTO lesion when there is a CTO lesion at the origin of the RV branch, it will be really difficult to pass wire beyond that CTO segment cap, because every time you want to every time you want to pass the wire in the CTO cap, it will go into the RV branch. So it will be really very difficult to negotiate such kind of the lesion. Here you can see that this case was started at around 12:40 p.m. and it took almost more than 40 minutes or 45 minutes to pierce the cap of the CTO segment. So what we did, initially I took a JR, and definitely the JR, we know that in CTO segment, it will not give a much support. So the considering and taking to consider the better catheters is really very important. Here we changed the guide to the M+ guide. Here we can see that we took M+, which will give a better support as compared to JR. Initially we took a Fielder XT wire. We were not able to negotiate the CTO lesion with the Fielder XT wire. So I changed it to the Gaia 2 wire with the help of the microcatheter. Here we can see that there is some black dot here. That is a microcatheter, and through which we passed the Gaia 2 wire, and we were able to pierce the cap of the CTO segment. Here we can see that RV branch is here coming here, and the CTO was beginning right at the beginning of the origin of the RV branch. So with the help of the microcatheter and with the stiff wire like Gaia 2, I was able to pierce the cap of this CTO segment. And after that, gradually we advanced the wire till the distal RCA. Here we can see that we advanced the wire distally with the help of the microcatheter in the next 20 minutes. As we are using the hard wire here, we cannot manipulate the wire just like the floppy wires, because there is always a chance of the perforation in such kind of the patients. So we have to be very careful while manipulating the hard wires in the coronaries, because it may give a tremendous emergency conditions like cardiac tamponade if there is a perforation of the coronary arteries. So we took another contralateral puncture in the left radial artery. We take a angiography of the left coronaries with help of the tiger from the left radial root, and we showed that there are collaterals coming from the left coronaries which are filling the LAD, which are filling the distal RCA, PDA, and PLV. Here we can see that there is a collaterals around 8 collaterals, and that confirm the position of the my Gaia 2 wire is in the true lumen. So this is really very important, that if it is in the false lumen, then if you pre-dilate such lesions, it will give a bad dissection, and sometimes it may cause a perforation as well. So this step is really very important, that we confirm the position of the wire is in a true lumen with help of the contralateral injection and showing that it's definitely in the true lumen. So after that, we pre-dilated the lesion. As the lesion was really very hard, CTO segment was really very hard, and the MI was of 5 years old. So you can imagine that how hard was the lesion. So even we were not able to pass the 1.0 Banul initially through the CTO segment. So what we did that, I deeply intubated the M+ catheter into the RCA. First, I inflated the 1.0 balloon in the proximal part till whatever part we were able to go into the RCA. And then we inflated the balloon. With help of the inflated balloon, I deeply intubated the M+ catheter till the proximal to mid part of the RCA. So that will give a support while pushing the balloon into the RCA. So here you can see that the AR is deeply intubated into the RCA. Followed by that, I was able to pass the 1.0 balloon up to the distal RCA. Then I did a pre-dilatation with a 1.0 balloon, followed by sequential pre-dilatation with the 1.5, followed by the 2.0 millimeter balloon. Here you can see that in this right angiogram, here you can see that this was after the pre-dilatation with the 2.0 balloon. There was a long lesion right from the beginning, from the proximal segment up to the distal RCA. So imagine, you can imagine that how hard was the lesion. And after that, and alternatively, if you cannot intubate the RCA, there is always a risk of the dissection with deep intubation of the M+. You can use a guide liner as well, and that will definitely give a support while passing the balloon in such lesions, difficult looking lesions. And after that, I took a stent. Here you can see that there are two markers, right? First from the mid to distal RCA, the stent was 2.5 millimeter by 40 millimeter. That was a Resser CC stent, 2.5 by 40 millimeter. From the mid to distal RCA, I inflated the stent from the mid to distal RCA. This is the stent mid to distal RCA. It is well inflated. And after that, we took another stent from proximal to mid RCA. That was 2.75 into 36 millimeter stent, SRCC. And this is after the inflation of the second stent, view after the inflation of the second stent. And after that, I post-dilated with the 3.0 millimeter balloon at the high pressure at 18 atmosphere from distal to proximal RCA. And this was the final result. Here you can see that the RCA is quite nicely open right from the beginning, from the proximal to distal RCA. There is no any angiography showing, there is no any dissection or any perforation or any edge dissection as well. So this was the case of the RCA CTO lesion, and this was done through the right radial artery route. And we took a contralateral injection again with the left radial route only. So we didn't use a femoral route in this particular case. So now coming to the circumflex lesion, circumflex was not that bad lesion. Here you can see that I already showed the left coronary angiography. There was a significant critical lesion at the origin of the OM. We pre-dilated, then we put a stent 2.75 millimeter into 40 millimeter stent from proximal to distal circ, and this is the final result. And this is the final result. That was after the post dilatation with the 3.0 millimeter balloon. And we did a follow-up of this patient after 6 months. We did a 2D echo after 6 months after the PCI, and we showed that ejection fraction improved from the 25% to moderate LV dysfunction. The last when I did a follow-up of this patient, ejection fraction was around 40 to 45. So after doing a CTO lesion, there was a significant improvement in the ejection fraction as well. So what are the take-home message? So femoral route is always definitely a preferable route while doing CTO lesion, because it will give a better support and all that. Another thing is that you can even do the CTO lesion through radial route also, as we did in this particular case. And the proper selection of the guiding catheter is really very important to provide the adequate support. So without support, we will not be able to pass the wire or even a balloon after passing the wire. So the selection with a proper support guiding catheter is really very important. Particularly the implant will give a better support in such kind of the lesion, particularly in the right coronary arteries. Now coming to the second thing, that always take a contralateral injection if there is a retrograde filling by collaterals is there, because that will confirm the position of the wire in the tube lumen, and that will avoid the perforation or dissection and such things and other complications. And another important thing is always use a micro catheter. That will definitely help in passing the wire, piercing the cap at the right position, and to avoid going into the false lumen. So help of the micro catheter is really very important in such patients. And another thing, if you are not getting enough support, there is always a benefit of using a guide liner or guide plus. So this such kind of the materials are really very helpful while doing such kind of the CTO lesions. And lastly, the most important thing and the primary need is patience. Patience is really very important in such kind of the chronic lesions, because without patience, if you try for a few minutes, like 5 or 10 minutes, you are not able to pass a wire, then definitely you are going to defer a patient. But here in this particular case, I was able to pierce the cap of the CTO lesion after 45 minutes. So the patience is really very important while doing the CTO angioplasties. Thanks.
So that was wonderful demonstration of a CTO. And now we move to the remaining last 2 lectures of best case demonstrations that we have today. Next is the other extreme of it. Dr. Prashant is going to talk about an interventionist nightmare and how he managed it. So what to Dr. Prashant? He's an interventional cardiologist at Sal Hospital.
Hello everyone, I am Dr. Prashant Vazirani, interventional cardiologist from Ahmedabad, and today I am going to share with you an interventional case from my archives. So it was a nightmare for me in the cath lab when I was doing my simple case. So let us begin. It was 61 years female, a Mahayojana beneficiary. She was hypertensive, diabetic, controlled. She had shoulder pain, chest pain, and dyspnea on exertion since 15 days. She was seen by a physician and was diagnosed as CAD unstable angina, as her ECG had showed valence pattern, and she was referred for a CAG. So incidentally, this patient was referred to me by my father. So he was the referring physician actually. And on echo, there was no RWMA and EF was normal, 65%, pre-angio was normal. So coming to the angiography, so as you can see, the osteoproximal portion of the LAD has a critical lesion. And the mid LAD, if I can run this for you, yeah. So the mid LAD also has a tight lesion and a small diagonal which is coming out from there. And this is another aleocaudal spider view for you to show the osteoproximal part of the LAD which has the lesion. Another cranial view showing the tight mid LAD limit to distal LAD lesion. This is another view showing the same tight lesion in the caudal view. Coming to the RCA did not have much disease, just a mild plaque in the proximal to mid portion. Another view of the RCA showing that it did not have much of the disease. So she was advised a single vessel disease, PTCA to LAD 2DS, and was posted for plasty after the approval. So the plasty was taken up for plasty in the evening after the approval came. She was loaded with routinely, like we do for our all myasthenia cases, prasugrel, aspirin, and atorvastatin. So it was a radial route, and iboguide 3.5 was taken. The wire used was filter FC, and for pre-dilatation I used a 215 Apollo NC at 12 to 14 atmospheric pressures. Similarly, the proximal, after the mid LAD lesion, the proximal osteoproximal portion of the lesion was also dilated. And after that, 215 2.5 by 18 millimeter drug-eluting stent was placed in the mid LAD. And as you can, if you can see very closely, the mid portion of where the lesion was, the stent has not expanded very properly. So post dilatation was done by a 2.5 12 millimeter NC balloon at 16 to 18 atmospheric pressures initially, and then it was gradually done at higher pressures at around 18 to 20 atmospheric pressures for around 2 times. And when I was doing for the 3rd time the post dilatation, a patient complained of severe chest pain and became visibly uneasy. So a check shoot at that time revealed this. So as you can see, there was a grade 3 perforation at the site of the where the stent was placed and where the post dilatation was done. And you can clearly see that it is a grade 3 perforation. The dye is filling up the pericardial cavity. So although every time it is said that you should not panic, but of course there was a panic in the cath lab at this time. So the same 2.5 and 12 NC balloon which was used for post dilatation, which was in the guide, it was advanced and inflated at 4 atmospheric pressures for 5 minutes initially. And half dose protamine for heparin reversal was done, that is 20 milligrams was given. A backup call was done for my colleague because a helping hand is always better, and a blood bank was notified. So initially the same balloon which was in my guide, it was advanced and inflated at 4 to 6 atmospheric pressures for 5 minutes, and then gradually the time of duration of inflation was increased from 10 minutes to 15 minutes because the patient was not able to tolerate the ischemia because of the occluded balloon. So this is showing that the balloon has occluded the segment, and it was done for 3 to 4 times, but still the perforation, it remained. And then patient went into suddenly a tamponade. So an emergency paracentesis was done by me and a pigtail was introduced. And the patient had stabilized immediately after this emergency pericardiocentesis. There was no autologous transfusion was done. IV fluid bolus and NORAD support was initiated, and she was sedated electively and also intubated so as to she can tolerate prolonged balloon inflations, because 10 minutes she was tolerating and then I had to deflate. So I wanted to try longer balloon inflations of 15 minutes at 8 atmospheric pressures. So after sedating her, we tried another longer balloon inflations of 15 minutes. But after that also the perforation was not sealing, and we did not have, unfortunately, we did not have graft master with us at that moment in the cath lab, and neither any other vicinity cath lab had it in an urgency. So rather we thought that waiting for a graft, we can use another drug-eluting stent, which is advised in the guidelines. Sometimes it can be used. So we overlapped it with another drug-eluting stent, 24 millimeter at 12 atmospheric pressure, in the hope that it might seal the perforation. And to benefit the perforation. This, as you can see, the perforation had sealed off with the second drug-eluting stent. And then we thought that proximal osteoproximal lesion, which is also critical, that should also be tackled with. So 3 by 21 millimeter DES was inflated at 12 to 14 atmospheric pressure, and the procedure was then completed with a post dilatation at 16 to 18 atmospheric pressure with a 3.5 NC balloon. So this is the result. Proximal and the perforation has completely sealed off now. So she had required 3 stents. Mid-LAD was sealed with 2 stents, and the proximal osteoproximal lesion required 1 stent. So post-op, patient was stable. She was kept on DAPT, off heparin and off inotropes. ACT at 30 minutes was around 150, so no further protamine was given. And repeat HB was 11, so no blood transfusion was given. Pigtail was removed next day morning, and because she had no further accumulations on echo. Patient did well and was discharged the next day. Last follow-up with the patient was 10 months back, and she is doing well. So this is how type 3 perforation should be managed. Initially, when there is hemodynamic instability, immediately you should advance the post-op balloon which you have used, and you should be ready for all the your things for a pericardiocentesis, a femoral line, and then you can either use a cover stent, which is advised. If you don't have it, unfortunately, then you can use a drug-eluting or a BMS stent, whatever is available. And if it does not seal, then you can even use another drug-eluting stent or a covered stent. And then after that, the only option is a surgery. So take home is that whether the proper lesion preparation or more aggressive pre-dilatation, might have avoided the perforation, because I would not have gone to higher post-dilatation pressures. And the cornerstone of the treatment is to maintain the guide wire position and control of bleeding with low pressure balloon inflations across the perforations. A second helping hand mind is always desirable, so never hesitate to call for help. Always check your CAT store for adequate materials prior to the procedure, like we did not have cover stent for this case. Complete reversal of anticoagulation is not desirable at all, and it should not be done. Half-dose reversal is still questionable. Surgery carries a very high mortality and should be the last resort after all your options have been exhausted, and try to fix the mess in the cath lab as far as possible. Thank you.
So that's how you salvage a perforation, the graft master, prolonged inflation, coils, distal perforation. Those are the techniques. And of course, now stent in stent and maybe one more stent. That's how some people do. But that's not the long-term good strategy. But I think it worked very well for Dr. Prashant. So we move to the last of the cases. This is an EP case. Dr. Chirayu is going to present one of his best EP cases. He's an electrophysiologist. Over to Dr. Chirayu.
Hello everyone, myself Dr. Chirayu Vyas. This is one of a electrophysiology case which in the last year I'm presenting, which was one of my best experiences as to the surface ECG, which was showing a typical morphology of a tachycardia, which when assessed properly gave a very good result and an outcome of my electrophysiology EP study RFA case, which helped the patient very nicely. Starting with the case, this was the ECG with which the patient had presented a very, very fast tachycardia, which apparently was projected on ECG as a most likely as a ventricular tachycardia, a VT, most likely in origin. And this is what, once the patient had presented with pre-syncope and a systolic blood pressure of 90 millimeters of mercury, the patient was given a DC shock and was referred to me and sent to me from a hospital outside for conducting electrophysiology study, EP study and RFA. And that too also very interesting. Just we'll go for the next slide, which is what we'll just realize the facts. That this was looking like some ventricular tachycardia at around 240 beats per minute, was sent to me for an EP study RFA, but most importantly, utilizing the government scheme Ayushman Bharat Yojana at the private corporate hospital, which has got the attachment for this purpose and has also got the machinery for this purpose. It initially looked impossible, if at all, if it turned out as a ventricular tachycardia on a two-dimensional mapping system, which is what is available in the such a kind of government scheme, Ayushman Bharat Yojana. The patient was actually a 36-year-old male with no past history of an acute coronary syndrome, ACS. There was no structural heart disease with an LV ejection fraction of 60 to 65% on two-dimensional echo. A prior resting electrocardiogram ECG was in sinus rhythm with insignificant ST segment changes. And that's why this course was taken up for an electrophysiology EP study plus radiofrequency ablation RFAS treatment in a two-dimensional mapping system at the corporate hospital, which is enrolled with the Ayushman Bharat Yojana scheme at Ahmedabad. And the most important reason for this criteria was the one which got it differentiated this wide QRS tachycardia as a SVT, supraventricular tachycardia with aberrancy. And that is what was a typical criterion which helped us in deciding this case, taking up for an electrophysiology EP study and RFA in Ayushman Bharat Yojana. This is what we conducted in the operation theater, taking the femoral artery and the vein from the groin and putting the catheters from there after applying local anesthesia. And on the fluoroscopy screen, we just put the catheters at the right locations according to the signals which were picked up on the electrophysiology mapping system. And once we picked up the abnormal electrical circuit, which was causing the supraventricular tachycardia with aberrancy, this is what we just treated by giving radiofrequency ablation RFA and got the patient treated completely. Actually, just a basic in terms of how to do an electrophysiology study, this is what would show in the diagram as to the four chambers of the heart: the right atrium, the right ventricle, left atrium, and the left ventricle, which is where the typical catheter locations as shown by the arrows, those are in usually the high right atrium HRA, then in the His bundle location, the His catheter, and at the right ventricular apical location, which is what these three are the main catheters which are used for the diagnostic electrophysiology study to study the origin of the arrhythmia and the pattern with which it is conducting. This arrhythmia, which was shown in the earlier ECG, it turned out as a right posterior accessory pathway with minimal pre-excitation on a resting surface electrocardiogram, which is what would be called as a Wolff-Parkinson-White WPW syndrome, with an inducible orthodromic atrioventricular re-entrant tachycardia, antidromic also the ART-AVRT was ablated by radiofrequency current at the posterior tricuspid location of the tricuspid valve annulus. Documentation of the removal of the bypass tract was done by checking a ventricular atrial conduction block in the presence of a right ventricular pacing, as well as blocking the AV node simultaneously with giving of an injection adenosine. This is what will be shown in the further slides. This is the slide which is depicting the surface ECG in the first 6 columns, lead 1, 2, 3, AVF, V1 and V6, which are what are showing the same kind of arrhythmia which was shown in the first ECG at actually a higher speed. And importantly, the signals below are being shown in the intracardiac electrogram. The coronary sinus CS910, CS78, CS56, CS34. These are the electrodes which are from proximal to distal from 910 to 12. So 12 is the distal most tip of the catheter and 910 are the proximal most catheter electrode locations inside the coronary sinus, which is actually mapping the left atrium. The next channels are his distal and his proximal. This is what quadripolar catheter is put in the right ventricle, which is what is assessing the ventriculogram. Along with that, the MAPD and the MAPU are the ablation catheter signals, which are just deciding as to at what point are we going to give the radio frequency current. This was the arrhythmia which ultimately got diagnosed as an antidromic re-entrant tachycardia, AVRT, induced by the right posterior accessory pathway. And these are the signals, which is what, if you can see in the prior ECG, there was 1:1 ventricular atrial conduction. If you just see the prior ECG, every wide QRS at the top is followed by a CS signal, which is what is actually the atrial signal. So every ventriculogram which was being paced pathway according to the presence of a ventricular atrial conduction block, which means the removal of the accessory pathway. That is what the patient got treated. And this was the ECG at end. The patient was discharged the next day in a normal surface ECG. So what we need to learn about this? This is what is the basic thing which I just wanted to project. That was a very, very interesting criterion in terms of an R wave peak time, RWPT, in lead 2 in a wide QRS tachycardia, which was considered as a new criterion for differentiating between wide QRS complex tachycardia. 2010, in onset of R wave to the small, just a small duration, but it did achieve a small positive peak. This is what was the peak of the positive R wave in the QRS, which is predominantly negative, but the initial very minimal positivity was what was very important. And the onset of this QRS complex to the peak of that small R wave was called as RWPT, R wave peak time, which is what, when calculated in this lead 2, was pointed out to be around maybe 50 to 60 milliseconds at maximum, which is what is the classical criteria, that if at all, if it is less than 50 milliseconds, this is what classifies it under the definition of supraventricular tachycardia with apparent conduction, which is what it turned out to be even on electrophysiology EP study. And considering that as a dangerous ventricular tachycardia VT, the procedure was not abandoned and was done even in a corporate hospital in the Ayushman Bharat Yojana government scheme, which is what got the patient treated permanently. Okay, thank you.
So that was the interesting EP case that Dr. Chirayu just mentioned. Now we will have the session ending in next 10 minutes. We will be starting our bouts and debates. The first one is going to be on cardiac rehab. So before I start and take you through those things, there are a couple of the cardiacon that we are going to do in over these next 1.5 days. Number one, we have been granted 8 GMC credit hours, and that's the news, but that's 4 per day. So if you log in only for 1 day, you'll get 4 credit hours. If you log in on second day, then only you will be getting another 4. It's not that 1 day attendance would get you all. And then you need to attend the number of sessions, because hours are measured in number of sessions. Other thing is, we are going Cardiacon Global. So global is that we are connecting to our global leaders in their practices and taking lessons and learnings and their viewpoints from our international friends who tell us and get us to know what are the latest guidelines and management strategies in the debate. Also, we have a quiz. So what we are going to do is that after each session, each bout, once it is over, that means all the 3 speakers say next session is going to be on cardiac rehab. So once all the 3 sessions are done and the panel discussion is over and the take-home message is delivered by the panelists, the chairpersons and the moderators, then we would have that quiz which is being flashed. And that quiz question is open to all our participants. So everybody can participate all across the spectrum. This is being streamed live globally on Twitter, and trending on Twitter. It's been done live also on a YouTube channel, also on the e-page of Cardiocon. It's also being on the link of the RX events. Also, it's on RX TV. It's also being transmitted with our another marketing channel partner, which is Medflix. So there are multiple platforms. So everybody can participate in this quiz on the link of the delegate or the faculty link that has been shared with each of you. So once you go into that link, the question is being flashed, and that question will be a multiple choice question. You have +4 marks for a correct, 1 mark for right answer, 0 mark for a wrong one. So you need to just attempt. And so we have 25 next 2 days. And so these questions, tomorrow being an in-person meeting, these questions would be only available on app, though the session is in person. Once you start playing those questions along, in the end, all the 20. So the tie is going to be decided by the time taken to submit your answer. So there'll be total marks and total time taken for that score is going to differentiate the top rankers. So the other interesting thing is that if you really want to attempt majority of the questions, you'll be shuffling between 2 halls. So that's how we are able to balance it out or not is also going to be very interesting, because there'll be quiz happening in hall A and on hall B. And so that's why you need to be very tech savvy, that you are always logged in, either physically in-person meeting or through virtually for the quiz sake, and are able to attempt and answer the question. So this has been like Fifth year, we have been able to promote science in new format where we talk about medical science with the two different aspects of management. And Cardiocon has been able to deliver that message that medical science, unlike mathematics, it need not be 1 + 1 always 2. In medical science, you have choices, options, and depending on the clinical scenario, the patient, and the available therapies, you have to choose your right clinical judgment based on the guidelines and acumen to choose the therapy that you think is the most appropriate for that particular case. So what would be a therapy for a patient X, even if he is a duplicate clone of the same patient with a slightly different clinical scenario, the therapy would be different. And that's what we are headed for as a personalized medicines. So people tell that what will happen once the cardio robos will come in, will the doctors become outdated? No, because the clinical judgment algorithms, whatever you may fit in, doctors, clinical acumen in choosing between the therapies, juggling between them, and be able to appropriately analyze as to how the new guidelines versus the clinical scenario fits in will always be different for even two genetically cloned similar diseased patients. So from genetically driven therapies, you need to evolve to personalized medicine. And for that to happen, you'll have to look at the overall clinical scenario of the patient along with the current existing guidelines. So each case debate that I have created personally over last 3 months, it's not that I end up with this in a week or so. Every case bout, I go and dig out the guidelines. Where does each of these therapy actually hold a ground? It should not be a case where the therapy has no place and I can still talk about and create a debate. Debate would be when the therapy has some role and the case has to be borderline, because if I was to debate whether to give SGLT2 or DPP4 in a overt heart failure, there is no debate. Same way, if I was to say left main triple vessel, elderly, 60-year-old, multiple lesions, syntax score bad, and I want to do angioplasty, again, there is no debate. But if I have a young patient who doesn't have diabetes and has a low syntax score, can I choose PCI? Yes, because guidelines also tell you for the same, for the triple vessel disease as class 2A, and CABG, of course, they say as class 1. And then we talk out and try to debate it out and bring out how the guidelines can be utilized and implemented in practices. So what we have done and which we have been doing previously, and as we have learned over the last 4 years, that the debate formats also need to have a platform of discussion more than just the debates. And this time what we have done, that we have increased the time of discussion, where we call it as things to learn or take home messages for our chairpersons and to our moderators to be delivering the same to our audiences as to what goes on to be presented for the same. So we will be now, we have all eminent faculties joining us here with us, and we will be looking forward to have the sessions rolling in. We still have 5 minutes. So this is Hall B. You also have Hall A going on, the Eindhoven Hall, where the things are still rolling in. We are going to move to the Hall A, which is the Hall B, which is the Gruentzig Hall, which is where we are right now. There are sessions happening, which are the pre-recorded sessions at Hall A today. The Hall B has now at 5:30 onwards, we are going live. So this is what we have, still got some time, but we have elite panelists with us, elite professors with us. Dr. B.D. Makad sir, good evening. Dr. Mahadev bhai, good evening. I have my friend Dr. Shilpi joining from Kyrgyzstan. She's also an interventional cardiologist, but she preaches and practices a lot of cardiac rehabilitation. I also have with me Dr. Alap Shah, owner of big chains of Mission Health, rehabilitative cardiac centers. It was a pleasure to be teaching him when I was assistant professor in medicine. I remember Alap doing his physiotherapy those days, and probably the first batch, Alap, correct me if I'm wrong, you were the first batch of NHL. Suyash and Gaurav have been my assistant professor. Dr. Shweta Nagar is a good dietitian that I rely upon. She's also here with us.
We have an elite panel joining us here with us. And so we still have a couple of minutes before we move on to the session. I hand over the session to our chairperson. I think we have enough time to actually discuss out and present the case to the audiences. I think we still have a couple of minutes, but I think we can start early so that we can maintain time. So this is the bout 7. 6 bouts are already over in today's pre-recorded formats. This is a 39-year-old male who presented with ACS and underwent successful PCI to right coronary artery, and his lipids show triglyceride of 212, HDL 33, LDL 111, already on 20 milligram rosuvastatin, and he has history of COVID 1 year back. A lot of people wonder whether long COVID actually ends up doing this to them. Apart from optimal guideline-directed therapy, the most important aspect of lifestyle modification is what we're going to look at. We'll for the session, I have following chairpersons: Dr. B.D. Makad, Dr. Gaurav Singh, Dr. Ashish Mishra, and Dr. Suyash. Dr. Gaurav and Dr. Suyash are from Indore. Dr. Ashish Mishra is from Mumbai. Dr. Mittal Prajapati is with us. She is a cardiac rehabilitator and physiotherapist as well with us. And Dr. Shweta is a dietitian, and Dr. Poonam is dietitian with us at UN Mehta. So I invite our chairpersons to take over. Dr. B.D. Makad. So we are looking at yoga, modern cardiac rehab in terms of either we are looking at pharmacotherapy, behavior therapy, education, smoking cessation, exercise, diet, cardiac rehab, all types of yoga and pranayam. That's the aspect that we are looking at. We are intending to learn yoga and cardiac rehab and role of home-based supervised cardiac rehab versus institutional cardiac rehab. We also will have Dr. Srirang Trivedi, who's a cardiac physiotherapist, joining us for the session. These are our chairpersons, as I already mentioned, and these are our moderators. So over to chairpersons to introduce our speakers. Makad sir, you're muted. You need to unmute. So you're muted.
Am I audible?
Yes, now you're audible, sir.
Yeah. Good evening, all of you. See, Dr. Kamal already has given you scenario, very peculiar one. Nowadays, we come across very young people coming out with coronary artery disease, and they are in their prime lifetime where they have to live very active life. And there are lots of questions. And what I should do, what I should not do, can I have my sexual life, whether I can run, do exercise, and then difficult. Even it's very easy to say as a doctor, but the person who is patient, he has lots of questions. And I think a person who is quite young, he has undergone right coronary angioplasty, and he has got dyslipidemia, and he needs to be addressed many questions. And I think we have got Dr. Alap Shah, who is a very eminent physiotherapist, and he would be rather delivering the lectures. We have got other as well. May I request now Dr. Alap Shah?
So we have timer on display, and each speaker is allotted 10 minutes here so that we can have discussion of another 10 minutes. I request all the speakers to stick to time. Dr. Alap, over to you.
Yeah, good evening, everyone. Good evening, respected Kamal Sharma sir, Dr. Makad sir, and eminent journalist. Sir, you were indeed our teacher, and you inspired us throughout our college journey as a professor. The case shared today is so ACS, PCI 7 days back, and cardiac rehabilitation. 39-year-old male had presented with ACS for which he underwent successful PCI to RCS 7 days back. He had dyslipidemia. He is on rosuvastatin and GDMT, and scientific and only supervised cardiac rehabilitation is the most time-tested and proven methodology for the ACS PCI to RCI 7 days back. Most important is keeping his acuteness and fragility of the whole condition in mind. Cardiac rehabilitation is the customized outpatient program of exercise and education. The program is designed to help improve the health and recover from heart attack, other forms of heart disease or surgery. Over a period of years, it has evolved from simple physical activity to a complete multidisciplinary approach where cardiologists, physicians, physiotherapists, nutritionists, exercise physiologists, psychologists, and yoga, entire team of multidisciplinary approach is involved in the overall care of rehabilitation. And in a particular case, and otherwise we would categorically divide into three parts. One is the primary prevention for a person having hypertension, diabetes, dyslipidemia, or a secondary prevention post myocardial, conservatively treated myocardial infarction, or PTCA, or CABG, or any other cardiac procedures. And third condition, which is now talked a lot, prehabilitation, where before undergoing any major surgery or major medical condition, person is prepared for the cardiac rehabilitation purpose. In most current guidelines of cardiovascular societies worldwide, cardiac rehabilitation is a class 1 recommendation. Clinical trials have proven the strategies for the detection, rehabilitation, and modification factors which can slow, stabilize, or even modestly reverse the progression of atherosclerosis and reduce the risk of cardiovascular events. Cardiac rehabilitation programs have become now integral part of standard of care in the modern cardiology. In recent time, the development of structured and supervised cardiac rehabilitation program grew out of concerns mainly about the safety of unsupervised exercise in patients with acute coronary events. If we recall the journey of incidents that we have seen over a period of last 1 or 2 years, we have seen so many celebrities, Siddharth Veer Suryavanshi at 46, collapse in the gym, Sagar Pandey, 50-year male, Raju Srivastav, Puneet Rajkumar at 46 was working out in the gym in the Bangalore and he expired, and many such known or unknown stories we have come across. Cardiac rehabilitation with supervision and programmed exercise is utmost importance to reduce the mortality rate, and it will consist of a journey where there will be a thorough physical assessment, cardiopulmonary fitness testing, prescription of exercise training, monitoring the vitals during exercise, emotional support, education about lifestyle changes like healthy diet, maintaining healthy lifestyle, quit smoking, etc. So technically it will be divided into 3 phases. One is inpatient, outpatient, and then long-term maintenance plan. Consistent 4 things will be major classification: exercise, nutrition, stress management, and lifestyle modification. But overall, assessment will play a vital role before beginning any program, and then there will be problem-oriented programs and solutions like blood pressure management, dyslipidemia management, diabetic management, lifestyle, tobacco cessation. Most important of all, here we are talking of physical activity and exercise planning along with nutrition planning. So research says that scientific data clearly establishes the exercise training results in improvement in exercise tolerance. Appropriately prescribed and conducted exercise training, therefore, is a key component of cardiac rehabilitation. Mayers et al. 2002 showed that an improvement of 1 MET in functional capacity imparts 12% reduction in all-cause mortality. More recently, Jolly et al. In 2011 showed the abnormal heart rate recovery, which is predicted mortality, can be normalized with exercise training with an improvement in mortality. Now, in specific cases like heart attack, congenital heart disease, post-PTCA, post-bypass, post-transplants, we would recommend supervised cardiac rehabilitation for the initial time, and then it can be managed independently in the long term. And these are the contraindication: unstable angina, arrhythmias, pulmonary hypertension, presence of thrombus, or severe obstructive cardiomyopathies, which was thought as many of the celebrities who died at young age in working out. The panel of medical people across the country have cited one of the reasons as hypertrophic obstructive cardiomyopathy. They did vigorous resistance training, and they were not aware about probably on their normal systolic or diastolic pressure also, and their resistance training went beyond imagination without any possible monitoring patterns. So our goal for a particular patient and otherwise will be to improve heart functioning with safety, to regain strength, endurance with safety, to prevent condition from worsening, to improve health and quality of life, and to reduce risk for future heart problems. So most of the time when we talk of cardiac rehabilitation, heart rate or Carbon's formula or maximum heart rate or target heart rate is one of the gold standard method found across the situations and across the different settings. But I would say that heart rate is only half the story. We will have to really look into many other parameters. heart rate, heart rhythm, specifically heart strain, like how much amount of oxygen deprivation is actually happening at the cardiac level, even if patient is physically feeling very comfortable, or heart rate variability or breathing pattern, rightly termed breathing rate, respiratory rate. Actually speaking, respiratory rate will be the ideal guideline, because actual muscular activation and physical exertion will be perceived rightly, or rate of perceived exertion will be correlated rightly in correlation with the respiratory rate, because heart rate is variable. Many times what will happen, situation like temperature, situation like people's presence, humidity, environment, anxiety, stress will bring change in the heart rate, whereas respiratory rate will, or breathing pattern will be directly correlated with the actual rate of perceived exertion. So in a particular case, and otherwise in this starting phase where it's considered as a sensitive phase, we must focus on particular parameters like heart rate, heart strain, heart rate variability, and there can be double checks also. For example, in the system that we use nowadays, where single beeps at a particular heart rate, or a double beep at a heart strain, where at 0.18 MV or 0.15 MV or 0.20 MV, wherever we set the parameter. So even if a cardiopulmonary physiotherapist or a medical officer who is monitoring the case progression is slightly unaware of the situation, but artificial intelligence and current technology has provided us with the database where they are able to detect the incident of anything which is not sound for a particular person at that particular time. So for this particular male, body weight, height, body mass index will be assessed. Then his risk factors, biochemistry finding, as we already knew, dyslipidemia, echo findings, past history of physical activity. What was his physical activity before this episode? Heart rate, blood pressure, SpO2 at rest, during and post exercise, ECG at rest, during and post exercise, and breathing rate correlated with rate of perceived exertion. And then in terms of functional capacity measurement, we will be talking of cardiopulmonary exercise test evaluation following different criteria, 6-minute walk test or shuttle walk test, or various other submaximal functional protocols which are to assess exercise intensity, muscle strength testing, respiratory muscle testing, or musculoskeletal assessment. And then on the basis of that FITT principle, frequency, intensity, time, type, entire classification of exercise will be made for him. And today, resistance training should also be given importance in a particular age group, but keeping in mind the response of heart rate, blood pressure, and other variables while the person is undergoing resistance training. But low weight or moderate weight resistance training will in long term help to benefit patients in daily activity performance. Otherwise, variety of material are used for endurance and resistance training: treadmill, stepper, weight, rowers, elliptical trainer, exercise bike, dumbbells. And beneficial effects are numerous, as already noted: improvement in autonomic balance, sympathetic system and parasympathetic system balancing, decrease inflammation, inflammatory cytokinins, improvement in insulin resistance, decrease adiposity, improvement in cardiopulmonary functional capacity, decrease dyspnea, decrease resting heart rate. And
1 minute left.
Warm up and cool down is very essential. Strength training, endurance, cardiopulmonary condition will play a critical role after warm up and before cool down. Interval training can also be performed depending upon the capacity of the person. Active interval and rest interval can be planned, where initially active interval is more and rest interval is less, but down the line rest interval will be reduced, and we will be taking this particular person on the continuous training also. Along with breathing exercise, breathe hold should be avoided, stretching, yoga, pranayam, nutrition, etc. We use various systems. One of the system we are using nowadays is wireless ECG monitoring system in the setup, where there are sensors across the cardiopulmonary rehab area, and patient wear straps. There is a pickup technology which picks up the waves with Bluetooth and various other parameters, and then this can be monitored. And this also has artificial intelligence component, where certain alarms are given inside the situation, and depending on the age group, safety plan can be done. So the benefit of supervised cardiac rehabilitation include mortality reduction, symptom reduction in smoking, improved exercise tolerance, risk factor modification, and increase in psychological well-being and quality of life. But unfortunately, cardiac rehabilitation remains considerably underutilized, mainly because of referral problems and maybe poor enrollment and maybe poor awareness, which has to be spread by us. Therefore, development and implementation, supervision of safe and effective person-based exercise plan are needed to maximize the benefit to health and quality of life with early and appropriate vocational and recreational activities. Thank you.
Thank you.
can you stop sharing the slides? Then we can move to the next speaker.
Yeah.
Yeah, Dr. Alap, can you stop sharing the slide? So wonderful talk. You have stressed upon how improvised and important it is to monitor heart rate and respiratory rate. So wonderful talk as anticipated from you. Chairpersons, we'll have the second speaker.
Am I audible? Yeah.
Yes, sir.
Yeah. Now we have got another topic, that is yoga and meditation are as effective modalities for the cardiac rehabilitation. It will be delivered by Dr. Shilpi Mohan. I think these all three topics are wonderful one. Dr. Shilpi Mohan, may I request you to please.
Dr. Shilpi, we can't hear you. We can see your slides, but they're not in slide mode. You need to unmute, Dr. Shilpi.
So, good evening, chairpersons, moderators, and my fellow speakers. At the outset, I would like to thank Dr. Kamal Sharma for giving me the opportunity to share my views with this August gathering. And I intend to highlight the role of yoga and meditation in post-PCI cardiac rehabilitation. Here we have a young male who had acute coronary syndrome and he underwent cardiac intervention. His lipid profile is deranged and he is put on optimal medical management. The important thing is he has history of COVID-19 a year back. He requires cardiac rehabilitation so as to reduce the risk of recurrence and improve the quality of life. The question is, which is the best suited lifestyle modification therapy for him? Is it supervised exercise, yoga and meditation, or home-based therapy? Cardiac rehabilitation includes all three aspects: exercise training, lifestyle modification, and psychological intervention, so as to reduce stress, reduce anxiety, and keep the person or the patient motivated so as to pursue exercise training as well as lifestyle modification. In this post-COVID scenario, as has been highlighted by the previous speaker, is physical exercise actually safe? Because we have seen that there is an increase in the incidence of sudden cardiac death, even in those patients, and even in those persons who are physically very active and who are athletes. The COVID virus not only has a direct viral damage, but it also has a immune system activation, which can lead to post-acute sequelae of COVID, which is also known as long hauler. And patient can present with potential symptoms long after COVID when the initial part is over, and they can present with tachycardia, palpitation, chest pain, dyspnea on exhaustion, and as well as exercise intolerance. So in such a patient, even if we advise them exercise, they are not able to tolerate it. And long-term consequence of COVID-19 has shown that myocarditis is prevalent, and fibrosis, myocardial edema, ongoing inflammation is present, thrombogenesis is there, systemic embolism is present, and patient can have heart failure. And then they can also have a new onset arrhythmia, which can lead to sudden cardiac death or some cardiac episodes. Looking at the cardiovascular involvement of COVID-19, it can be in the form of venous thromboembolism, arrhythmia, pericarditis, Takot's tubercardiomyopathy, myocarditis, heart failure, and myocardial injury. This was published, this expert consensus decision pathway was published in JACC May 2022. which highlighted the importance of return to play, how we should bring the patient back to their physical activity, normal patient as well as athletes, how should we go about it? And they have emphasized that regimented return to play should be emphasized in all individuals with prior COVID-19 so that cardiac monitoring of the symptoms and cardiopulmonary symptoms can be done. And those patients who have myocarditis, long-term abstinence is advised. And as has been highlighted by the previous speaker, individualized training concept for post-COVID-19 patient has been brought out. But I would like to bring to the notice of the panelists and the chairpersons, and I would like to quote from this article: through all stages of COVID-19 pandemic and beyond, risk of adverse cardiovascular outcome during athletics will persist despite best CV screening practices, and emergency action planning initiative represents our best strategy to save lives. So even though we analyze the patient and give them the right supervised, individualized protocol, still the risk of sudden cardiac event will be there. So in such a scenario, is yoga and meditation best suited for post-COVID patients? I would say yes, because it shifts the focus from illness to wellness, and it produces an integration of spirit, mind, and body. It integrates breathing pattern. It brings the focus back to now. Breath becomes steady. The body is still, and all aspects of human psycho and physiological functioning is improved. It avoids any violent, jerky movement. It is non-competitive, and it is done with breath consciousness, and it is instrumental to bring physical, mental, and spiritual well-being in a patient, especially in a post-COVID scenario where post-traumatic stress syndrome has been brought into light. Positive psychological well-being is very important for cardiovascular health. This we all know. And stress increases the episodes of a cardiovascular event. So yoga reduces stress by breath control and meditation. Physical fitness is improved by yogic postures, and lifestyle changes is also brought by self-restraint. By stimulation of parasympathetic activation, it increases glucose tolerance, insulin sensitivity, which is effective in obesity and diabetes. It also reduces oxidative stress, and it reduces the risk of atherosclerosis, hypertension, and cardiovascular death. Coming to the benefits of pranayama, it improves respiratory function, immunity improves, inflammation decreases, and psychological stress also reduces. So in the nutshell, yoga and meditation brings about physical wellness, mental wellness, as well as emotional well-being. So all the core components of cardiac rehabilitation, like exercise training, nutritional counseling, weight management, blood pressure management, lipid management, diabetes management, this was brought out by Dr. Alap also, that we want complete cardiac rehabilitation. This all can be done by yoga and meditation. It is a one-stop arrangement for everything that we want for cardiac rehabilitation. Coming to the review of literature, this is an article which was published in Health, Sport and Rehabilitation 2022, where it showed that yoga improves physical and cardiopulmonary conditioning and attenuates systemic pro-inflammatory and pro-thrombotic disorders. Again, coming to this article, Yoga for COVID-19, an ancient practice for a new condition. This was again a literature review, and it showed that yoga is a psychosomatic approach that increases physical, mental, emotional, and spiritual strength. This was an editorial which was published in International Journal of Yoga 2020, and it showed that yoga causes significant alpha brainwave activation in frontal lobe, an increase in natural killer cells, which points to a calm mind, as well as better cellular immunity. This was a case report which showed that integrated yoga and naturotherapy brings about cardiovascular and mental well-being. Again, this was a randomized controlled trial which highlighted the importance of yoga and naturotherapy. This was a review article which I have taken from This was done in Indian Institute of Public Health, Gandhinagar, Gujarat, and it again showed that yoga is a positive long-term. Yoga brings about positive long-term impact on overall physical and psychological well-being and quality of life. So I would strongly recommend yoga and meditation as the best and holistic cardiac rehabilitation strategy for my patient, because there is no incidence of exercise-induced adverse event, and it brings about complete physical and mental well-being. When we get everything through yoga and meditation, why should we look for any other modality? Thank you so much for your patient listening.
Thank you so much. Can you stop sharing, Dr. Shilpi? So now we have heard two aspects. One is institutionalized rehab versus yoga. And now we also need to hear, can you rehab at home? I mean, that's the common practice in India. You give them what to do, what not to do, charts from our hospital at the time of discharge, what to eat, not to eat. Previously, it used to be. Now we print one more chart, what to do and what not to do, and then send the patient home. So we have Dr. Srirang Trivedi to talk about the same. Dr. Srirang.
Hello, good evening, everyone. And sorry, I have noted down the points only, and I will be speaking directly, sir. Okay.
That's fine. Please go ahead.
Thank you, sir. And let me tell you, this is my first talking.
Dr. Kamal, I am just now leaving because I have got certain commitment. Thank you.
Yes,
thank
sir.
you all
Thank
of
you,
you. It was nice discussion. I enjoyed. Thank you very much.
Thank you.
Yeah, Dr. Srirang, please go ahead.
Good evening, everyone, and respected doctors. Today we will discuss physiotherapist guide home-based home-based cardiac rehab in the setting of post-PCI ACS. So I want to emphasize on home-based physiotherapy more because I strongly believe that all we are discussing right now are the lifestyle changes, which has become patient's lifelong habit. Then it is going to benefit patient the most, and by home-based physiotherapy guided exercise, I can assure that patient will learn them in his familiar environment and at his home, and he's surely going to include that in his lifestyle. So there are many more benefits at home-based guided rehabilitation. So we can modify lifestyle changes like diet, weight control, flexibility, strength, psychological support with home-based guided rehab. So the phase we are around 3 phases available. So first phase we are going with first optimal phase of cardiac rehab, in which we include breathing exercise. So there are 5 types of breathing exercise. So normal breathing exercise, then diaphragmatic breathing exercise, then pursed lip breathing exercise, then modified mobility breathing exercise, a kind of segmental breathing exercise, and whole breathing exercise. So we will be monitoring him with this exercise and assess with vitals. If patient is compliant with breathing exercise in 14 days, then we will upgrade him to next phase, which will last for 15 to 45 days. Then after we have modification around phase level 2. This is a phase 2 workout. So in which we include moderate walking, 6 to 10 minute walk on ground surface, and going downstairs, not upstairs, going downstairs 10 to 12 steps per day, and start with also spirometer exercise. And if patient compliant with this stage, then we will upgrade him for the next phase. And then the next phase. So this is an upgrade phase. Phase 1 is a low level, phase 2 is a moderate level, and then phase 3 is a graduation. Like in after 1.5 months, we will start with medium intensity circuit exercise. In this, we will focus on cardio, strength, and stretching circuit exercise, and also start with aerobic exercise like walking, jogging, cycling, and circuit exercise, and also interval training exercise at home. Then why? So patient will adhere more to home-based rehab, and rehab and therapy will be more subjective and customized. And so in a nutshell, physiotherapists guide home-based cardiac rehab will help us in secondary prevention of ACS morbidity and mortality both. So thank you so much.
So that was very precise and to the point. I think we have learned from, because that was the most obvious talk, and Dr. Sriram, but I think that will give us more time. Over to chairpersons. We have Dr. Gaurav Singh, Dr. Suyash, Dr. Ashish Mishra, Dr. Shweta, Dr. Mittal, Dr. Poonam. Over to you. What are your inputs and thoughts about it? And then we can hear some counters from Dr. Alap and Dr. Shilpi as well.
Myself, Shweta, again, I would like to give a highlight here. I typically agree with Dr. Alap and Dr. Shilpi when they said that, celebrity deaths in the gym is very high these days. The major reason I would also highlight here is the steroids and the fat burners that have been given. When we talk about actual steps after PCI, there are also few steps that we should reverse back, which actually leads to the condition, right? So it's more of the time the patients are being put on steroids and fat burners, which actually leads to these kind of an issue at the first place. So pehle ho ya baad mein ho, every time the diet, when we talk about it, is all has to be high on fiber, it has to be high on flax and omega-3/6 ka jo ratio hai, that is also a very much important, that also plays a very much important role. And yes, yoga is something even I recommend to my client along with 30 minutes of walk, because 30 minutes of walk or 45 minutes of walk is what I feel is releases adiponectin hormone also, which will also help them control their blood sugar levels and other aspects of the medical condition if they have. So yes, definitely, I totally agree with Dr. Alap and Dr. Shilpi in that case.
Very good evening, sir. I am Dr. Suyash. I would like to thank you first for including this very important topic as the first topic. Initially, whenever the patient comes and patient gets the discharge along with the stents that we put into the patient, this rehabilitation process also goes with the patient. And in this thing, many a times in that, since being a cardiologist, we all are busy with treating the acute cases. So this rehabilitation part is most of the time is neglected. But there comes the social stigmas, the insecurities, and many a times the phases of depression. Many a times we are facing young patients nowadays who are having these cardiac diseases in the early stages in their life. So they go through all these things, and the management of these things are also important along with just opening up the coronaries. So as very importantly said, that we can avoid many of the mortalities by giving the patients proper knowledge of how much they should work up, how much their target heart rate should go while doing the exercises. And definitely we should not stick to one thing, we should get the best of all the worlds. So we should include yoga, meditation. Also we have to first work on decreasing the risk factors which the patient is taking throughout his life. So these smoking and the knowledge of all these things is very much important. And then comes the role of rehabilitation by doing the positive things like including various lifestyle changes. Then also I would like to emphasize that during the initial days, it will be always better if they have a trainer or someone who comes to their home to get a good compliance, and then later on they can continue on with it. So I would like to say, to conclude, that rehabilitation is not a procedure, it's a process. And so it takes time, and you have to be with the patient through all those ups and downs. Thank you, sir.
Dr. Gaurav, Dr. Ashish.
Good evening, sir. Congratulations and thank you for inviting us. I would like to add that in cardiac rehabilitation, it should be individualized. We cannot say that yoga works for everyone, or home-based physiotherapy will work for everyone. So it should be individualized. And in some patients, maybe combination of either of three can work. So it is a very important aspect in post ACS or post PCI patients, and it should be individualized, and a combination of all the three can work.
Yes, Dr. Ashish. Dr. Ashish, you have something to add to it?
Hello, sir. So basically, sir, listening to
all the speakers. In fact, they have rightly brought out the key aspect related to the cardiac rehabilitation. We have multidisciplinary forms of providing the cardiac rehabilitation, and in fact, it usually starts for a patient who is like, as the case has been discussed, as a post PCI patient who is a high risk and is in need of all aggressive therapy, including cardiac rehabilitation. So usually, in fact, in most settings, it starts as an institutional based cardiac rehabilitation, and then the patient is like in a turn to a home based physiotherapy. So in such cases, in fact, cardiac rehabilitation is being perceived and should be taken up rightly as a continuum, and not as just a part of peri procedural care. And in fact, yes, it has to be individualized as per the need of the patient, and in fact, it should be a part of life once the patient has recovered as well.
Dr. Mittal, Dr. Puram, you
Hello.
have something to add? Yeah, Dr. Mittal, yeah, please.
Hello, sir. Hello, sir. I think cardiac rehabilitation is a part of everything. Patient have to do the cardiac rehabilitation under some guidance. And yes, yoga and meditation is equally important. But as per my perspective, first we have to give the physiotherapy under observation of physiotherapy. And we can start the rehabilitation by observations and by under the observation. And second part, we can, yes, advise to do at home. So I think breathing exercise, yoga and meditation is more important at the earlier stage, and interval training and the strengthening and the stretching exercise is the later stage. So it's my conclusion. Every aspect is helpful to the patient for better recovery.
Yes, so I think we need to consider everything. It's a holistic approach. So I let me ask Dr. Alap, do you also include yoga in your rehabilitation?
Yes, sir. If you could see my slides,
yes,
breathing is most important part. And see what happens in today's time. When you talk of breathing, there are various things other than what pranayam we observe, Anulom Vilom, Brahmari, or whatever we see. Other than that, there are a lot of breathing protocols: diaphragmatic breathing, segmental expansion, inspiratory hold, PNF breathing, 4 square breathing. There are so many breathing patterns by which we are just trying to improve the lung function capacity. So that is very important part post cardiac event and even in preventive. So 360-degree approach is very important, because we always tell each patient, a marathoner has a tough time. If he is trained only for marathon, he cannot win in 100-meter sprint. Or 100-meter sprint runner who is trained for anaerobic will not have a capacity to lift 20 kg weight. So strength training is different component, pranayam, meditation, yoga is different component, cardiopulmonary conditioning. So we talk of 360-degree, each parameter should be given importance.
Yeah. So, which patients ultimately we need to take this as a take-home message? Which patient amongst these ACS patients would we ultimately be advising institutional cardiac rehab versus home-based cardiac rehab? So that's the thing that the message has to go. So we all have got this message that yoga is an integrated approach. Yoga is part of rehab. You can choose what types of yoga to do, whether it's institutional or home-based. So that message is clear. I need to know, and that's the message that we have to learn, as to which patient you would say only institutional and then go at home, and which patients you can say directly go at home. If we can have some comments on this from either of the speakers or chairperson.
Sir, this patient you discussed is a 39-year acute event. In the initial phase, he should be put under monitoring. Everyone may not have access to such facility, and everyone may not have access to even ECG monitoring, but at least a physio professional guides him for a particular intensity setup and bring up some confidence. Then depending upon patient's comfort, home approach is also, and then clear guideline has to, because everything will be operated at submaximal level. So long term, depending upon the comfort of the patient, it can be given as home. But initially, first few weeks or at least 3 to 4 weeks, supervision would help a lot.
Yeah. So I think patients with LV dysfunction, patients with ventricular arrhythmia, patients with multiple comorbidities, including respiratory disorders, patient with elderly, as you said, and maybe COVID. So long COVID, acute COVID, of course, always probably do a institutionalize and observant, but like this case was borderline, only COVID we included so that we have these recent evidence and episodes of young people actually getting young, collapsing in institutionalized rehabs also. I mean, you'll not call them rehabs because some of them were actually gym, not supervised by trained cardiac rehabilitator, but some of those incidents were like that. Poonam, do you have any comments to add?
So, Kamal sir,
yeah.
if somebody suddenly decides to do exercise with a very bad family history, lifestyle history, lack of sleep, smoking, weight, obesity, and suddenly he or she thinks to decide doing workout, then first few weeks should be monitored and guided. Absolutely. Then they can go their own way.
Absolutely.
What I feel is like whenever it is post, PCI or any kind of a surgery, it has to go little on a very lighter pace. First, to focus on a right diet is, I would say, is the right approach alongside the yoga and the walk. Being a dietitian, I will always be pro towards the dietary approach before anything comes.
Yeah. So we had Dr. Shweta speaking the same last CardioCon. So this time we changed the focus from diet to rehab. This time we wanted, because the discharge cards contain the medicine, what to do, what not to do, and what to eat, what not to eat. So these are the three sheets we tend to give to our patients. So we've been discussing the other two. I think this time we wanted a focus, and that's why. But I agree, all three have to go together. Can we have the next slide? I think if there are no more comments from the panelists, I think the balance and the message is pretty clear from the chair. We'll have the quiz for the question, which was based on the set of talks that we had. Can we have the next slide, RX events? Next slide, please. Ria. So as I said, you'll have timer here. Next slide, please. And this is the first question based on this. Yoga is the most proven in cardiac rehab in improving which of the following outcomes? This is from one of the trials. Can we have the timer on? And I think 2 minutes are too much of a time because the speakers did anyway wonderfully well. It should be a straight away click to get the right answer. But anyway, if you are trying to take half a minute for each option, you can move around. And I am taking in consideration the time that you may have because of a slow internet as well. So which of the outcomes in one of the largest study was looking at the improvement, and there is no controversy about yoga does what? It improves which of the following outcome non-controversially? Quality of life, LV ejection fraction, reducing the heart failure hospitalization, or does it reduce mortality? Now, there are papers, individual papers, which have looked into various aspects, but all of the papers have looked into one of these aspects to be, non-controversially be improved upon. There is no paper to tell you that this parameter does not change. So which is that parameter? That's your option. Of course, there are no negative markings. We are a very positive people. We don't give negative marks. We only give positive marks. So we have +1. And at the end of 25, as I said, whosoever gets maximum right, and once the CardioCon is over, for all students or all the participants, whosoever gets highest marks, we have 3 prizes for the top 3 scorers. And when there is a tie, the time taken to answer is going to be the consideration. So out of 25, if there is say 20 people at 20 points, we'll look at what time they took to answer that 20 points correctly. So we have 30 seconds. We can have some comments as soon as this gets over. I think there are papers. Dr. Shilpi showed us about one of the papers from Indian Institute of Public Health. She also showed some of the papers from meta-analysis. But as I said, I'm going to not only give you the answer, but I'll also give you the reference for the explanation. So as the timer ends now.
How do I select the answer? I'm so sorry.
Sorry?
How do I select the answer? I don't get the clicks.
It's on the app. It's on the app. You are in the Zoom, so you can't. It was in the app. The quiz was displayed as I said on the app. App is the link, the delegate link. When you open it up, you can click on the option, and that's how it was. So is the timer off? Can we go to the answer? Can you click next, Ria?
How do I select the answer? I don't. I'm so sorry.
It's on the app. It's on the app. You are in the Zoom, so you can't. It was in the app. The quiz was displayed as I said on the app. App is the link, the delegate link. When you open it up, you can click on the option, and that's how it was. So is the timer off? Can we go to the answer?
Yes, the answer is quality of life. Irrespective of which study you look at, the quality of life does improve. Same is the case with cardiac rehab. Cardiac rehab, you have some data to even talk about reduction in heart failure, hospitalization, improvement in ejection fraction. Even some papers talk about mortality. So does yoga as well, including a paper. And this is the paper from, of course, the paper that Dr. Shilpi was talking, the IIPHG paper. It was based on Dr. Prabhakaran's original paper. Dr. Prabhakaran is head of the Indian Institute of Public Health, and he was, and IPHG, and I think they reported the self-rated health quality was higher in yoga compared to enhanced care group, with the adjusted mean in favor of 1.5, that is 50% yoga care group. This was called as yoga care study, which had a greater return to pre-infarct activities. These are the patients post-MI who were evaluated, and they found out that the quality of life was surely 50%, and they used very stringent criteria like KCCQ questionnaire, Minnesota Living with Heart Failure Qualification scores. All those criteria were used, and based on irrespective of which they used, they found this out. So I think we are headed towards the end of the session. Maybe we'll be glad to have you stay connected for the sessions beyond. And thank you very much, all the chairpersons, moderators. Thank you, Dr. Makar, Dr. Gaurav, Dr. Ashish, Dr. Suyash, Dr. Mithil, Dr. Shweta, Dr. Poonam, and of course, our speakers, Dr. Alap, Dr. Shilpi Mohan, and Dr. Sriran. Thank you very much for being with us. We move to our next session. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
So this was the quiz. Now we move to the bout 8, and this is now to the hardcore intervention. This is bout 8 of imaging physiological assessment in ISR, whether you go for imaging or you go for physiology, and amongst imaging, would you go for OCT or you would go for IVUS? For this, we have a 55-year-old bus driver. You know how critical that job is. We don't want him to ram up his bus against somebody and not only have his own lifestyle impaired, but also create an accident with new onset of angina with instant restenosis of 65 to 70%, a borderline lesion. The LAD osteal stent, 4/28, implanted 9 months back. His TMT is borderline. Duke treadmill score is -2. Troponin I is 22 with a normal of 19, very borderline. With a normal CPK-MB, his eGFR is borderline 44. The preferred mode of evaluation of this lesion. The first talk will be by Dr. Priyank, HDI was preferred view for proximal lesion with alternative RFT. Dr. Vineet Sakla, my friend from UK, physiological assessment, FFR is most appropriate because of coronary are not rigid pipes. And then my friend from UK again, Professor Mamas, OCT is preferred modality despite borderline renal function and proximal lesion due to higher efficacy. May I invite the chairpersons for the session, Dr. Tejas Patel, Dr. Nikhil Yadav, Dr. Dharmin Balodia, Dr. Naveen Agrawal, and our moderators, Dr. Sunil Karna, Dr. Mandip Tilra, Dr. Amit Chaudhary, and Dr. Alok Shinde. So we know the ISR patterns: focal, type 1, which is articulation or a gap, type B, which is marginal, type C, focal body, and type D, multifocal, while 2, 3, and 4, that's not been defined here, which kind of lesion we are dealing with, has got an intrastent, proliferative, or total occlusion, but we have 60 to 70% lesion. That's what it was. So I think we can have Dr. Vineet because Dr. Priyank is yet to log in to come in first. Dr. Priyank is not joined yet. Can we have the chairpersons? So we have role of imaging in ISR, role of physiological assessment, and these are our chairpersons, Dr. Tejas Patel, Dr. Nikhil Jadhav, Dr. Dharmin Balodia, and Dr. Naveen Agrawal, Dr. Sunil, Dr. Mandip, Dr. Amit Chaudhary, and Dr. Alok Shinde. Over to chairpersons. Yes, Dr. Dharmin, you can take over.
We have Dr. Vineet before Dr. Priyank Modi speaks. So, Dr.
Good
Dharmesh?
evening. Good evening, everyone. So as per the patient profile, it appears very critical to exactly define the diameter and lesion stenosis and lesion morphology, as patient is occupied in a high risk employment, and life of other people also depend on him. So selection of a proper technology to define lesion is important. The previous stent size was 4 millimeters, so proper imaging technique in this much larger artery with precise diameters is of prime importance. So it is a good comparison of the current technologies like IVAS and OCT.
Yes, and yes, sir. Good evening, Dr. Nikhil here.
Yes, Nikhil.
Also, yes. So patient's EGFR is also on lower side. So it is stage 1 CKD. So again, we need to see role of OCT. We need to be careful about using dye in this patient to see for dye-induced nephropathy as well. This will be a good discussion. Role of IVAS, FFR, or OCT, which modality is better in this clinical scenario. That we need to see. Thank you.
So Dr. Vineet sir is online, I think.
Yes, Dr. Vineet, as Dr. Priyank Modi is still loading his presentation, I think we can have Dr. Vineet Sakla. Vineet is my contemporary, my colleague. We passed our DM almost the same time. He's practicing in UK. So welcome, Vineet, to the session. Over to you. Vineet, you need to you can unmute and you can share your slides as well.
Yeah, you can hear 1 minute.
Yeah, we can now. Please share your slides.
1 minute. Am I able to share? No?
Yes, sir, you can say.
Yeah, you can see my slides.
Yeah, please make it full screen. Yeah, please.
Yeah. So thank you very much, Kamal, for inviting me for this very prestigious and informative conference. Thanks a lot. And Kamal is always in the front of this delivering academic conferences and lectures. And I basically look upon him as a very academic professor in cardiology, because he's also a professor in UN Mehta. Anyway, so my talk is on FFR in intermediate coronary stenosis. So this is about the patient. He's 55 years old and he's a bus driver. So he's leading his active life, and he underwent angioplasty to LAD, which was implanted 9 months back. Currently, he's having angina. Troponin is normal. EGFR is 44, so it's CKD stage 3. His TMT is borderline positive, and his angiography shows an intermediate stenosis in LAD stent. Now, how to proceed? It's very important to know what exactly this stenosis is significant or not, because we have to treat him. Of course, medical treatment is there, but whether he will require any intervention, that is the prime question here. So 2 fundamental questions here. Is the lesion significant or not? Just hold on 1 minute. Yeah. So is the lesion significant or not? That is, we have to decide, because it's an intermediate lesion. And we know that angiography may be dicey here, may not show the perfect severity of the lesions. So is the lesion significant? It is producing ischemia. That is the first fundamental question. And has the PCI been optimized? Because if you do not optimize the PCI, it will not matter even if you offer a stent or not. That is very, very important. These are the 2 fundamental questions we have to always answer. Why it is important to know this patient is having ischemic lesion or he's really having ischemia? Because we know by the studies that any kind of ischemia burden will increase the MACE rate. So it's very, very important to know whether this patient is suffering from ischemic coronary artery disease, or whether that particular lesion is ischemic or not. At the same time, we don't want to put stents, because if we just put stents depending upon the angiography lesions, Putting unnecessary stents definitely increases target lesion failure. It increases the cost. There are so many, there are about 5% chances of developing in-stent restenosis, repeat procedures. So there are problems of putting unnecessary stent apart from the cost. And this slide shows about it. Also, we know that stenting may not benefit every patient. We have ischemia trial where we know that stable ischemic heart disease and moderate to severe ischemia on stress testing, we can, in fact, the OMT was almost fair equal as compared to intervention. So this was the ischemia trial. So how to evaluate this patient who's having intermediate stenosis? Visual, by just looking at the angiography, or we do a test called physiology. We put a pressure wire in the coronary arteries and decide whether the lesion is significant, or we do imaging. We look into the artery, we visualize the artery from inside and see whether there is any plaque or how much is the minimal lumen area. So these are the three modalities. Of course, we all know that just looking at the angiography visually, it's a two-dimensional view, and it always varies from which view you are seeing, and it sometimes cannot give a clear view of the severity of the coronary stenosis. So, of course, there's observer bias in coronary angiography, seeing visually. What about imaging? Now, imaging, the most important thing we see in imaging is the minimal lumen area. Now, the studies have shown that just observing minimal lumen area is having a very high negative predictive value, but a very low positive predictive value. Now, as a clinician, we are always worrying about, we always see what is the, for the patient benefit, we always see what is the negative predictive value and what is the positive predictive value. So what does that mean that is having a low negative predictive value, positive predictive value? Is that when the minimal lumen area is large, it's safe to defer intervention. But if it is small, it may not justify intervention. So it's like that. If the minimal lumen area of a non-LM lesion is more than 4 mm, it is safe to justify that, okay, we can avoid intervention. But if it is small, that because of the low positive predictive value, it may not justify intervention. And plus, the IVUS will not tell you what is the amount of subtended myocardium, how large is the myocardium below this coronary artery. So these are the problems with imaging. And then there was a meta-analysis which was done in Korean, which was published in Korean Circulation Journal. And the conclusion was that the IVUS-derived minimal lumen area has a limited diagnostic accuracy, and it needs a careful interpretation to correlate with functionally significant non-LM stenosis. So these are the problems of the imagings. Now coming back to the physiology, what is pressure wire study? So in the pressure wire, what we exactly detect is the blood flow distal to obstruction, or which is compared to a blood flow without obstruction. And we cannot measure directly blood flow because it's difficult. So what we do as a surrogate marker is measuring the pressure. So what is the pressure beyond the artery, and what was the pressure in the presence of a normal artery without any obstruction? So it's just like FFR is measuring, it's almost like a surrogate of a treadmill which is done inside the cath lab. It's a stress test for the artery inside the cath lab during the cath. So this is about which I'll come to the future trial. This is about the pyramid of diagnostic accuracy. If we just do a coronary angiography, it is only positive. It's correct only 65% of times. 35% of times it may be erratic. And FFR is almost 95% of times you are certain that this patient is having a physiological significant stenosis. And these were the initial landmark trials which came out of physiology, the FFR. One was the deferred trial, where, as the name indicates, if the FFR is more than 0.75, so it was compared between PCI and medical. So what this trial meant was, can we defer the PCI in the patients who have FFR more than 0.75? Then came the FAME trial, which actually ruled in PCI in the patients who had FFR less than 0.8. So it was a comparison between FFR less than 0.8 versus FFR more than 0.8, and FFR 0.8 was less than 0.8 was actually subjected to PCI, while the rest was subjected to medical. And then came the FAME2, in which they compare in the patients who had FFR less than 0.8 and they were offered PCI with medical therapy or a medical therapy alone, and then it was compared which fared better. So in the deferred trial, it was proven actually that the patients who had FFR more than 0.75 and if we defer interventions, they actually fared better. So the cardiac death and acute MI were actually much better as compared to the patients who underwent an intervention if the FFR was 0.75. So this trial proved that, okay, if the FFR is if the FFR is more than 0.75, we can safely defer intervention. So that is about this trial. And then came the trial of FAME study, which actually proved that if the FFR is less than 0.8, it is better to intervene this patient rather than putting on the medical therapy alone. And that NMI, after 2 years, actually fared better in the patients who were offered interventions if the FFR was less than 0.8. While in the FAME2, it was actually compared between ischemia-directed PCI plus OMT versus OMT alone. Means the patients who had FFR less than 0.8, whether to offer PCI plus OMT or OMT alone. And again, in this, it was proven that the patients who were offered PCI plus OMT in FFR less than 0.8, the cumulative incidence of MI death and was actually much better in these patients who were offered PCI based on FFR. So one thing was certain, that beyond 0.75 or 0.80, intervention is not required. And if the FFR is less than 0.8, interventions may benefit, reduce the future revascularization. Of course, mortality may or may not benefit, but definitely it reduces the future spontaneous MI, spontaneous revascularization. So this was the essence of these trials, namely the DEFER trial, FAME1, FAME trial, and FAME2 trial. And it was proven that routine adoption of FFR in clinical practice allows the physician to make right decision for the right patient at the right time. Now, the greatest advantage, as I told in my before slide, was that we are avoiding actually stents. Stents means cost. So there was definitely proven cost effectiveness by using physiology studies, and it was economically better, especially in countries like in our countries like India, where stents may cost some money. So definitely it is cost effective, and we are avoiding contrast usage also. There are many benefits of not doing the procedure, like contrast usage involved during the procedure, especially in this kind of patient where it's a CKD stage 3, EGFR is 44. If we avoid intervention by proving that FFR is more than 0.80, we can reduce the contrast usage, and we can reduce the contrast-induced nephropathy or contrast problems, which may deteriorate the kidney functions. So it saves resources, it increases the quality of life, it improves outcomes. Outcomes have been, all the trials have proven outcomes with FFR. And of course, it is very cost effective, and it reduces the cost. One more thing is that it changes the perception, it changes the treatment also, depending upon the FFR. Like, it was a trial was compared between angiography-based severity, angiography-based number of coronary vessels involved. And once they did an angiography, so there was almost a 30 to 40% change in the management of the patient. Like 3-vessel angiography or 3-vessel disease on coronary angiography was actually proved only 14% with physiology, and 2% was actually proven with only 43% with physiology. So if we use physiology in all the patients randomly, and if who have been multi-vessel disease, and if we do a physiology, at least 30 to 40%, the management will change, which means they may or may not require interventions in that particular vessels who were judged significant or non-significant on coronary angiography. So this was about all the trials, and recently a very large trial, very famous trial came called as FLAVOR trial, in which the physiology was compared with IVUS, and it was proven that physiology-based studies or physiology assessment is non-inferior to IVUS. Well, we all know that it's almost non-inferior to IVUS, but we know that the IVUS comes with cost, or any imaging comes with cost. While in FFR, the advantages were that there was no cost of imaging involved, there were less number of stents involved, there's less number of cost involved. So these were the advantages, and plus it was non-inferior to imaging studies. So that is the greatest benefit of physiology, which I think is much, much better as compared to imagings. And this was a landmark trial, the FLAVOR trial, which was published in NEGM. Then there was one more trial called as FORZA trial, in which the physiology was compared between OCTs, and this came in JAK interventions. Of course, in this trial, the physiology was compared between, just a minute. Okay, of course, in this trial, the physiology was compared between OCTs, and it was proven that, again, the physiology There were more patients put on medical therapy as compared to interventions, again reducing the cost, reducing the extra number of stents used, reducing the length of the stents used, and reducing the kidney injury because less contrast, reducing the cost. There were more PCIs in the OCT groups, more increase in contrast medium use. Of course, there was decrease in MACE and significant angina with PCI because you offer more stents, but the cost, the kidney injuries and medical therapies were definitely much better with physiology studies. And this was again in the same trial where the patients who were managed with medical therapy were much higher in physiology studies, and the costs were much reduced as compared to the OCTs in the FOSA trial. This came in JAMA, and this proved that it is not dichomatous like if we make the FFR 0.82 or 0.81 after the procedure, the patient will fare better. The more, what I mean is that more the increase in FFR, more better the outcomes. So it is a continuous variable, and it has been proven that post PCI FFR of at least 0.95 is the target we should achieve in achieving an optimized PCI. So even with the, because the pros of imaging is the people who actually are pro imaging, they always say that the optimization of PCI is much better with imagings. But in fact, even with a physiology study, if you prove that the post PCI FFR or imaging is at least 0.9, post PCI FFR is at least 0.95, that indicates that the PCI is optimized, the stent is optimized, and there are very low chances of future events. And this was actually studied in the JAMA, where actually they studied the post PCI FFR, and they found that it was a continuous variable, and the higher the FFR after post PCI, more better reduction in the events. And in fact, it has been given a class 1 indications in the ACC guidelines. It has been given class 1 indications in European guidelines. So to conclude, physiology guidance will help you in appropriate need for stents, avoiding stents if it is not necessary, and giving objective evidence of ischemic, whether this particular artery is ischemic or not. Like if you do a treadmill test, treadmill will not give you an exact idea which vessel is ischemic and what level it is ischemic, while physiology will give you which vessel, what level is ischemic, and it will give you objective evidence of ischemia. It eliminates operator uncertainty. As I told, the decision changed when the people did a physiology versus angiography alone. So minimal observer bias, it's guideline recommended. It's used for optimizing of revascularization strategies. Even post PCI strategies, even stent optimization can be done with physiology based, and very, very important, it is very cost effective and it improves the outcomes which have been proven in the trials. Thank you very much.
Thank you, Vineet. So you were very precise. Like people talk about precision angioplasty with imaging, you could be precise with your physiology rather than imaging. So thank you for being on time. So we have Dr. Priyank Modi. Over to you, Dr. Priyank, for his talk, and then once we have Dr. Mama speaking on OCT, then we can open up it for discussion. Dr. Priyank Modi, over to you.
Thank you, Vineet sir, for the introduction to our session. As rightly said, we are now into a phase where we keep on discussing how we are going to deal with, and we forget the basic question whether actually the patient requires, rather than going ahead and planning things. So I'm Dr. Priyank Modi, and I would be speaking on IVUS. Good is good, bad is bad. What is not white shall be black. It's a quote I just wrote an hour before. So 5 millimeter LMCS stenosis, we all know IVUS is the choice. A borderline lesion, FFR is the choice. Early restenosis in a mid-LAD stent of 3 millimeter OCT gives you maximum information to determine the mechanism of restenosis. The problem is life isn't black and white, black or white. It's all sorts of shades of gray in between. I think that is the reason Dr. Kamal Sharma brings Cardiocon every year to discuss these gray zones of cardiology, where learning can be a two-way process, not just speaking for something, but getting the other side and changing the way we practice. So, what do we have today? He's a 54-year-old guy. He's a bus driver. He has had instant restenosis, a restenosis which has happened in the first year of stent implantation. It's an ostial LAD lesion. The patient is symptomatic. Borderline markers, the top slightly positive, uh, stress test inconclusive, and an established reduced renal function. Now, what do we have and how do I see it? So he's a 54-year-old guy. I see him. I see him as a young person who deserves to get a single one-time lifelong procedure. He's a bus driver. It's a responsible job. Any event in him, whether it is an acute coronary event or an arrhythmia, is not just going to endanger his life, but it is going to endanger life of thousands of people who may be traveling in his bus over a period of time. Instant restenosis. Here, the instant restenosis has happened in a large stent. It's a 4 millimeter stent, and we have a stent restenosis in less than 1 year. It's very important to understand the mechanism of restenosis if we plan to intervene. It's an ostial LAD lesion. We need to make sure that the result is optimum. Ostial LAD are the widow makers, and any problem there can be life-threatening to the patient. Is symptomatic and there are borderline markers. Here, I would err on the side of safety. He has reduced renal function, so we have to make sure that we don't harm the kidney in anything we do. So the very first question, whether the patient requires intervention. Dr. Vinit sir has rightly put up any physiological assessment would be the first way forward. So what's my take here? He's a young guy and has ostial LAD disease. We have to understand here it's not a native vessel disease. He has a stent implanted just 7-8 months before, and he has progressive disease in the next 7-8 months. So if we leave the disease at this point of time, I'm not talking about another stent implantation. I'm talking maybe about optimizing the previous result. But this is a progressive disease. In 7-8 months, it has progressed to 70%, and it is going to progress further. Very sure the patient is on medication. He's a bus driver, so it's not only his life which is at stake, but many people who travel with him. So here, personally, I would err on the side of intervention. He is young, a job profile which involves multiple lives, and an early ISR. So re-intervention, if at all we plan, irrespective of the discussion here, has to be imaging guided. So why did I select high definition IVUS as the preferred modality? So my reasons for selecting IVUS, it's an early ISR. We need to understand the mechanism of restenosis. Imaging is a must. OCT, though a better modality in giving a good image quality, but HD IVUS fares pretty well. It's an ostial LAD lesion. 4 millimeter stent has already been implanted. We need to see even the substent anatomy. So good penetration is a must. Patient has reduced renal function. I don't want to increase the dye load. Rather, here I would want to err on zero contrast angioplasty if at all it's required. So my mama taught me our prime purpose in life is to help others. And if we can't help them, at least we should do no harm. The most important for me is the borderline renal function, EGFR of 44, and these patients are prone to get into an acute kidney injury. So PCI in patients with underlying chronic kidney disease and diabetes mellitus, they have a high risk of contrast-induced acute kidney injury. EGFR of less than 60 is a strong risk factor for contrast-induced AKI, particularly like in intra-arterial contrast administration, what we do for angiography or angioplasty. According to the Mayo registry, 3.3% of the total patient who went for PCI developed AKI. And considering that this patient has borderline markers in acute coronary infarction, the chances of developing AKI in this particular patient would exceed 20%. If we see the data, the mortality rates at 1 month and 1 year were significantly higher. An incremental use of 75 ml of contrast would increase the risk of AKI by 42%. The maximum considering the GFR of this patient would be 100 to 120 ml of dye, what we are going to use. And we all know that ostial LED lesions are the lesions in real life practice where we require maximum dye because we really want to place the exact stent. Maybe left main to LED crossover would require far lesser dye. So reduction in contrast volume by just 30% would prevent AKI incidence by 13. I think Dr. Zayed Ali was one of the initial people who had a paper published on zero contrast angiography or angioplasty. Our Indian data comes from Dr. Pratap Kumar. So he did a study in the 6 months between November 2019 to May 2020, where he included 15 patients. And why did I decide to select this study? To quote my point. So PCIs in patients with significant renal dysfunction is challenging because the risk of AKI is there. With advancement of IVUS, we can go towards zero contrast angioplasty. So he selected around 15 patients, and coronary angiogram was routinely done with minimum dye. For angioplasty, guide catheter we can all engage the guide catheter based on our experience. How will we know that the guide catheter is engaged? Based on the angiographic views, we can give a short normal saline injection that would cause some ECG changes, which would be transient, and we'll know that we have engaged. We can pass in the wire. If the wire goes into the conventional routes where the coronaries are, we know that we are engaged. Generally, now integrated IVUS system would give us a very clear idea how the lesion is, where we have the normal segments, what will be the size of stents. Post stenting, we can optimize the stents based on IVUS, and practically the use of contrast would be near to zero, or maybe only in emergency or to take the final shoot. So 15 patients were there. eGFR of the study substrate was around 31, and 4 patients of these 4 patients here in these 15 patients were left main coronary artery patients, like in our patients. So that is as much as 25% of the patient substrate had bad disease. These were not type A lesions, and in spite of that, zero contrast angioplasty was possible. High procedural success was achieved without complications, no major adverse event, not even one patient required dialysis. So zero contrast PCI guided by IVUS is a very safe thing to do in coronary artery disease, particularly in patients with moderate to severe CKD. What does the guidelines say? For non-LMCA lesions, IVUS and OCT or imaging is still a class 2B indication. What is the data of use of IVUS in in-stent restenosis? RIPS 3 study was the first to evaluate. Here, no significant benefit was found, particularly because only around 40% of the patients had IVUS use during the procedure in in-stent restenosis, and the use of IVUS was put on the operator's discretion. Eye-open ISR registry was the first, it was around 300 patients or so, which demonstrated prognostic benefit of use of IVUS in ISR cases. What does the guideline say? IVUS is superior to OCT, that is the 2018 ESC guidelines for LMC and ostial disease. As Vinit sir rightly said, MLA of LMCA less than 6 correlates with an FFR less than 0.75, and these were the patients whom intervention could be planned. For ostial LED, we do not have exact data like 4.8 for ostial LED for Asians. Indian data still lacking. I believe Dr. Kirti Punami and a lot of other people are gathering data of Indian patients on IVUS. So maybe over the period of time, we can have our own numbers. So there was a correlation between IVUS and FFR, and MLA of more than 6 correlated well with an FFR of more than 0.8, and here we could easily defer revascularization. So the step 2 in this particular patient, the first step why I wanted to use IVUS was to make sure that we do not have to use dye. The step 2 important aspect here is it's a 70% lesion. Post wiring, we can directly take an IVUS run without any pre-dilatation. This would give us an opportunity to identify the mechanism of restenosis. Stent under expansion. I believe this might be the most common reason, because it was a 4 millimeter stent, and the ISR is less than 1 year of age. So stent under expansion remains the most common reason for ISR around the world. And imaging as modality is the gold standard to make sure that we have stented it right. Missed ostium in that case can be identified if at all the LED ostium was missed, and that is where the restenosis has happened. If there was a stent fracture, particularly during post dilatation of the previous procedure, can be identified. If the ISR is happening on the distal part of the stent, then an edge dissection and increased plaque at stent edge can be identified with an IVUS, and that may help us to identify the mechanism of restenosis. Once we understand the mechanism of restenosis, it would be extremely wise of how to go ahead with the procedure. So these are different IVUS and OCT views for stent under expansion or thrombus, stent missing the thing, a dissection flap, a fractured stent. And anyone of us who are using imaging on a daily basis, this would be a routine thing to identify. IVUS would just not let us understand the mechanism of restenosis, it would even help us plan the treatment. As Vineet sir rightly said, and it would be very wise not to put up extra metal or extra stents in an already stented segment. So to understanding the mechanism would in a clear way help us how to go ahead. If there was stent under expansion, the simple way forward based on the IVUS imaging measurements was to expand the stent with a new NC balloon, a larger NC balloon. IVUS also would give us a very good idea about the plaque or neointimal characteristic. And here HD IVUS would be better than the routine IVUS, the 60 Hertz catheter we have. So over the period of time, it has been determined in different studies. The original study was through Lee and all. So homogeneous versus heterogeneous plaque, like a fatty plaque, which is more homogeneous, fared better with just drug-eluting balloon, and we could avoid stents, and 1 year target vessel revascularization was far less. If the plaque was heterogeneous, then maybe another drug-eluting stent would be a better choice. So IVUS would just not help us determine whether the patient requires intervention, but if we take it forward through the MLAs that the patient requires intervention, it would help us know why the instant restenosis happened and to optimize the result of this instant restenosis.
Yeah, please wind up.
Sure. Sorry. Sure. So that is the summary of why we would go ahead with IVUS in this particular patient. Maybe in the discussion part, we would have the differential between OCT, IVUS, and FFR in this particular subset. Thank you so much, sir.
Thank you, Priyank. Thank you. That was wonderful, and you built it up very well. Importance of the clinical scenario. So we'll have Dr. Mamas now take his view on OCT, why he would prefer OCT despite a low eGFR. Dr. Mamas? And after that, maybe we can have the discussion with the panel here. Dr. Mamas, slide, please. So as he plays the slides, do you have any counter, Vineet, for this? What Dr. Priyank has said in the meanwhile?
No, in fact, 1 minute. Yeah.
Yeah, I think it was
In fact,
more
it was
complimentary.
excellent.
Both of them were on probably the same page.
Yeah, in fact, excellent presentation by Priyank. And since it's an ISR case, it's always like this. When you want to do an intervention, whether this patient, I think Dr. Mamas is online. Is he online?
Yeah. So can we have Dr. Mamas talk, please?
Hi, my name is Mamas Mamas. I'm Professor of Cardiology at Keele University, the United Kingdom. And it's a real pleasure to join Cardiacon, and I'd like to thank my good friend, Dr. Kamal Sharma, for inviting me to contribute. I'd also like to thank the other discussants for what promises to be a very interesting session, to both Dr. Modi and Dr. Sankler. So this is something that's very close to my heart, both physiology and imaging. And really, our discussion is going to be which of the three modalities is best for this particular case. Now, the important thing to say in this debate is, of course, we're doing this from an academic perspective. Often one uses more than one modality in many cases. So I think there is an important role for physiology and imaging. But nevertheless, my remit today will be to try to persuade you that OCT is the preferred modality. So this is the clinical scenario. This is a 55-year-old male with new onset angina and in-stent restenosis, which is assessed to be around 70% in the ostial LAD, where he had a previous stent of 4/28. He has mild renal dysfunction with an eGFR of 44 mils per minute per meter squared and has a high normal, high sensitivity troponin. And we're given three choices in this gentleman's management: a pressure wire, an IVUS, OCT. But of course, there's the fourth choice of using nothing. So I think these are the important considerations for this debate. This patient has had stent failure after 9 months. So really, we've probably got one more chance to get it right. So we should use everything in our armamentarium to make sure that this patient gets the best treatments. And I would hope that anyone approaching this case would ask 5 questions. And these are the 5 questions I'm going to take you through to show and try to argue my case that OCT would be better. The first case would be, should we be intervening in this case? The second question that we should ask when faced with such a case is, what is the extent of the disease? Would the patient be better served by a bypass operation? The third question that you should always answer in these sorts of cases is, what is the mechanism of in-stent restenosis? If we do decide to intervene, the fourth question should be whether we use a drug-eluting balloon or a further stent. And the final question that we should ask of ourselves in such a case is whether the result that we have produced is optimal. So the first question, should we be intervening? And this is really the only question and the only part of the procedure that the pressure wire can answer and should be used. So in such a case, by all means, use a pressure wire, use non-invasive imaging to see whether the lesion is functionally significant. This is the only role for the pressure wire in such a case. The pressure wire cannot tell us the extent of the disease, whether the patient will be better served with CABG. It cannot tell us anything about the mechanism of in-stent restenosis. It can provide no insight into drug-eluting stent versus further stent, and it provides only minimal insight into whether the result is optimized. So in my view, the pressure wire has an important role to answer the first question. Thereafter, it has little or no role. So then we're left between IVUS and OCT. The second question we should be asking ourselves is, what is the extent of the disease? Would the patient be better served with a bypass operation? Well, this is an important question. We know that patients undergoing PCI for osteal lesions have poorer outcomes. This is data from the Melbourne Interventional Group, which looked at over 1,600 lesions, 100 of which were osteal lesions. And you can see on the right-hand side of the graph that there is worse outcomes associated with osteal lesions. So MACE rates of close to 20% at 1 year compared to half the MACE rate in non-osteal lesions, so around 10%. And you can see there is a strong trend towards worse outcomes for each of the components of MACE at 12 months. particularly target vessel revascularization, almost double. And as we've said, MACE double at 12 months, 25%. So these are high risk lesions. Now, one of the reasons that we want to image is to look at the extent of the disease. This is an osteal LAD lesion. And often we see in clinical practice, and I'm sure many of the proponents of this debate will have encountered this situation where you see an osteal lesion, you want to nail the ostium, you do imaging, whether it be IVUS or OCT, and you find left main involvement. Now, this is some data from my good friend Gary Mintz and colleagues. And what you can see is that isolated LAD disease is incredibly rare, 3% of cases. So the likelihood is this patient has disease in the left main, and we are going to have to stent into the left main. You can detect this, whether it be IVUS or with OCT. You would not see this with pressure wire. The next thing is, when we do something in interventional cardiology, we want to show that you have an improvement in outcomes. So for in-stent restenosis, has pressure wire ever been shown to improve outcomes? No. In contrast, intravascular imaging, whether it be IVUS, whether it be OCT, has been shown to improve outcomes. This is some data published from the UK, from my group, looking at outcomes with complex PCI. You can see, rather surprisingly, in the United Kingdom, only a third of in-stent restenosis cases have intravascular imaging. But you can see that for MACE, there is a reduction in in-stent restenosis of the odds by about 20 to 30% associated with intravascular imaging use, and the trend towards improved mortality as well, which was not significant. So certainly using imaging, whether IVUS or OCT, is associated with better outcomes in such cases. The third question, which I think is really quite central to this debate, is what is the mechanism of in-stent restenosis? Because once we understand the mechanism, that is when we can intervene and direct our approach depending on what the mechanism is. And this is really where OCT comes out on top. So stent under expansion is an important mechanism of in-stent restenosis. And you can see stent under expansion, whether you use OCT or IVUS. Now, there are many reasons why a stent may be underexpanded. Perhaps the operator did not assess the size of the vessel optimally and put an undersized stent. That is a possibility. However, more important causes of stent underexpansion are things like calcification. And this is where really OCT comes out on top, because you cannot assess the thickness and distribution of the calcium as well with IVUS as you can with OCT. And clearly, your approach will completely differ depending on the nature of the calcium, which you can only assess properly using OCT. Other causes of in-stent restenosis that you may be able to identify is landing your stent in significant plaque. And I would say that probably OCT has an advantage here, but IVUS, again, is useful. Overlapping stents, so where people have used multiple stents, they've not overlapped, and there's been a geographical missize, another cause of in-stent restenosis that one has to address, and you can see that as easily on IVUS and OCT. Things like dissection in the index procedure, you will see that on OCT, you may not necessarily see that on IVUS, and fractured stent, again, much better visualized on OCT than IVUS. So going back to the calcification, I think this is really quite key. When you're looking at underexpansion as your mechanism, you have to think about, why have you had an underexpanded stent? Is it because that the operator has misjudged the size of the stent, or is it because of severe calcification? So this is the exact same lesion assessed with IVUS and with OCT. So it's a calcific lesion, and you can clearly see that both of them show calcification. With IVUS, you cannot tell how thick this calcium is. There's no way. So you cannot tell whether you can use a cutting balloon here. You cannot tell whether the calcium would crack with a non-compliant balloon. With OCT, you can see exactly distribution and measure the thickness of the calcium. Now, you may ask me, okay, why do I need to measure the thickness of the calcium? Well, it's important to be able to measure the thickness of the calcium, because that will tell you whether you will get good expansion. And we have scoring systems. So this is one such scoring system based on OCT. And you can see that if you have a calcium thickness of greater than 0.5 millimeters, that gives you a point. If you have 4 points, then we know that expansion is going to be a problem. And you can think about the optimal way of managing this calcium, whether it be lithotripsy, cutting balloon, even rotablation. So I think it's really important that in cases where you have significant calcification, which is likely to be the case here in a patient with renal dysfunction, that you use OCT to properly assess the calcium burden, which you cannot do with IVUS. Now, the fourth part of the question is, okay, so we've assessed the mechanism, we're going to try to treat it. What should we use? Should we use drug-eluting balloon or a further stent? Now, obviously, if you only have one stent, as in this case, then you have that option. If you've had 2 or 3 layers, then you clearly cannot put another stent, and so you have drug-eluting balloon as your option. But in this case, we have the option of a drug-eluting balloon or a further stent. And this is a consensus document about treatment of in-stent restenosis using IVUS or OCT. And you can see, depending on the mechanism, will depend on whether you use a drug-eluting balloon or a stent. So if you have stent under expansion because the operator has misassessed the size of the stent, then I think it would be reasonable to use a drug-eluting balloon with perhaps a cutting balloon. If you have non-overlapping stents as your cause, then clearly another stent would be appropriate. If you have a stent fracture, then I think it would be reasonable to look at the design of the stent, and if it's one of the older, less flexible stents, then using a more contemporary stent with fewer links that allows for conformability would reduce the risk of stent fracture. Now, this is where OCT is key. If you have neoarthrosclerosis, you cannot assess this properly with IVUS. You have to have OCT. Now, depending on the type of neoarthrosclerosis will very much guide whether you use drug-eluting balloon or a further stent. So if you have a very homogeneous picture of a neoarthrosclerosis that you can assess with OCT, but you can't with IVUS, then a drug-coated balloon has been shown to have as good and maybe even better outcomes than a stent. In contrast, if you have heterogeneous, layered or lipid-rich neoarthrosclerosis and neointimal morphology, then I think very much the view of the community is that you should be using a drug-eluting stent. So assessing neointima, if it's heterogeneous, layered, or lipid-rich, use drug-eluting stent. If it's homogeneous in appearance, then I think drug-coated balloon is better. You cannot do this with IVUS. And again, when looking at calcium, you can assess the thickness of the calcium, and that will help guide your treatment, whereas with IVUS, you can't do that. It will only tell you the distribution of calcium, not the thickness. And this is quite a useful guide for intravascular imaging in guiding in-stent restenosis and stent thrombosis from my good friend, Chris Baruntis. And you can see that for many things, stent under expansion, malapose stents, looking at plaque at the stent edge, IVUS and OCT perform very similarly. However, for things like neointimal morphology, you cannot use the IVUS to assess this. And this is really important when you have neointimal hyperplasia, when deciding whether you use drug-eluting balloon or a stent. And again, if you want to assess for neoarthrosclerosis, very poor with IVUS. If you want to assess stent fracture or multiple stent layers, again, much better with OCT than IVUS. And the final question when undertaking these cases, so when you've undertaken the intervention, is whether your result is optimized. And we have guidelines. We have guidelines in that you should not land your stent in a plaque burden of greater than 50%. You should make sure there's no dissection at the edge of your stent, so not going into the media, less than 60-degree flap, less than 2 millimeters in length. We have MSAs that we aim for, and we have malapposition. So in terms of MSA, malapposition, you can equally see these on IVUS or OCT. For dissections, much better on OCT. Many watching this debate will have experience on IVUS. You sometimes cannot see dissections very well, particularly in calcific coronary disease. In OCT, you can always see dissections. So I think OCT is clearly better, but I think a key question is whether I should use OCT in a patient with an EGFR of 44. And we have data now from Japan. This is a Japanese registry that compared OCT and IVUS-guided PCI, close to 1,300 cases, and they propensity score matched patients on clinical presentation, CKD, diabetes, lesion characteristics, and looked at in-hospital and longer-term outcomes. both in terms of acute chronic kidney injury and longer chronic kidney injury. And you can see that overall, or in the CKD and non-CKD population, there was no significant difference in either acute kidney injury, so this is the OCT, this is the IVUS, or in the longer kidney injury. And in someone with only mild renal dysfunction, I think that the risk would be very low. In patients with much greater degrees of kidney dysfunction, I think it would be reasonable to use contrast-free OCT. So you could use that with saline OCT, and you get good pictures and probably better imaging than you would, particularly with some of the IVUS probes, perhaps not with HD IVUS, but certainly Eagle Eye and so forth. So I think in conclusion, the only role of pressure wire in this case is to help you decide whether you should do the PCI. I think intravascular imaging will provide information regarding the mechanism of stent failure and whether PCI is still the best option, or if there's significant left main involvement, then make a decision about whether you do the PCI or refer the patient for surgery, particularly if the stent failure is not because of another expansion, but because of intimal hyperplasia. Its mechanism of in-stent restenosis, I think, is much better detected with OCT, and it will impact your treatment strategies, and result optimization is again better with OCT. This patient has mild renal dysfunction. This is not a contraindication to OCT. In most cases, you will only need 2 OCT runs. At most, this will add 20 to 30 contrast mils to your cases if you use contrast. If you're using saline, then it's irrelevant. We know that in cases of patients with mild renal dysfunction, literature suggests that if you increase the risk of contrast-induced nephropathy only when you increase the EGFR by 3.5-fold in mils of contrast. So in this case, this patient has an EGFR of around 45. That means that we can probably use around 140, 150 mils safely of contrast without increasing this patient's risk of CKD. Only 20 to 30 of those mils, if we do use contrast, will be will be due to the OCT. So in summary, I think that I would use pressure wire for this case to assess whether I would do the case, and then OCT for the rest of the case. I rest my case and hand back to the chairman, and thank you for inviting me to contribute.
Thank you, Dr. Mamas. I think we had all the 3 wonderful talks. Dr. Mamas had to leave, so we can open the discussion. We have Dr. Tejas Patel, sir, with us. Sir, we can see you. Can you hear us, sir? Meanwhile, Dr. Nikhil, Dr. Dharmin, Dr. Naveen, Dr. Sunil, Dr. Mandip, Dr. Amit, and Dr. Alok, we can have your comments.
Hello, can you hear me?
Yes, sir, we can hear you.
My apologies for joining late because of the preoccupation, but I heard most of the talk of my friend Mamas. Yeah.
Yes, sir. So, Vineet, do you have a counter? I mean, they are saying imaging because probably you will end up doing the same. But I think Mamas was very clear. If you want to do an FFR and FFR is negative, you probably will not require either IVUS or OCT because you have strong data for the same. But an ostial lesion, as Priyank was countering, probably you would be more comfortable doing either of the imaging. Any counter on that, Vineet?
I agree. Actually, I agree with Dr. Mamas and your comments. See, physiology is very, very important, whether to decide whether this patient requires intervention. That is a step 1. That is very, very important. But how to do this PCI, whether the LM is involved or not, and whether optimizing the PCI, what is the mechanism of the restenosis and all those things, I think imaging is must in this case. So for the sake of discussion, this lectures were okay, but in fact, practically, I will do both in this case. First, do a physiology to know whether this lesion is significant or not. And if at all physiology shows a significance, then definitely, I don't think anybody will do this. Anybody should do this case without doing imaging, because to know exactly what is the extent of the lesion, to know what is the size of the lesion, what is the morphology, and then optimizing the stent depending upon the sizes and all those things.
Nikhil?
Yeah, absolutely, sir. So the most important point was to know mechanism of in-stent restenosis. For that, imaging is very important, and there are certain advantages of OCT or IVUS as far as neo intima formation or stent edge dissection, all these things. So OCT should be reasonable, provided we need to use dye in a very, need to look for contrast-induced nephropathy as well.
So there is a dictum, sorry. So there is a dictum
Yes,
when
sir,
to
Dr.
do.
Tejas Patel wants to come with his comment, sir. I thought you'll give the closing remarks.
Well, I will, I like to ask you a question. How do you diagnose that proximal osteoarthritis without angiogram? Angiogram in any case, either 30 cc, 40 cc, or 50 cc contrast. And for one injection of you in OCT, you require 7 to 8 or maximum 10 cc of busy pack to get the information which is so precious. And if you are still very much contrast conscious, you can use OCT plus IVUS in the same case, and you have characterization in your hand. And as Vinny told, if you still want to stick to the guideline, you have an FFR. So if you are thinking of safety, I don't think 5 to 10 cc of OCT will make any difference.
I completely agree, sir. And of course, as you mentioned, saline is pretty easy, and we do acute MIs with much lesser EGFR than 44. So this argument for OCT for EGFR is probably not that strongly grounded as compared to the osteal aspect of it. So, sir, your comments on osteal lesions, I mean, how good are osteal lesions to assess? Because the catheter doesn't have much margin to come back. So does osteal lesion impair in any way doing an OCT?
I don't think there is any problem, because probably I am commanding the largest series in the world for left main bifurcation PCI stenting using OCT, which is now almost touching the 100 cases. And I have done 22 cases with simultaneous OCT and IVUS, both in left main. I personally feel that the bifurcation part is best seen and the osteal part is best seen. Tissue characterization is best understood with OCT, and IVUS helps in POT in very proximal left main. This is what I'm talking about, left main bifurcation in toto. But regarding osteal LAD or osteal circ, I don't have to think much. It has to work, particularly in South Asian scenario, where the left main 95% of the time is not more than 5 millimeter. And OCT will be good for 4.5 to 5, up to 4.5 to 5 millimeter vessels.
True, sir. True. Yeah, there is a very important study, and I think, sir, you're probably part of that study, which is called as OCTIVUS trial. That's where the IVUS and OCT both were combined into one. And that's where they are assessing the utility of both imaging in one and the same patient.
Yeah, and one investigator initiated trial I am conducting, IVUS as well as OCT, IOPUS, in which we have already enrolled 59 cases with all different lesion varieties. And after 100 cases, we will go for publication. Yeah.
Fantastic, sir. Fantastic. Dr. Dharmin, Dr. Naveen, Dr. Sunil, you have any comments to add?
Yeah, I think
Sunil. Yeah.
As discussed, mechanism is very important when the stent failure is there within 1 year of time. So even with IFR, any pressure wire testing negative, I like to do imaging to know what is the cause for stent failure. If we see there is significant under expansion, then obviously even if the FFR is negative, I will not like to leave a significantly under expanded stent at osteal LAD location. So mechanism remains most important, be it with IVUS or OCT. But to look at what is the mechanism for stent failure within 1 year remains significant, particularly when it is osteal LAD lesion.
True. Any other panelists, or we can have closing comments from our chairperson, Dr. Tejas?
Last but not the least, Kamal.
Yes, sir. Yes, sir.
It is very important. But heart is also important.
True.
And that proximal LAD area where you can miss anything.
Right, sir. Right. So I think we've got the important message from all our chairpersons, including Dr. Tejas Patel, sir, and Dr. Nikhil, Dr. Dharmin, Dr. Naveen, Dr. Sunil, Dr. Mandip, Dr. Amit, and Dr. Alok. We had wonderful talk by Dr. Priyank, also Dr. Vineet, and our friend Dr. Mamas. So that gives us the message: restenosis, always image. OCT, don't be worried if it's osteal or creatinine 2 in the borderline range, but always do physiology if you think that the actual case is borderline. So that's why we had a case which was fitting for all cases in to talk about 3 important physiology. So that was the concluding message, and based on that we have kept a quiz, as I said, and the question for the quiz goes live now. So as we said, we are doing quiz all throughout the program. For every bout that is done, there is a question based on the same, so that it just gives you a summary and you get illuminated about the same topic. So in Illumine study, amongst the patients who underwent the FFR and PCI between OCT and IVUS, Illumine was one of the important trials. Which modality achieved better stent expansion? I think Dr. Mamas had touched upon this, but the quiz is active on the delegate, and there is a Q&A click. You can click on that option and then choose the option. It's live till the next quiz comes up. Till that time, you can fill up, and the total, the delegates, whosoever gets the highest top 3 rankers will get the prize. So A answer was option was OCT, B was IVUS. Both achieved similar and both were good in post dilatation without imaging. So the right answer for the same is both achieved similar expansion. This was published in JACC, not surprisingly in Illumine 2. Both methods achieved a similar percentage of expansion, and IVUS OCT was compared. This was by Mahera et al., where they compared which one of the 2 was doing better modality. So I think extent expansion is pretty okay with both of them, but imaging is an important aspect in the whole thing. So thank you. I thank from the core of my heart, bottom of my heart, Dr. Tejas Patel, sir, and all our panelists and speakers, Dr. Mamas, Dr. Priyank, and Dr. Vineet, Dr. Nikhil, Dr. Sunil, Dr. Mandeep, Dr. Amit, Dr. Alok, Dr. Dharmen, and Dr. Naveen for making this such a wonderful and session to enlighten all our audiences about physiology and imaging. Thank you very much. And I now move to the next session, and I invite the chairpersons and speaker for the same. So the next bout is hemodynamic assist devices in cardiogenic shock. We all have been facing some shortages of IABP, and there is also a problem of the cost with the Impella. So where do we go? So this is a case of hyperacute anterior wall MI, 34-year-old male, presents with history of fever 2 days back, pulse of 120, blood pressure 88/55 on inverted commas, low dose NORAD. We need to know what is that. Saturation 94, bibasal Krebs, Killip class 3, intubated on mechanical ventilation, had a hospital primary VT, reverted with DC shock, shifted to cath lab, pH of 7.25, lactate of 8, echo shows moderate ischemic MR, severe LV dysfunction, LAD territory, anterior territory, hypokinetic. Preferred mechanical assist device for primary PCI in this cardiogenic shock would be, we'll have Dr. Rupesh Singhal speaking for IBP, and my friend from USA, Dr. Aditya Bharadwaj, who's a chip operator. He's been doing a lot of Impella. He's joining us for the same from Loma Linda University, USA, with the Impella. So for the session, I invite our chairperson, Dr. Darshan Banker, another academician. Very high regards for you, Dr. Banker. Dr.
Thank
Pujan,
you.
a good debater. Dr. Siddharth Singh Wala, high volume operator from Bhavnagar. Dr. Abhishek Raval, Dr. Dennis from Rajkot, and Dr. Parminder from Nanded. So over to you, Dr. Banker, and the chairpersons for this carrying this forward.
Thank you, Kamal. You have been a great academician yourself and has been a torchbearer for Gujarat for a lot of academic presentations all throughout. And as you rightly mentioned that we are facing a big, I would say, crisis in supply of intra-aortic balloon. And obviously, there is a prohibitive cost to Impella. Where do we go? That is I think more of a social question than an academic question. But with still that, I would request Rupesh to start the session. A very dynamic and very academically very sound fellow. I know him personally also very well. So Rupesh, please give us insights into IABP, because I think still for another 3 to 5 years, we still will continue with IABP as our main armamentarium to treat patients in cardiogenic shock.
Thank you, Dr. Banker, sir. Thank you for the kind introduction. And with the permission of the chairpersons, I would like to share my screen. Yeah. So the case, so it's a young chap, 34-year-old with the cardiogenic shock. He's in Philip plus 4, already on inotropes with increased lactates. We have well-documented evidence of systemic hypoperfusion. His lungs are all congested. He's already intubated, had a primary VT, DC verted, with severe elbow dysfunction and moderate MR. And yes, he's being attempted for the primary PCI. So again, this is a very classical and unfortunately a rather common scenario that we face. And it is important that we realize what can we do about this. So Sky has recently come up with this, has recently modified, actually, this was an expert consensus, this has been modified. And the pyramid identifies and classifies shock. Stage A is a patient which is otherwise hemodynamically stable, but has a risk for cardiogenic shock, like patients with an acute MI or decompensated heart failure. Patients who have hemodynamic, stage B is hemodynamic instability without evidence of hypoperfusion. Stage C is systemic hypoperfusion. Stage D is patients of stage C which deteriorate despite doing some intervention or escalation of therapy. And state E is extremist shock. So unless a patient comes with out of cardiac arrest and with an anoxic brain injury, wherein the patient will be directly classified as stage E. Otherwise, by default, patients with systemic hypoperfusion end up being classified as initially as stage C, and then they are either they deteriorate to stage D or improve to stage B. So Sky has again in that expert consensus set a 3-axial model of prognostication and evaluation of cardiogenic shock. We need to identify the phenotypes and etiology, whether it's an acute and chronic etiology, clinical etiology of the cardiogenic shock, right ventricular type, LV type, or biventricular failure, cardiac versus cardiac pulmonary failure, congestion profiles, and biochemical phenotypes. The severity of shock, the staging of shock can help you identify this, and the various risk modifiers like age, comorbidities, cardiac arrest, presence of other organ failures, and infections. So this entire staging is a continuum. The patient can either improve or deteriorate in either ways. So there are deterioration paths and there are recovery pathways. So when a patient with cardiogenic shock comes, so coming slightly back to our case, acute myocardial infarction with cardiogenic shock, our aim is to provide circulatory support, increase the mean arterial pressures. We do this by inotropes. Our patient is already on inotrope. We can add an IBP or ECMO or Impella. Yeah. Hello. And then we can, because of the congestion, we can unload an LV. Am I audible?
Yeah, Rupesh, go ahead. Prashant, you can mute.
Yeah. So we can, put in diuretics, inotropes, IBP, and Impella to unload our LV. And we can obviously, the most important, improve coronary perfusion. This is again done by PCI or including CABGs. So again, from this consensus, they have presented this algorithm in which patients with acute myocardial infarction, whether undergoing a high-risk PCI or having a clinical evidence of shock, they have put forward an algorithm to follow. It is said that using MCS prior to PCI or in patients with cardiogenic shock helps, and that is what has been said in this algorithm. So what are the MCS devices which are available to us? IBP has a modest increment of only 0.5 in the cardiac output and power. Impella CP, tandem heart, and ECMO with increasing, LV assist that they can provide. So what are the various mechanisms? We all have undergone this. This is a slide which has been presented again and again over various meetings, and we are very familiar with this. Let's stick to our question and let's look at IBP and Impella. More or less very similar. Impella, no doubt, has a better power or better efficiency. I wouldn't say efficiency is that, but it is more potent in its way to increase the arterial pressures or improve the cardiac output. So, but is IBP bad? No. So, what is the basic physiological? The augmentation has been around for good old. The concept of augmentation was started in early 1960s. So, I guess it predates me and my colleague. So, an IBP has been around for a good 50 years. And the logic of using IBP has been very clear. So, IBP will improve the coronary perfusion and decrease the left ventricular afterload, and a combination would allow a better coronary perfusion and decrease the myocardial work. So over a period of time, we have seen in various studies and practically also that IBP has been used for cardiogenic shock in patients with acute MI, in post-infarction cardiogenic shock, for LV unloading, refractory ventricular arrhythmias, perioperative care during cardiac surgery, and even for non-ischemic cardiogenic shock or non-ischemic heart failures, and also as in support for high-risk PCI. So what do the guidelines say about IABP? It is interesting to know. I was just going through the historical data, and it was said before the days of reperfusion or PCI, IABP was actually shown to improve mortality. But as we had more potent ways of revascularization, the benefit then started getting clouded, probably because reperfusion had a stronger effect. So before 2004, IBP use was a class 1 in recommendation in cardiogenic shock. However, in an update of that same 2004 guideline, it was slightly downgraded and to a class 2A. Similarly, this was the US guidelines. In the European guidelines, till 2008, IBP was a class 1. In 2002-10 onwards, it was downgraded. A majority of this discussion about IBP started after the IBP Shock 2 trial, in which, after which the use of IBP was downgraded to class 3. And in both the 2014 and 18 guidelines for myocardial revascularization. And however, they have said that it is still considered or a class 2 indication in patients with an acute myocardial infarction with mechanical complication. This is the ACC guideline on myocardial revascularization. That is the last available version. It says on IBP, in selected high-risk patients, if elective insertion of appropriate hemodynamic support as an adjunct to PCI may be reasonable. So it's a class 2B indication. I would also point out or bring to your attention the paragraph or the text that follows this, and it has said that Impella, though provided better hemodynamic support, but unfortunately was not able to translate into a better mortality. A lot of data with IBP and a lot of data with Impella as well now. Unfortunately, cardiogenic shock is a milieu which is very hard to study in randomized controlled trials. So a lot of these studies have been retrospective in nature, a lot of meta-analysis, and a very variable kind of result. So, but there are enough studies now which showed that IBP had mortality reduction in patients with failed PCI or in high-risk patients undergoing PCIs for acute myocardial infarction. Similarly with Impella, again, the data is slightly dicey. It's more of the use that has been coming up because of various factors, because of the kind of support and the pathophysiology that Impella offers. Let's compare the two. So this is a whole timeline of the studies that have compared the various mechanical circulatory support options in acute myocardial infarction and cardiogenic shock. And so let's look at some of these trials. In the Aisha shock trial, a small study with randomized patients to IBP or Impella 2.5, effectively no survival benefit. Though it was documented Impella had a better hemodynamic support. The IBP Shock 2 trial, again, though this does not compare, this was the study which drove IBP out of fashion, and they had around 600 patients and they classified it to IBP versus no IBP. But though a lot of talk is based around IBP shock 2 trial, the study had its limitations. Firstly, only 70% of the enrolled patients presented with STEMI, and among these, more than half had a non-interval myocardial infarction. The timing of cardiogenic shock development has not been clearly documented in this study. IBP was implanted after the PCI in almost 90% cases, which is not what is recommended. We all now recognize that IBP insertion prior to the PCI may help, or for that matter, even Impella insertion prior to the PCI helps more. Fourth, almost 50% of the patients enrolled a resuscitated cardiac arrest, and which is a very bad milieu on stage E extremis shock. Again, the median duration of counter IBP use was 3 days, and most of the deaths that occurred after this period. Also, there was a lot of crossover from IBP to non-IBP to IBP group. And so apart from this, statistically speaking, the mortality rate in the control group was only 41.3%, which was less than the assumed mortality rate of 56%. So this brought down the power of study from 0.8 to 0.6. And that is why, like, though we can, it's an important study, we pay due respect and regard to it. But
time is someplace. Yeah.
So again, IMPRESS, IBP was Impella, no mortality benefit. So somebody compared like Impella support in IBP shock to matched patients, and they found that again, no mortality benefit, higher vascular and bleeding complications. So this is a meta-analysis for IBP use, IBP versus non-IBP, and IBP versus other LVADs, predominantly Impella. And the forest plot shows effectively there is no statistical difference. A lot of other studies comparing IBP versus Impella, mostly retrospective in nature, as I said, because of the milieu of the disease, and unfortunately, none of them very definitive. So some trials addressing this, let's see what light they shed. Practically, I guess it is the timing of insertion is very important. In early pre-shock state, IBP insertion might help. Again, I would like to point out the statement, IBP insertion should be considered in acute MI complicated by cardiogenic shock when other mechanical circulatory devices are not available, which is the case in here, which is likely the case with my patient as well. So 2 position papers, one is from EAC. Again, I would like to point out IBP should be considered if other devices are not available. This is from AHA. They also say IBP or Impella in their cardiogenic shock algorithm. So IBP is not out of the picture. Impella has a better hemodynamic support, but I don't know if that translates into mortality benefit. So this is probably Dr. Bharadwaj will speak on this. This is Impella has been, so this started with Detroit. I mean, as a Detroit cardiogenic shock initiative, they put forward the concept of shock teams and the shock algorithms, and they did show some benefit, like compared to their institutional history. This was later translated into the National Cardiogenic Shock Initiative, in which I find my colleague as one of the authors. And so they have said that there is some mortality reduction and better results. Unfortunately, this is a single-arm, non-randomized study. And of the almost 280 patients, if I'm not wrong, only 171 were randomized. So a lot of gray area here. And really, let's reread the question. What is the preferred device? Preferred device should be available, should be accessible to the patient, should be actually feasible. In our case, IBP is good enough. That's the only one which is available. And I don't think so Impella would do any other magic that IB cannot do.
Thank you, Rupesh. Thank you. Dr. Aditya, can we have your talk?
Yes. So first of all, thank you, Dr. Kamal Sharma and all the organizers. I think this is a fantastic meeting, and I tuned in a few minutes earlier, and I heard the previous session as well. So this is very educational. So and thank you for the opportunity to be here. It's indeed a pleasure to be here, and a great presentation on IABP, Dr. Rupesh Singhal. I hope you guys can see my screen. So I'm going to be talking about Impella and, arguing that Impella is the best strategy in this patient. So like it was mentioned initially at the beginning of the talk, I practice here at Loma Linda, California, and we are in the southern part of California, and we are a pretty big cardiac program. We do about 100 Impellas a year, which includes both high-risk PCI and cardiogenic shock. We also do LVADs and heart transplants. So pretty busy program. So I'm not going to go over the details of the case, which was already discussed, but just to sort of highlight some of the key takeaways and summarize what this case is talking about. So this is a case of acute MI with cardiogenic shock, which is very important. Sometimes we tend to put all cardiogenic shocks in the same bucket, but it's important to distinguish the etiology of cardiogenic shock. Acute MI is very different from acute decompensated heart failure or myocarditis type of cardiogenic shock. So this is AMI cardiogenic shock, number one. Number two, it is SCAI stage D, C to D. I would argue that this is D. I mean, initially he has been tried on vasopressors, like Dr. Sharma mentioned, low dose noradrenaline. A lot of times we get transfers from other hospitals saying that, the patient is on low dose noradrenaline, and you get the patient and they're on 25 mics per minute. So I think this is SCAI stage D. The patient also has moderate MR. And more importantly, the patient has a lactate of 8, which is a very important thing to recognize, that this patient is pretty far down in the spiral, the death spiral of cardiogenic shock, as it is called. There's a lot of data to show that lactate is an important predictor of mortality in these patients with cardiogenic shock. And anytime the lactate is more than 4, that actually means that the survival is under 50%. So a lactate of 8, I would say this patient's mortality is very high unless you pull out all the big guns and treat him very aggressively. So I am going to be talking about Impella, which is the best strategy, but this is sort of going to be what the agenda for my talk is going to look like. So first we'll look at the comparison of MCS devices, which was already touched upon previously. We'll focus on the Impella family of catheters. We'll talk about the hemodynamic benefits of Impella, which is, I think, very important. We'll talk about the best practices for use of Impella in cardiogenic shock. And finally, I think, we're talking about balloon pump and Impella in this case. Some people might argue that this is a case where we would go straight with an ECMO because the patient has hypoxic respiratory failure, has advanced cardiogenic shock. So would ECMO be an ideal choice as the initial MCS in this patient? And I think that is reasonable. But even if you do that, there is a role for Impella for LV unloading, even in the presence of ECMO. So I want to touch upon that as well. So I'm not going to, belabor the contents of this slide because I think everybody is quite familiar with this. But just to sort of drive home some key points, I think what we do need to realize, just a comparison between balloon pump and Impella. So balloon pump only modestly increases the cardiac output, at best maybe about half a liter per minute, as compared to Impella, where, depending on what type of Impella catheter you use, most commonly we use Impella CP, which is the one that is implanted in the cath lab for cardiogenic shock, and that improves the cardiac output by about 3.5 to 4 liters per minute. There are also the surgically implanted Impella devices such as 5.0 and 5.5, which I'll touch upon in a little bit, which provide a greater cardiac output of up to 6 liters per minute. But I'm going to talk about the hemodynamic benefits of Impella. But before we do that, let's quickly look at the devices in the Impella family other than CP and 2.5. So like, 2.5 was the initial Impella that came out, provided cardiac output of about 2.5 liters per minute. Pretty much, I think most centers across the world have stopped using 2.5 at this point. Definitely not indicated for cardiogenic shock where you need higher degree of cardiac output support. So for cardiogenic shock, our go-to catheter is Impella CP, which, like I said, provides about 4 liters of additional cardiac output. And in addition to these, there is the Impella RP, which is the right-sided support device, which basically is indicated in patients who have acute RV failure leading to right-sided shock. And it was traditionally implanted through the groin. Now there is the Impella RP Flex, which is being implanted through the IJ. It is still being studied in a few select centers and will hopefully be available in the market sometime soon. Then there are the surgically implanted devices, Impella 5.0, LD, and 5.5 with Smart Assist. So this is just a comparison of the devices. Like I said, RP is a right-sided device, 22 French, and insertion method, like I said, percutaneously via femoral vein. Impella 5.0, LD, and 5.5 are all left-sided devices, provide left-sided support, provide a forward cardiac output of about 5 to 6 liters per minute. And these are surgically implanted. So either you need an arterial cut down, most commonly implanted through an axillary cut down. And the advantage of these devices is that they provide greater degree of cardiac output and they allow for patient ambulation. So a lot of patients who are waiting for a heart transplant, waiting for recovery, get an Impella 5.0 or 5.5, which can be left in the patient for several weeks, hoping that their LV recovers. So like I said, it's most commonly implanted through axillary cut down in the OR. So let's quickly take a few minutes to review the hemodynamic benefits of Impella, which I think are quite unique compared to the other mechanical circulatory support devices that we have available. So first and foremost, it increases the forward flow and the mean arterial pressure, like we've talked about, as a result of which it increases the cardiac power output and increases end organ perfusion. But more importantly, something that is quite unique to Impella, which no other device does, is it draws blood from the left ventricle and expels it into the aorta. So by that action, it decreases the left ventricular end diastolic pressure and end diastolic volume, which has a lot of beneficial effects. So decrease in LVEDP and LVEDV result in decreased wall tension, which causes decreased microvascular resistance, which in turn increases myocardial perfusion and decreases pulmonary congestion, both of which increase the oxygen supply to the myocardium. Additionally, Impella also decreases the mechanical work of the heart, as a result of which the myocardial oxygen demand is further reduced. And I am going to explain this in a little bit. We'll come back to this in a second, but there's an important term that needs to be understood, and that is called cardiac power output. Cardiac power output is basically mean arterial pressure into cardiac output divided by 451. And Impella increases the cardiac power output. So just remember this formula because it's a very important formula, which is part of the NCSI algorithm, which I'll talk about in a little bit. So the ISAR shock trial was talked about. So this was a trial looking at Impella 2.5. Remember, not the CP. It was the 2.5 versus balloon pump. It was a small trial, which was definitely underpowered to detect any clinical outcomes. But we do have some other data from this trial, which showed that in the Impella 2.5 arm, when patients were supported with Impella, the Impella actually augmented the cardiac output by about 2.2 liters per minute. And like you can see here, when somebody is put on Impella, what happens is that the patient's native cardiac output or the native cardiac index goes down. So in other words, the patient's native heart is resting and is able to recover when they're having an acute MI, whereas Impella takes over the function of the heart, as opposed to balloon pump, which augments the native cardiac output by a little bit, but it's certainly not taking away and is not reducing the work of the heart. So this is a pretty nice illustration of how Impella improves end organ perfusion. And this is what is called a side stream dark field imaging. And this actually looks at the sublingual circulation. So this is the sublingual circulation in a patient with the Impella device turned off. And after 48 hours of support, you see how Impella has improved the end organ perfusion, recruited all these capillaries, and there's nice robust flow in all the different branches. So This is an important illustration because, again, it helps us put things in perspective as to what exactly the Impella device does. So there are two things that we need to recognize when we're treating patients with cardiogenic shock. One is hemodynamic support, which is important. You want to sustain life. And number two, there's something called myocardial protection. So with ECMO or with balloon pump, like I said, what it does is it's not really letting the heart rest or recover, as a result of which, you're really not protecting the myocardium. So Impella is the only category of MCS devices that protects the myocardium. And what I mean by that, let's go back to the pressure volume loop. Not to go into great detail with this, but I think it's important to touch upon this. So I think we're all quite familiar with the PV loop, where you have left ventricular volume on the x-axis and left ventricular pressure on the y-axis. And so this is the diastolic filling.
Aditya, we are short of time. If you can just
sure, I'll quickly go through these. So the pressure volume area is basically a sum of these two pressures here. So it's the stroke work and the potential energy. Stroke work is a measure of the mechanical energy, and potential energy, like we know, is the stored energy. So what pressure volume area is, it's a sum of these two. And in the interest of time, I'm going to quickly go through these. What Impella does is it basically modifies the pressure volume loop to look like this. So it's narrow and it's taller, as a result of which it's reducing the pressure volume area, reduces the mechanical and potential energy, and reduces the myocardial oxygen demand. Now, in addition to that, as a result of active unloading, the wall tension is decreased. And when you reduce the wall tension, there's reduced microvascular resistance and increased myocardial oxygen supply. Not to go into the details of this, but basically this is just, again, another illustration on a perfusion scan with Impella turned on, where you have nice recruitment of capillary flow, and the perfusion defect actually goes away. So far, I've just been talking mostly about all the physiology. So let's quickly review some data before we wrap up. So the National Cardiogenic Shock Initiative, I think, was mentioned previously. We were part of this at Loma Linda. So it's a prospective, non-randomized, single-arm, multi-center study. We enrolled about 406 patients. 697 patients were excluded, mostly because of standard inclusion-exclusion criteria. I'm not going to go into the details of this, but I think this is sort of the meat of the matter, if you will. So this is the NCSI algorithm, which stresses on rapid identification of cardiogenic shock, cath lab activation, femoral access. You confirm the diagnosis of AMI cardiogenic shock, and you insert the mechanical circulatory support. So like we have door to balloon time of less than 90 minutes in STEMI patients, in shock patients, our aim should be to provide a door to support of less than 90 minutes. So like it was previously mentioned, very important to initiate the mechanical circulatory support before you do PCI. Now, one of the really groundbreaking things about NCSI is that it put a lot of emphasis on right heart cath, which is very important. How else will you make decisions on escalation or de-escalation of MCS in patients with cardiogenic shock? So there are two important metrics to remember. There's the cardiac power output, and there's pulmonary artery pulsatility index. So cardiac power output tells us how the overall heart is doing, and pulmonary artery pulsatility index, or PAPI, tells us how the right ventricle is doing. So the algorithm is here. If you have any questions, you can reach out to me even later on. But basically, if the CPO is less than 0.6, that means that you either need to consider RV support if the PAPI is low, or if the PAPI is okay, you need to consider increasing the LV support. So what we really want to achieve is a CPO of greater than 0.6 and a PAPI of greater than 0.9. So why is NCSI so important? So this is a comparison of the survival in all the previous shock trials. So the shock trial, the culprit shock trial, IABP shock trials, historically, the survival of patients in cardiogenic shock at 30 days has been in the 40 to 50 range. But if you actually look at these curves, the curves on top are the NCSI survival curves. All the way at the top is Sky Stage C and D, which had survival of 77%. And if you look at all comers, which also included Sky Stage E, the survival was 68%. So clearly a signal towards increased survival as compared to all the prior shock trials. This is how these patients were enrolled. We were, like I said, one of the enrollers, and this is the publication. Our final publication is in consideration right now at JAC Interventions, and hopefully should be out soon. But in the interest of time, I have a few more slides before we wrap up. And this is an important point to make, because even if you go with an ECMO, like I said, ECMO increases after load, and it actually is detrimental to the pathophysiology of the heart in patients with cardiogenic shock. So Impella should be considered for unloading even in the presence of ECMO, the so-called ECMELA or ECPELA, and there is actually data to suggest this as well. This obviously is not a randomized controlled trial, but this is a large registry of patients showing that an ECPELA strategy or an ECMELA strategy is associated with better survival as compared to just VA ECMO alone, despite an increased risk of vascular and other complications. There was improvement in survival. So in conclusion, Impella actively unloads the left ventricle, increases cardiac output, improves end-organ perfusion. Most importantly, it helps with native heart recovery by decreasing myocardial oxygen demand and improving supply. If you are using Impella, it's very important to follow best practices in cardiogenic shock: early identification, Impella pre-PCI, use of right heart cath. I think without a Swan-Ganz catheter, you cannot make any decisions. And finally, Impella is recommended for LV unloading even in the presence of VA ECMO for all the reasons that I just mentioned. Thank you.
Thank you, Aditya, for wonderful talk. Over to chairpersons for some discussion. Dr. Banker.
Yeah, and both were very great presentations, and keeps us confused as usual, which is better. But for us, as of now, we have very limited use of Impella anywhere in India. Especially, we don't have an experience of using Impella. But whatever we read, it seems as of now that Impella does improve hemodynamics to a great extent, but increasing or improving mortality benefits, we still need further studies and larger studies to prove its worth for the cost we are going to pay.
Yes, absolutely, Dr. Banker. I think that is a great point. And like Dr. Rupesh Singhal mentioned, there is the Recover 4 trial that is coming, which is going to be a global randomized controlled trial, which is going to be quite a game changer, because Abiomed was able to get FDA to approve waiver of consent. Like we know, in patients with cardiogenic shock, enrollment is always a challenge, because these are sick and dying patients. And how do you enroll somebody into a clinical trial in that situation? So Abiomed was able to negotiate with FDA, and they have a waiver of consent where these patients can be enrolled into the trial and retrospectively consented if they survive. And this is going to look at Impella with right heart cath strategy versus non-Impella. And hopefully with this randomized controlled trial, we should have, good insights into survival.
I also see Dr. Abhishek and Dr. Parminder. Your comments?
Yeah, there were two lucid presentations, and both have emphasized on correct points that Rupesh has said that as the IBP shock trial was a game changer, and IPA was the trial who make the status of IBP downstage in the current guidelines. However, that trial was, as Dr. Rupesh has suggested, there are several lacunes, like in most of the patients, the IBP was inserted immediately or later on post PCI. The mean proper time duration was also not important, and still, as our experience is in that field shows that still IBP also leads to at least better peri-procedural comfort as well as post-procedural and till hospital discharge. However, as the trial suggested that there was no clear-cut implication of that on the benefit of mortality. Now, still, as Dr. Bhardwaj suggested, that we are in the wait of seeing the great results of Impella in future trials in the short future. Once these trials regarding the Impella are out, especially the trials which truly shows the randomized results, and these trials will enlighten our knowledge and insight regarding the impella as well. So as Dr. Bhardwaj has suggested, looking to the numbers, the cardiac output generated as well as the indices, the impella definitely does better. However, the ease and feasibility of using is more with IBP. So these kind of debates will better going on and on, and the future trials and studies will throw more lights on in this regard. Thank you.
Same. Dr. Parminder, you have anything to add? Please unmute yourself here. Yeah.
Sir, I fully agree with the chairperson and Dr. Abhishek also. Like considering the clinical outcomes and the scenario in our setup, and for all practical purpose, IBP also definitely has a role. Though Impella definitely provides better hemodynamic support, but use of IBP cannot be ruled out. Like,
Dr. Darshan, if you could conclude, and then we can move to the quiz.
Yeah, thank you all, especially Kamal, for organizing such a fantastic interactive session. And thank you all, both speakers, Singhal and Bharadwaj, for giving us so many insights. And we would be excited to use Impala in near future, especially for patients who deserves it. And we see so many young acute MIs, and we can help them by giving an option of Impella over a period of time. So it was quite an exciting session. Thank you. Thank you all.
Thank you. So we have a question based on this debate. The IBP Shock 2 trial, which was talked about by both the speakers, I think they did not touch upon was the trend towards that P of 0.06. There was a trend towards outcome being lower in IBP arm for one of the outcomes, and you have to choose which of them was. The quiz will remain live till we get to the next quiz, which will be another quiz after the all women in cardiology session that we have, all women panelists, women patient, and women care. So women deserve the equal right and probably the bigger right to the dominance in cardiology. And that's the reason we've been promoting at CardioCon one all women in session there, where we have not exclusively only for that session, but even other sessions, we do have women participants and chairpersons and speakers. But all 4 years we've been there for supporting the cause. But till we do that, this question will be live when that question comes up. And the options are all cause mortality, stroke, LV ejection fraction, and CV mortality. So you can choose what you think is right. This quiz you can play along on the Delegate app on the Q&A section on the right side of your screen, which is there on the Delegate link as it's being live streamed. So for the sake of the audiences who have played it along, and the time that's been there for choosing that option, answer is stroke actually. So this was the all-cause mortality at 6 years was 66.3 versus IBP of 67, but stroke at 6 years was lower with IBP. I'm surprised why a stroke would be lesser, almost by 5%, though not reaching statistical significance, but very strong trend towards significance with 1% versus 6.2% in the IBP versus no IBP arm. And this was published in an EJM in 2012 from the IBP subgroup analysis itself. So thank you very much, all the chairpersons. And now we are moving to a very important session, which represents half the humanity, the better half of ours, women in cardiology. And for this session, we have an elite panel. I invite Dr. Aisha Kader from Bangladesh, Dr. Sonali Inamdar from Pune, Dr. Nikhila Panchali from Rajkot, Dr. Rujuta Parikh, and Dr. Pallavi Majan from Ahmedabad, all are interventional cardiologists. Our moderators are Dr. Parul Bhatt, she's head of the Department of Medicine at Sola Medical College, Dr. Neha Sharma, my better half, my wife, and she's associate physician with us, and Dr. Bhumi Patel, she is a clinical cardiologist working with us. Over to chairperson. This is a clinical case scenario, 65-year-old female with hypertension and dyslipidemia presented with atypical angina, non-specific STT changes in inferior lead with ejection fraction of 65%, no evident regional wall motion abnormality, severe bilateral osteoarthritis knee, best modality for coronary artery disease evaluation,
rather than invasive angiogram would be Dr. Pooja Vyas will talk about pharmacological stress echo. Dr. Purvi Parwani will be taking us through stress CV MRI, and Dr. Megha Sheth will talk about CT choreangiogram, while Dr. Swati Raj will speak on stress radionuclear imaging. Over to chairpersons. Dr. Aisha, over to you.
Thank you very much, Dr. Kamal Sharma, for the opportunity once again to be a part of this very interesting program of yours, and also to chair this session. Interestingly, today is also International Day of Women and Girls in Science, so you picked the best day for the best session. And on behalf of my co-chairpersons and co-moderators, without much ado, we will first move on to our first speaker today, who is Dr. Pooja Vyas. And thank you for presenting the scenario. It's a very interesting scenario to be debated. And I will hand it over to Dr. Pooja Vyas, who will speak on pharmacological stress echocardiography would be the best choice in this patient. Dr. Pooja, you can share your slide.
Yeah.
Is there?
I think there is some problem.
Okay, no problem. I think, can Dr. Purvi go ahead and present her scenario? Dr. Purvi? Technical team, can you get in touch with Dr. Pooja and try to help her?
Yeah.
Over to Dr.
Purvi, you need to unmute.
The most common phrase used in Zoom world every time gets used on me. Good morning, everyone. Very happy to be here again, speaking on the same thing, but I promised I have added some more literature for you to review. So I'll be speaking about why stress CMR in 2023 is the best stress imaging modality. So my disclosures are that I am a multimodality imager, so I practice all the imaging modalities. But apart from that, what's close to my heart is, of course, cardiac MRI. And what I'll try to do during this debate is I'll try to give you the evidence that's out there for all the imaging modality and let the science speak. So the case that has been given to us is a 65-year-old female. She has hypertension, hyperlipidemia, unfortunately has a severe arthritis, probably is menopausal given her age, and she has atypical chest pain. Her EKG has non-specific STT changes, and the question that is posed in front of us is, what's the imaging modality? And also in the bracket is given rather than cardiac cath. And I have several problems with this. So of course, number one is there are no atypical symptoms. If the symptoms are present in a larger population, the symptoms are different than what we have known, but they are not atypical. Number two is I don't like the comparison with cardiac cath because gone are the days where anatomical testing used to be superior to any of the stress imaging. It is probably true for the macrovascular disease, but no more for combined ischemic cardiac disease. So the question that we are asking is, if this patient comes into my clinic, what my objectives in my mind are, I want to tell the patient what's the cause of chest pain. I want to figure out what's the cause of these non-specific STT changes. How do I get this patient most information without doing many testing? So with one test, can I answer all these questions? What's the overall prognosis for this patient given these changes on the EKG? And what exactly does the patient need next? Whether it is anatomical testing or, before going there, probably a medical management. So when we look at the stress imaging modalities, I think what we need to look at, what is the accuracy of the test? what's the safety of the test, whether that test is appropriate or not, given the patient's clinical context, what's the management and prognostic implications, and whether that test is cost effective or not, because we all will agree that across the world, whether it is United States or in India, cost has become a big issue for healthcare, and we want to help as many patients as possible at as minimum cost as we can. So I think what I'll try to take you through, we have been given 4 imaging modalities, cardiac CT, stress echoes, SPECT MPI, and stress CMR. And I will tell you what are the issues with others, hopefully make a case for myself by showing you the evidence. So let's look at the evidence, right? So if we look at the ESC guidelines for chronic coronary syndrome, meaningly angina, where does this patient fit? Unfortunately, we go back to the pretest probability data where this was defined by typical, atypical, or non-cardiac chest pain. And this patient is a 65-year-old lady, but we are told that she has atypical chest pain. So her risk is 11%. By definition, it falls into the low risk category. But if we take into consideration her postmenopausal status, probably I would put her at a higher risk, particularly for the overall ischemic heart syndrome, not for the macrovascular disease. The other thing is that this patient actually, in spite of whatever likelihood what we may say, she does have resting EKG changes. So that again, changes the overall pretest probability for the testing that you're going for, because you want to figure out why there are ST changes given on that EKG. Now, we are not being given the information on the EF, etc. Further looking at the guidelines say that the non-invasive testing, this is both European as well as US guidelines, that you should consider non-invasive testing only if there is high pretest probability, if there is local expertise and availability, and if there is a viability assessment required. And I would say that given the amount of information that is given for our patient, I'm not sure if her EF is normal. I am not sure, what exactly this chest pain entails, and I would put her risk, higher, given that she's a postmenopausal woman. So if we look at overall sensitivity and specificity data for different imaging modalities, of course, here, there is a lot of variability. There are a lot of testing done since back in the day in 1990s, when many imaging modalities like cardiac MRI was still developing. So the numbers are all over the place. But I'd like to show you this paper in SERC, where they compared CMR and SPECT. And if you look at the sensitivity, right away, you can say that CMR has better sensitivity compared to SPECT. And when it comes to specificity, it's actually, they are both kind of the same. So there is higher negative predictive value with CMR, and that's probably because it's able to tell you about the vasculature, and it also does not have any phenomena like total ischemic dilatation or TID, as we know. So there is no balanced ischemia phenomena that we see with CMR, the way it works, and hence the sensitivity of CMR is much higher. Even with a negative CMR, you can tell 87% of the time, higher if you look at the recent studies, that a patient has no evidence of ischemia at all. This is a paper, again, kind of on the same category, that this was published in Lancet. And if we look at macrovasculature, single vessel disease, triple vessel disease, left main disease, CMR was better than SPECT when it came to accuracy. Now, one of the things that accuracy, should take into consideration is less variability, because I think everyone here in this audience would agree that one of the main concerns with imaging testing, whether it is cardiac CT or its stress modality, is the variability between the readers, right? So whether it is the test is read in US versus in India, the test, the way it should look, whether the findings are subtle or or very abnormal, it should be read consistently. And this is what was shown in this paper by Dr. Andrew Arai in JACC, where CMR really had excellent sensitivity, specificity, and excellent area under curve, showing that stress CMR actually is less variable compared to any other modality. And here I'm speaking to you, stress echo. So what about the safety? So of course, when I have looked up the nuclear stress testing in India, the predominant option yet given is stress thallium. And that makes me very worried because the amount of radiation that is given with thallium testing is extremely high. And in my opinion, it should not be done. I think the nuclear testing probably, if you ask me, has a chance with stress PET, but otherwise, the amount of radiation with nuclear testing, both SPECT, whether it is thallium or any other nuclear tracer, it is so high that I don't think there are gone are the days when we do it. Particularly in United States, I can tell you it's being done because of the financial incentives provided by the government, by the Medicare insurance that is given to anyone above age 65. So now let's look at how does the CMR compared to cardiac cath. And if we look at the FFR group, not just with the solid macrovascular disease, but also with the intermediate disease, where FFR was positive, CMR in this NEJM paper did excellent and provided that information, not only with the management, the referring provider was able to decide which are the patients to be taken for the stenting or for further intervention. Also, it gave excellent information about prognosis compared to FFR. So even when we look at the management and the prognosis, CMR is able to do really well. And because of this excellent prognostic value, the added advantage is that there is less downstream testing. If you are a referring provider, if I am a referring provider for a stress imaging modality, and when that stress imaging modality is negative, I should be able to sleep at night that my patient does not have any macrovascular disease, that they are gonna drop dead in middle of night. And that's the advantage with stress CMR, the best prognostic data in comparison with any other stress modality. And then this is just yet another paper when we look at the prognostic value of stress CMR. And CMR is cost effective. So there has been multiple cost effective analysis that has been done. And of course, this data is for United States. I guess you may argue that in Indian scenario, it may not be, but I'm telling you, it's only next 20 to 30 years when this imaging modality will be prevalent in India. And that is because of the evidence that is backed up by it. It's a very contemporary imaging modality. It just, the first sequence, a proper CMR was done only in 1992. So it is actually younger than me, but I think that we will see a lot of stress CMR across the world soon. So again, one of the biggest advantage for the cost effectiveness is if a patient comes with low EF or ST depressions, and I want to see what exactly is the reason or etiology for that low EF, I'm able to give you all those answers. Function wise, if we look at the LVEF, CMR is the most accurate out of any imaging modality. It also can give you the initial valvular assessment. So with one testing, you not only get the accurate information about patient's ejection fraction, probably the reason for ST changes or cardiomyopathy. You can do the stress imaging modality and then figure out if there is any ischemia, and also look at the valves simultaneously and provide the prognostic information to the patient, to me, which is very important to inform to our patient what exactly all these changes mean. So I think I'm going to let this go. The most important thing that I want to reiterate from this is 30% of the women or 30% of the patients actually that present with chest pain have microvascular disease or INOCA. And CMR is a very effective tool along with stress PET, which can detect microvascular dysfunction. This is not done by echo and CTCA. And yes, stress PET has the upper hand because they have been validating this method for many years and it's used very commonly. However, I can tell you that the studies are done already to validate the stress CMR against stress PET in this scenario, where we can determine what is a patient's CFR in particular territory, before deciding that that patient is completely normal or not. I mean, completely, yes, if the patient has any ischemia or not. So just to give you an example, so this is probably a normal stress CMR. So you can see this is the perfusion. So by looking at the pixels that are there after the contrast is given, you can actually determine what is the blood flow that is at rest and at stress. So as we all know, in stress, the blood flow should actually double. And with this pixel wide analysis, you are able to tell if that blood flow is not double, and in that case it would look like this. And this color coding, it's red actually, which is abnormal and low. So you can see that these levels compared to the rest are low, and so this patient possibly has microvascular dysfunction. And this is just an example. The other way to figure it out is again by visually looking at the endocardium. So if we look at the microvascular disease, it will have this in spite of a normal EF, it can have this perfusion defect right in near the endocardium. So this is a case of patient with microvascular disease that was seen on stress CMR. So my point being is stress CMR can detect microvascular dysfunction, which cannot be done at this point by stress echo or dobutamine echo or CTCA. And if we look at, I'm going to skip this because okay, so now let's come to
we need to wind up. Yeah.
Okay, sounds good. So if we look at the CTCA, I think I order a lot of CTCA in my practice, depending on the patient I'm looking at. But my main problem with the CT is you have presented me a patient with chest pain. You haven't asked me to tell you if the patient had atherosclerosis or not. And now after many randomized control trial, we know that ischemia and atherosclerosis are not the same. Anatomy and physiology is not the same. And the only testing that can tell you the answer with physiology is the stress testing. So the CTCA is very good with sensitivity, positive predictive value. I'm not sure because not every athero means that the patient has ischemia. The whole left main argument that many interventional cardiologists or CT people will give you, that is flawed because the left main incidence in this community is only in worldwide community is only 1 to 2%. So in general, we are not worried about left main, and left main can show up on any other stress testing as well. So in my opinion, with this and with ionizing radiation and stuff, CTCA is not the first good imaging modality. So what I've shown you is CMR is accurate, appropriate. It has, it's safe, it's cost effective, and it has excellent prognostic implication. I'm going to skip over this case that I wanted to show you. So what does this patient need? They don't need dobutamine stress echo because dobutamine stress echo cannot detect microvascular disease. It has poor sensitivity, is variable from one person to other person. Stress MPI cannot be done. Too much radiation, it is not going to tell you EF or the cause of EF, and the accuracy is doubtable. And CTCA, I'm not here to tell you why the patient has atherosclerosis. My job is to tell you why the patient has chest pain. It won't tell you anything about microvascular disease. This patient, being a woman, has high risk of microvascular disease. It won't tell you EF if not done in a particular manner, and it leads to more downstream cath. Many studies have suggested that. So stress CMR will be able to tell you EF, will be able to tell you the cause of the symptoms. It has excellent accuracy, no radiation, cost effective, one test, less downstream testing, and hence it's safe if appropriate, cost effective and evidence-based. And thank you so much. And I'm sorry I went over time.
That's fine.
Thank you very much. Thanks, Purvi. You made a very good case for CMR, but we'll discuss and debate it, I guess, in the interest of time at the end of all the talks. So I would like to now invite Dr. Megha Sheth from Ahmedabad to speak on CT angiography, which was just debated a little bit by Purvi as well. So Dr. Megha Sheth, please make your case.
Dr. Megha Sheth is probably the highest reporting radiologist for CT angios from this region. Over to Dr. Megha. You need to unmute, Dr. Megha. You're muted.
Yes, so you can see my screen properly, I hope. Yes.
Yes.
So a very good evening to all of you. After Purvi has debated the case of stress cardiac MRI, we will move on to CT coronary angiography. And in the next few minutes, I will try to explain how it is a very safe and reliable option in patients with probable cardiac origin chest pain. Yeah. So I'm sorry, but yeah. So recently, the 2021 guidelines, that is American College of Cardiology, American Heart Association, and Joint Committee on Clinical Practice Guidelines have come up this guidelines in entirety of how to approach a patient with chest pain. So first of all, initial assessment of chest pain is recommended to triage patients, okay? So instead of saying chest pain is typical or atypical, it would be more beneficial if we describe it as cardiac, possibly cardiac or non-cardiac, because typical and atypical words are out of context in this relativity. So this is how the chest pain is described with red spectrum indicating high probability of ischemia, whereas green spectrum representing probability, low probability of ischemia. So what I would like to focus on is women present with chest pain, they have a risk of underdiagnosis. So potential causes should always be considered. And women are more likely to present with atypical symptoms. Now, this patient also has severe osteoarthritis. So exercise ECG, TMT is out of context for this patient. Okay. So over the past decade, the non-invasive testing has increased dramatically and the scenario has changed a lot rather than invasive coronary angiography. So again, any testing anywhere in the world is dependent to give more appropriate diagnosis, reduce layered testing, means one after another, or not doing the testing when the probability is low. So our patient here, 65-year-old female patient with severe osteoarthritis, with hypertension and dyslipidemia, with non-specific ST changes, according to me, falls in the list of intermediate risk. Okay, so she can either undergo anatomic testing, that is anatomic non-invasive testing, that is CT coronary angiography, or she can undergo functional testing, that could be any of these stress modality. Okay, so again, imaging will be testing choice will be influenced by site expertise and availability, which is a major factor considering our Indian population. Cost is also a consideration, and at present, CT coronary angiography cost is quite low, so it can be optimally utilized. So again, it is to ascertain the diagnosis of coronary artery disease and define coronary anatomy, or it could be to assess ischemia. For that, we need any stress modality. So now we come to CT coronary angiography. See, CT coronary angiography will tell us about both non-obstructive as well as obstructive coronary artery disease. Not only that, in present day, it is the best modality to tell us what is happening in the wall of the coronary artery vessels. What is the plaque morphology? What are the characteristics of high risk or vulnerable plaque? Why is this important? Maybe this is not the cause of ischemia of the patient, but we can initiate preventive therapies, because everywhere in the world now the focus is shifting on preventive therapies, and that will have a long-term implication on patients' health also. What is new in CT coronary angiography? The addition of CT-FFR. Though it is a costly modality is at present, but what functional information CT coronary angiography was lacking earlier, now we can get with CT-FFR, and in future it will be widely available and widely used. So, as I said, CT can very nicely depict the compositional alterations within the plaque. I will show you few images also, and it can identify high risk or vulnerable plaque, which are independent predictors of major adverse coronary events. And recently, Williams et al. Reported that a low attenuation plaque is associated with a 6-fold increase in incident myocardial infarction for patients, even with though the patient has non-obstructive coronary artery disease. So it is very important to diagnose such patients also. So for high-risk features on CT coronary angiography include plaque morphology, which include low attenuation plaques that are less than 30 Hounsfield units, positive remodeling, spotty calcifications, and napkin ring sign. And we can also do the evaluation of stenosis, where significant stenosis in left main is considered when there is luminal narrowing of greater than or equal to 50%. So this is an image of vulnerable plaque, where we can see this is the patent lumen. This entire one is the hypodense plaque with a atheromatous rim or hyper rim. That is why it is called the napkin ring sign, which can very nicely be seen on CT coronary angiography. This is just an image to show you how a maximum intensity projection can show a fibrofatty plaque with some amount of positive remodeling. Okay, with newer softwares, you can depict so nicely. See, these are the calcified plaques. We can see that calcium is orange color. Calcified plaques are stable plaques, how much luminal narrowing they are doing. So we can very nicely see all these things on CT coronary angiography. So now our patient falls in this category. Patient has stable chest pain and no known coronary artery disease. That is what we presume. So the patient comes in intermediate risk. So the patient can go either for anatomical testing, that is CT coronary angiography, or either of the stress testing modalities. If anything comes negative, we are okay. If something comes positive, we know how to progress with that pathway. But what happens when something falls in the intermediate category, where decision making hangs on how is the functional hemodynamic changes distal to the obstruction? So that is when CT-FFR comes into play, and especially for stenosis that is in between 40 to 90%, CT-FFR can very nicely tell us what are the hemodynamic implications. Again, see, the same thing, this is about CT-FFR that I said, but one another thing, if there is inconclusive prior stress test, then you should definitely go for CT coronary angiography, because then you can determine the presence of atherosclerotic plaque burden and obstructive coronary artery disease. The same applies vice versa. That is, if the CTCA is inconclusive, then you can obviously go for any stress study. But for intermediate high-risk patients, this is very important, with stable chest pain but a negative stress test, and still you have high suspicion of coronary artery disease, then please go for CT coronary angiography as a non-invasive modality. It is a very reasonable approach. So again, if the low probability of ischemia, no testing is required, you can go for risk stratification. If there is intermediate risk, that is for a young, especially for a younger patient, less than 65 years of age or less obstructive coronary artery disease, then CTCA is still the preferred modality at present. If older patient and more obstructive coronary artery disease is suspected, then stress is the preferred modality of choice. favors the factors that affect the use of CT coronary angiography is to detect obstructive as well as non-obstructive. This non-obstructive word is very important. Then high quality imaging and expert interpretation is routinely available. Age in younger patients, prior functional study is inconclusive. If there are anomalous coronary arteries or require evaluation of aorta or pulmonary arteries, the so-called triple rule out, where we can also evaluate pulmonary thromboembolism and diseases of aorta like aortic dissection. Moreover, we have seen female patients coming with moderate to large size hiatus hernia also. For coronary evaluation, the gastric symptoms mimic as coronary symptoms. So this also has to be, this also can be seen on CT. So again, this is same thing. Younger patient go for CT coronary angiography, otherwise go for stress. So what is the advantage of CT coronary angiography? That it is supported by a huge number of randomized control trials, as I will show you. And this also I mentioned that preventive intensification of preventive and anti-ischemic therapies is very important when we diagnose non-obstructive coronary artery disease on CT scan. Okay, and there is a high degree of concordance between CT and invasive coronary angiography obstructive coronary artery disease. So clinical trials have reported a higher diagnostic sensitivity of CT coronary angiography compared with stress testing for detective obstructive coronary artery disease. The CTCA without stenosis or plaque has a low event rate of coronary adverse events. Okay, from PROMISE trial, 3-year coronary artery adverse event rate for negative CT coronary angiography was 0.9% for CT coronary angiography versus 2% for stress testing.
Dr. Megha, apologies to interrupt. Could you please go to your wrap-up slides, please? We have 2 more speakers. Thank you.
Yeah. So other randomized trials include SCOT-HEART, then especially with patients for conserved trial. All these trials, since we are not able to go in detail, but all of them support and establish the superiority of CT coronary artery angiography in present study. And also they have in ED evaluation of patients with acute chest pain, CT coronary angiography leads to reduced time of diagnosis and prompt discharge. This is a very important factor that can be considered. Again, we have the CATCH trial, which confirmed to these findings. Similar 40-month MACE rates were reported in PROSPECT trial also, while comparing CT coronary angiography with stress. So use of CT coronary angiography after stress testing also can diagnose or exclude obstructive coronary artery disease. Ischemia trial, in ischemia trial, half of the screen failures were identified by CT coronary angiography, including those with non-obstructive or unprotected left main coronary artery disease. So that is also an important factor. Another thing is after a normal CT coronary angiography means no stenosis of plaque, the warranty period is approx 2 years compared to 1 year with stress testing. So observational registry data suggests that adding coronary artery calcium score in health checkup also can reduce diagnostic uncertainty and help detect atherosclerosis and guide preventive management. Again, CT-FFR is found to be highly coherent with invasive FFR, and its sensitivity and specificity are quite reproducible. So it has to be used when there is intermediate, that is 40 to 90% stenosis when we are in doubt. There you can use the CT-FFR, and a trial advanced registry has changed treatment after CT-FFR in 2/3 of 5,000 patients. So that is a huge number. Okay, radiation consider when we talk about CT coronary angiography, we cannot refrain from that. For prospective gating, newer softwares and newer machines, radiation can be brought down to 3 to 5 millisieverts. Triple rule out, I have already mentioned. What are the contraindications? Allergy, we know, inability to cooperate with no breath holding. Clinically unstable patients, you cannot go for CT coronary angiography. Renal impairment is defined by local protocols. If you are not able to beta block the patient, that is a contraindication. Arrhythmia, though with newer scanners, we don't have much issue with arrhythmia, and contraindication to nitroglycerin, if any. So for this patient, factors to consider when selecting optimal candidate for CT coronary angiography and why she is there. We presume she has no previous coronary artery disease. She is a case of intermediate probability. We presume she has regular heart rate, able to achieve a low heart rate. Her age is less than 70 years. If the BMI is also low, creatinine clearance is okay, no contrast allergy, then I would definitely go for CT coronary angiography in this patient. European Society current guidelines state that in patients, you should go, a stress test is recommended when there is significant ischemia. But multi-CT coronary angiography is highly sensitive, and even it is for rule out of coronary artery disease in troponin negative acute coronary artery syndrome. So that is a very important thing.
Yeah,
So,
Dr. Megha, you can wind up for the other speakers. Thank you.
Yes. So it can even independently predict the risk of myocardial infarction, cardiovascular death, urgent revascularization at a follow-up. So this is just a take-home message from this trial. So what I want to stress is women may be more likely to present with accompanying symptoms. Don't ignore that and share the decision making. That is what is important. Thank you.
Excellent talk, Dr. Megha. Thank you for introducing to us the very important concept of knowing about the plaque morphology and especially the non-obstructive variety of coronary artery disease. So for want of time, let's go ahead with the next speaker. Dr. Pooja Vyas will be speaking on pharmacological stress echo.
Pooja, unmute, please. Yeah. We have one similarity between all speakers. They are all women, I meant.
Yeah, thank you, Dr. Kamal Sharma, sir, and the team for giving me this opportunity. And here, many of my friends are here, and two of my seniors from the same hostel, and some juniors are also sharing the same platform now. So it's making me anxious as well as nervous. Let's see how it goes. I'll be talking on the approach to this patient. And I think everybody knows from the last session, last year also, I was biased towards MR, but still I would try to make my point toward pharmacological stress echocardiography, especially in our Indian setting where we are facing cost constraints and availability issues. So history, we all know that our patient is 65-year-old, hypertensive and having dyslipidemia. And as we now don't use the term atypical angina, we'll use to avoid ambiguity, we'll use possible cardiac chest pain. In this case, ECG is showing non-specific STT changes in inferior leads. Echo is normal without any RWMA. And as patient has bilateral osteoarthritis of the knee, so patient cannot exercise. Evaluation pathway in this patient will be estimation of the pretest probability, then using that pretest probability, then various stress tests available in this case, sensitivity, specificity, and accuracy of the test, and choosing an appropriate test out of them. So to calculate the pretest probabilities, I've taken this table from the recent 2021 SECHA guidelines. So our patient is 65 years old and is having chest pain. So she will fall in intermediate to high risk category. And the guideline also says that if we have availability of doing calcium scoring, coronary artery calcium score, we should do it to enhance the pretest probability. Now, coming to the clinical diagnostic pathway, as patient is falling in intermediate to high risk group, so we will have anatomical testing as an option and class 1 recommendation, which is preferred in less than 65 years of age, because in women with less than 65 years, they have less chances of having obstructive coronary artery disease, and the CT coronary angiography is very good at ruling out the disease. And as our patient age is 65 years, so stress testing would be a good option, because definitely stress testing have very good ruling in power. And the stress testing which we can do in this case are stress echocardiography, stress cardiac MR, stress PET, and stress PET. Sensitivity and specificity of the various stress tests. Let us concentrate on pharmacological stress echocardiography. It has sensitivity of around 85 to 90% and specificity of around 75 to 90%. So it is almost comparable to cardiac MR, the sensitivity around 83 to 91 and specificity of about 86 to 81%. So various tests have range of clinical likelihood of coronary artery disease, where the usefulness of the application of the test is maximal. So here, the ranges of the clinical likelihood of the coronary artery disease is demonstrated in the table, in which the test can either rule out or can rule in. The green line demonstrates the ruling out power of the test, while the red line demonstrates the ruling in power of the test. We can see from this table that CT coronary angiography has the best ruling out power. And if we concentrate on the stress echocardiography, it has comparable ruling in as well as ruling in power. When we select an appropriate test, we should also consider the likelihood ratio, which we calculate that by calculating it is the ratio of likelihood of having the test positive when the patient is having a disease to the likelihood of having the test positive when the patient doesn't have the disease. So it tells about the test ability to correctly classify the patients. So in stress echocardiography, the positive likelihood ratio of the test is 4.67, which is comparable to the stress cardiac MR, which is 4.54, and even the PET, that is 5.8. And the maximum negative likelihood ratio is with the CT coronary angiography. So definitely we know that it has the maximum ruling out power. Pharmacological stress echocardiography has the wide scope of applicability. It has many diagnostic and prognostic features. This pharmacological stress echocardiography test can detect the abnormality at the most of the steps of the ischemic cascade. So the step 1 is the perfusion abnormality in the ischemic cascade. So it can be detected by using the real-time myocardial contrast echocardiography. Then would be the metabolic dysfunction. It will be detected by PET. The diastolic dysfunction can be detected by using tissue Doppler and the methods on stress echocardiography. We can even diagnose early systolic and early diastolic dysfunction using the tissue Doppler and strain imaging. And definitely we can visualize the regional wall motion abnormality on 2D echocardiography, and even the viability can be assessed by using stress echocardiography. Pharmacological stressors, which we commonly used in the stress testing, is dobutamine, which increases the myocardial oxygen demand, and another stressor which we use is the adenosine. It reduces the subendocardial supply, and it causes the coronary still in the subendocardium. The prime function of stress echocardiography is to detect the ischemia by various parameters, like we can detect ischemia by looking at the development of abnormality in systolic endocardial excursion, can detect by seeing the reduction in the overall ejection fraction after stress, by looking at the stress-induced ischemic dilatation in the LV cavity, and even the RV assessment gives us information regarding the ischemia. In this image, we can see that in the rest image, the LV looks normal, and in the post-stress, we can see the dilatation of the LV and also the decreased endocardial excursion in the apical septum and anterior wall. 10% of these patients have poor acoustic window, where comes the role of IV contrast agent, which will help in improving the visualization of the endocardial borders. Even perfusion imaging can be done using stress echocardiography. We can use the ultrasound enhancing agent. What we see in this perfusion imaging assessment is the replenishment of the contrast agent. Normally, at rest, the replenishment happens within 4 seconds after giving flash, and at stress, it happens earlier within the 2 seconds. In this image, we can say that replenishment didn't happen even at 4 seconds post-flash, and we can see perfusion abnormalities in the apical septum and apex. Even quantitative analysis methods like tissue Doppler imaging, color kinesis method, acoustic quantification, then strain and strain rate imaging, speckle tracking, echocardiography, this all quantitative methods can be used to detect early systolic and diastolic dysfunction in stress echocardiography. Even we can calculate coronary flow reserve by putting a pulse wave Doppler in mid to distal left anterior descending artery, and we can calculate coronary flow reserve. It is the ratio of the maximum diastolic flow velocity during the hyperemia to the maximum diastolic velocity at the rest. If the ratio is coming less than 2, it surely indicates the significant coronary artery stenosis. Even 3D echocardiography, 3D stress echocardiography has a role in ischemia evaluation with its advantages, like it can visualize all the segments in a single view, it will reduce the procedure duration, and it will avoid the apical foreshortening. Definitely, we can do viability assessment using a stress echocardiography. The typical response for viability are biphasic response, maintained improved response, and scarred myocardium will not move at all during the stress echocardiography. Simultaneously, we can do hemodynamic assessment, and we can even do assessment of valvular functions and structural abnormality when we use stress echocardiography. It has a good prognostic value also. If the test is coming negative, then the clinical cardiac event rate is less than 1% per year. And if the test is abnormal, according to the various parameters like transient ischemic dilatation, extent and severity of the wall motion abnormalities, coronary territories involved, presence and absence of RV ischemia, and time to develop RWMA, and the time to recovery, we can prognosticate the patients. So I would say that the pharmacological stress echocardiography has very good accuracy and efficiency with minimal cost involvement, and it will need minimal time also, with no radiation at all, and it is environment friendly also. I can share one funny and relevant incidents also here that happened to me 7 years back. My uncle got a stress thallium done 7 years back, and he just came to our home, and I was pregnant at that time. And whenever he was about to come near to me, I would just run away from him. So I was just fearing the effect of radiation on the baby. So I would not recommend the test which has radiation involved, while we have available test which doesn't have any radiation involved and which can give the same desired information with the comparable accuracy. Then I would definitely go for non-radiation test. And on a lighter note, if your patient is claustrophobic, this is the only non-invasive stress test where your doctor will accompany you during the whole test. And in the last, I'll say that even the guidelines say that we should we should choose the test, and the choice of the test should be guided by the local availability and also by the local expertise. Thank you.
Pooja, I hold my patients' hands in MRI suite, so I'm there with them.
Yeah.
Thank you, Dr. Pooja. It was a wonderful presentation. I think all the speakers have been doing their job really great, trying to justify and prove their presentations and all the modalities they have been given to. So I think I'll invite the next speaker, Dr. Swati Raj, and she'll be taking us to stress radio nuclear imaging. I think PET and SPECT will be spoken about. Over to Dr. Swati.
Can you hear me? Hello?
Yes, we can. Yes.
Yes,
And your
yes,
slides
yes.
are
And can you
visible.
see my slides, right? My slides are, everyone can see my slides?
Yes, yes, we can.
Yes,
It's
okay,
perfect.
okay. So I can start.
Thank you.
Okay, okay, thank you. So, first of all, I would like to thank Dr. Sharma for inviting me for the interesting subject. And actually, the old speakers have told that that is a radiation. Nuclear medicine is radiation, but in recent times, nuclear medicine is mandatory in almost all the fields like oncology and cardiology. So I am nuclear medicine physician, and I will speak about the nuclear medicine aspect of imaging. So as we all know that myocardial perfusion imaging is an important and critical aspect of CAD management, and it is almost for the 20 years because it is accurate, it is reproducible, and it is a marker of clinical risk. It is the article that is published 20 years back have shown that it gives a risk stratification. It stratify the risk in patient, divides patient into low risk and high risk. So it will prognosticate the patient, and management depends on the MPR results. And there is incremental prognostic value of spexity by addition of clinical MPI and ST segment variables. And now there are recent articles that you can add the calcium scoring with the SPECT MPI results to further increase the risk stratification if we add the CT part in spexity. And after the introduction of this PET-CT, it gives a comprehensive assessment of anatomical and functional burden of coronary artery disease. It identifies the focal disease. It identifies the left ventricle function and volumes. It gives atherosclerotic burden, that CT part of PET, and also that is the most is that it gives a diffuse disease, is the microvascular disease by CFR measurement. So coronary flow reserve, that is CFR, is this ratio of myocardial blood flow at rest, peak hyperemia to rest, and CFR exactly gives the hemodynamic effects of epicardial CAD, diffuse atherosclerosis, and microvascular dysfunction of myocardial tissue perfusion. So if we see the ischemic cascade, PET-CFR is the first to detect the disease when it is at the microvascular dysfunction level. And also when PET and SPECT identify the disease when there is a decrease in the perfusion. And PET nuclear testing is also useful when there is arrhythmias, rapid heart rates, and poor acoustic windows. And other modalities are contraindicated when CT and MRI are contraindicated because of the one of the reasons. So if we see the pathophysiology of women have more non-obstructive CAD. They have plaque erosion with subsequent thrombus, and there was a endothelial dysfunction is more prevalent in women, and also have a lower vasomotor tone of coronary arteries, smaller epicardial coronary arteries, and thinner myocardial walls. So they're more prone to CAD. And so we will discuss our case, that is a 65-year-old female with hypertension, dyslipidemia, that is, and patient has a preserved LVF and bilateral osteoarthritis. So we will do the pharmacological stress testing in this case. Possible etiologies for angina, epicardial microvascular disease or coronary microvascular dysfunction. The cause of epicardial disease are the plaque rupture, stable plaque or bridging, or microvascular disease is usually because of the endothelial dysfunction. So CFD is more prevalent in women, hypertensive patients, and patients with the dyslipidemia. So in our case, this patient also have a chances of coronary microvascular dysfunction. Coronary microvascular dysfunction is not benign and has a greater implication for women with regards to adverse outcomes. So this chart is showing the distribution of cardiovascular risk by CFR. So if it is a CFR is normal, then there is a lower chance of cardiac related mortality. And if CFR is less, then there is a chance of higher chances of cardiac mortality. And if we see the CFR in the same CFR values for the female and male, then there's a female has a higher higher log adjusted hazard ratios. So now we can see what the guidelines say. So 2021 guidelines have shown that for the chest pain, this patient has a atypical angina and it falls into the maybe cardiac group. And according to the age, sex, and symptoms, this patient is falling into the intermediate risk category. For the intermediate category patients, guidelines say that either we go for anatomical or function testing, but we should know the patients has unestablished or known CAD, pre-test probabilities, prior test results, prior revascularization, and expertise and local availability. So and also further guidelines say that patients with older patient that is 65 year of age and more obstructive CAD suspected, patient should go for the stress testing. And because the goal of management is ischemia guided management. So this patient can go for the stress testing. And guidelines have suggested in the stress testing, PET and SPECT MPI is the most indicated. There's evidence 1, and also class 1 2A evidence say that PET is reasonable in preference to SPECT if it is available. So this patient will go for the PET and SPECT MPI, either SPECT or PET, and it depends on the availability. And we have now newer softwares available that by that we can achieve the less radiation. See the radiation dose to the patient. So now we will see the cause of microvascular dysfunction, and now the management by how the PET diagnose the coronary microvascular dysfunction. So this is the patient with having a coronary artery calcium score of 0 and myocardial perfusion PET is normal, but this patient has a value of this CFR values are less than 2. So this patient has a coronary microvascular dysfunction. So that and also guidelines have suggested the stress MPI with the CFR management is reasonable to diagnose a microvascular dysfunction. But in Indian scenario, PET's CFR is not available because PET MPI is machines are available, but because of the unavailability of the radiopharmaceuticals and because of the logistic issues, PET MPI radiopharmaceuticals are not available, and there are some emerging evidence that SPECT MFR can be used for the diagnosis of obstructive CAD. So the paper of EJNM, that is 2019, have shown that low dose SPECT-CT for regional MFR and diagnosis of obstructive CAD can be useful and has a good sensitivity and specificity. This another paper have shown that SPECT MFR can detect the multi-vessel CAD. Also, in comparison with the SPECT and PET, the JNM 2017 articles has shown that there is a good correlation was found with the MFR values with the both PET and SPECT. And also with the CZT SPECT, they are the newer gamma cameras with the thinner crystals have diagnostic accuracy higher, and they can be used full for inavailability of the PET, and it may improve the MPI specificity. And also, if we are using the SPECT, we have to use attenuation correction or prone imaging to reasonable to decrease the false positive rates, because females have sometimes anterior defect or introseptal defect. So we have to do the prone imaging, and that will increase the false positive rate, decrease the false positive rate. Also, the guidelines have 2A evidence of guidelines have suggested that addition of coronary artery calcium testing can be useful in intermediate and high risk patients with stable chest pain and no known CAD. So now I can argue that this patient can go for the SPECT MPI in our Indian scenario, where with the new gamma cameras, with the new hardware and new software, we can use the stress first protocols to decrease the radiation burden to the patient. We can add coronary artery calcium score with SPECT-CT or myocardial blood flow with the CZT SPECT. So we have to triage the patients according to the risk. So now I can conclude that nuclear medicine is best for this patient because it is a powerful test across the spectrum of CAD risk. Guidelines suggest the ischemia-guided management in stable chest pain and intermediate risk group, supported by the evidence-based data. And pathophysiology of women is different. So women have more plaque erosion and microvascular disease that can be detected with PET. But PET is most accurate, but due to some limitations, we are not able to do PET MPI in recent times. So we can alternately, we can use the SPECT-CT with the new gamma cameras. And these are the best alternatives after considering the old pretest probabilities and the history of CAD. And with the newer hardware and software, we can achieve the lower radiation dose for cardiac PET-CT and SPECT-CT. Thank you.
That was wonderful, Dr. Swati.
Yeah.
I'd like to invite some of the other panelists if they have any comments to make on all the 4 speakers' wonderful speeches. Dr. Parul, Dr. Neha, Dr. Bhumi. Is there anybody who'd like to say something and make a comment?
Hello. Hello, everybody.
Hello, ma'am.
I am Dr. Neha. Great speech by each of the speakers. Great valid points put by everybody. I have one question. There is a study called Enas et al. In which they say that Indian Asian males are more at risk of coronary artery disease worldwide comparatively. So is that thing also, this rule applies to females, Asian females also? This is my question to anybody who can answer.
Purvi, you would like to take that? Purvi or anyone, chairpersons, we have data from
Sorry, I was on mute. Did you ask me?
No, yeah. So she's asking if Inas had published a paper from West which talked about higher prevalence in the Asian Indians who moved to US being twice.
You went mute as
risk.
well. I don't know if that is just me.
No, it's just you. Am I audible to everybody else?
Yes.
Can everyone else hear me?
Yes.
Yeah,
we can.
But, I think we need to text her. Anybody else? I mean, would like to take that?
Can you hear me or no?
Yes.
Okay, sorry. You all went mute for me. I think.
Yeah. Can you hear me?
Yes, I can. Okay. So South Asian population is higher risk regardless of men or women. And I think that, I was just arguing with Dr. Sharma behind the back of importance of prevention and exercise. I think it comes down to our lifestyle. A lot of our lifestyle.
You call that conspiracy. You don't care arguing because you and my wife are conspiring behind my back to make me exercise more.
I think it's all about, prevention. And unfortunately, that lacks in Indian population. I think women in India are way more busier, or in Southeast Asia, I would say, taking care of the household chores and somehow all the childcare responsibilities. So there is less focus on self-care, less focus on stress management, less focus on exercise. Our diet is unfortunately full of carbohydrates, which puts it at risk. So a lot of saturated fat and carbohydrate. So I think there is a very good paper by AHA, by I think it was particularly focused on the Southeast Asian population and why the risk is higher. So we definitely have some genetic predisposition, but I think combined with our lifestyle, particularly for women, where there is bias in the society, how much they are ignored and stuff, everything kind of together, puts them at a way higher risk. And I would say that microvascular disease is, of course, issue, but more than that, I always worry about the macrovascular disease in Indian subcontinent because of how the symptoms are taken for women versus men.
Dr. Parul, ma'am, you have some comments to make. Madam is HOD Medicine. I think she sees with number of population.
Yes, all the speakers as a justification of the topic allotted there. And thank you very much for giving me this opportunity to wonderful talk related to the female session and female patient as well. I just wanted to add one thing is that every this procedure has an advantage and disadvantage, but I prefer as a non-invasive will be the better option. This is what I feel. But the thing is that CT angiography, there is some limitation. If the patient is having some pacemaker or some device inside, then we have to definitely go for the invasive or stress echo also. So this is what I feel. Is there any comment on that? Which one is the better if patient is having any device inside in form of either a fracture or the plates and anything?
Yeah, clips also. MR cannot be.
MR cannot be. So there is a limitation of, however, it looks very good CT angio and all this. So at that time, we have to go for the invasive, especially the stress echo and all this. This is what I conclude. And congratulations to all lady and to the Kamal Sharma sir also for this wonderful talk for the women's session. Thank you very much.
Yeah, I would like to make the comment that we are routinely doing stress, that is maybe we are using. We are not using thallium basically. In India, thallium is not available. We are routinely doing maybe. And this type of patient like fracture or any knee joint problems, we are routinely doing stress thallium, stress maybe. That is a stress MPI with the maybe. Routinely we are doing. And we can use a stress first protocol. So if stress study is normal, we can just avoid the rest part. So in our scenario, we are doing this type of patients, we are doing this test, because if stress MPI is normal, patient can go for the surgery. So it is a pre-anesthetic or pre-surgery assessment. We are doing routinely myocardial perfusion imaging.
Fine, thank you. Thank you.
So I think the comment was about stress CMR not being able to done in pacemaker population, and with the new sequences we are able to do it in the population, and my colleague Dr. Contractor is going to speak next. So most of the ICDs and devices that are planted, they are CMR safe, and there are new sequences where we can do it very effectively. So perhaps those sequences are not available in India, but we are able to do them effectively.
Yeah, so I think pacemakers, yes, but metallic implants, fractures, which have been repaired, probably no. Yes, we have now MR compatible devices being implanted in India as well. You can do whole body MR, including pacemakers, ICDs, etc. So I think I must thank each of you for the sake of time for this wonderful session. If there are no comments to be made by any of the other panelists, I can close the session from the permission of chair.
Thank you very much.
Thank you very much.
Thank you, sir.
Aisha, Dr. Sonali, Dr. Nikhila, Dr. Rujuta, Dr. Pallavi, Dr. Parul, Dr. Neha, Dr. Bhumi, and our elite panel of speakers, Dr. Pooja, Dr. Purvi, Dr. Megha, Dr. Swati. We had no dropouts for the session. That's the women power. Thank you very much. That's how it should be. We had complete panel on and complete care for all women case as well. So we move to the question for the session, which was based on this session. In women study, the study was called Women, which was done, and there were 2-year outcomes. They looked at the outcome of ischemia evaluation in women. MPI was compared to exercise testing, and you need to choose what the option is correct on the quiz in the delegate platform. Was it superior? Was it inferior? Has similar outcomes with higher crossover rates, or resulted in more choreangiogram in ETT? So that was the question. The quiz will remain open till the next question is put up, and then it will be closing. And then we'll have a total score, which we'll be evaluating at the end of the conference. And then whosoever gets the top 3 ranking would be rewarded a prize. The answer was had similar outcomes with higher crossover rates. This was women investigator, trial investigators had published this.
Hello.
This is an old study done in 2012. And this has the explanation here for the same. So let's move to the next session. And we have the next panels here. This is a case of pacemaker, 80-year-old lady, degenerative complete heart block on hemodialysis with left upper limb AV fistula, 99% occluded right subclavian, scheduled for permanent pacemaker. And best permanent pacing strategy would be, for this we have 2 speakers, Dr. Shomobura, my colleague, he's an EP specialist renowned in this part of the world. He's talking for venous angioplasty first of the right subclavian, which he has done in a lot of cases, for transvenous pacemaker because that's cost effective. And we'll have Dr. Tamid Contractor speaking on leadless pacemaker implanted for such a case. We'll have Dr. Tamid speak first. Our chairpersons for the session are Dr. Sharajan, Dr. Sachin Patel, Dr. Pramesh, Dr. Keur, Dr. Manjunath, and Dr. Pinkesh. Over to Dr. Tamid.
Hi, am I able to share my screen at this stage?
Yes, you are. You are.
Okay.
Please go ahead and share your screen.
Is everybody able to see the slide? Hello, everyone. Good evening. Good evening in India. It's morning here. It's good to be among Indian colleagues. I haven't been home for a long time, so this feels like I'm there a little bit anyway. I've been charged to talk about the topic of the right choice of the pacemaker in an 80-year-old female with a complete heart block, hemodialysis, a left-sided AV fistula, and a right-sided occluded vein. I have to defend the strategy that the leadless pacemaker is the most suited option. In the next 10 minutes, I would like to talk about the issues with traditional transvenous pacemakers in this setting. I would also like to talk about the advantages of leadless pacemakers and also present potential arguments that are against leadless pacemakers and try to defend these arguments. For those of you who may not be aware of the leadless pacemaker technology, this is really amazing and probably the future of cardiac pacing. There's no leads, there's no pacemaker pocket. The most commonly used system is this, the Micra Medtronic system. This is a time-based pacemaker that is implanted from the femoral vein. We put it in the right ventricular septum in the trabeculae. Once we feel it's in a good location, we tug on it and then we remove this string attachment and the pacemaker is left in place. Again, no leads, no pocket. This is a relatively newer system that is not being used as much. The first version had some issues and now they have come up with a newer version. This is the Abbott system. Instead of the tine or the passive fixation mechanism, this is an actual screw-in mechanism. The advantage of this is it has a longer battery life and it can also be retrieved many years later if needed. In terms of issues in ESRD patients, if you put in a traditional transvenous pacemaker, I think the biggest issue is infection, whether it's endocarditis or pocket infection. We are a large extraction center, and so we get a lot of referrals for these patients. Even at this time in the hospital, we have 2 patients with end-stage renal disease that have infection, both with MRSA. We did 1 extraction yesterday, very sick patient, and we have actually 1 coming up that has a large SVC mass with MRSA bacteremia that we have to first do an angiovac and remove that mass and then do the extraction. These are very high risk procedures, And I'll also try to share some data on how these patients do and how they get there. There is actually a risk score to calculate the risk of infection when someone undergoes a traditional transvenous pacemaker, whether it's pocket or endocarditis. And you can see in the middle that renal dysfunction is actually one of the factors that increases the risk. In this a large study from the US, more than 500,000 patients with were studied. There were 6% patients among these ESRD patients that had some form of a pacemaker or ICD, transvenous, not leadless. And among these, the rate of infection was 8%. That's like 1 in 10. That's obviously a very high risk. Only 1 in 3 of these patients underwent extraction. And even if they did undergo extraction, the outcomes were not good. 16 months versus 9 months. Again, if these patients get infected, they don't do well. This is another study from the Cleveland Clinic that looked at 1,400 patients undergoing extraction. And they looked at patients that had normal renal function and those that had renal dysfunction, either on dialysis or not on dialysis. For the sake of this presentation, I'm just comparing those on dialysis and those with normal renal function. You can see that the risk of complications is double, 7% versus 12%, and the risk of mortality is almost 4 times 6-month mortality in those that had normal renal function versus those that were on dialysis. Again, when these patients get infected or have vascular issues and need extraction, they don't do well. I don't know if anyone else has seen this issue. We are again an extraction center, so we get a lot of referrals for this. I like to call this the Hemi-Hulk syndrome. The story typically is a patient has a fistula on one side and then they need a pacemaker, so they get a pacemaker on the other side. Then something goes wrong with this fistula, so they put a fistula on the same side as the pacemaker, and now there's all this fibrous tissue and growth around the leads. The vein is occluded, and now the arterialized vein flow cannot get back to the central circulation, and so the arm and the upper body start swelling. These patients usually have a lot of pain and discomfort, and we have had to perform extraction in an arterialized venous system, again, which is very high risk of bleeding. Leadless pacemakers, on the other hand, it's obvious because there's no leads, there's no vascular issues, but it's also a much lower risk of infection, both the pocket infection and endocarditis. But why is that, right? It's a foreign body. So why is there why is there so much less infection with leadless pacemakers? For one, there is no pocket, right? So that's the best part. So one part of the infection is the pocket infection, and that's completely taken out if there's no pocket. But the other is also the risk of endocarditis, and the key word is forming a biofilm. Because of having almost 1/7 of the surface area, and a lot of the pacemakers actually get completely encapsulated by biological tissue. I'm sorry, there's some issue here. Are you still able to see my slides? Okay.
Yeah, we are seeing your slides. Yeah.
Okay, thanks. Because it gets encapsulated by tissue, the chance of forming a biofilm decreases a lot. These leadless pacemakers also have a parylene coating that prevents biofilm formation. This coating is not there on the traditional transvenous pacemakers, and also it is implanted, at least as of now, in this a turbulent right ventricle, right, where there's so much flow that the chance of forming an actual vegetation is low. I'm sure a lot of you do transesophageal echocardiograms, and if you all have seen any fibrous tissue on the pacemaker leads or ICD leads, it's usually in the right atrial aspect. It's very rarely in the right ventricular aspect because of this reason. There are some arguments against leadless pacemaker that I'll try to go through. One is safety, that the risk of pericardial effusion may be slightly higher. If there is a pericardial effusion, then the risk of cardiac surgery is higher. Again, this was the initial experience. Things have changed now. There's obviously cost considerations. There is an upfront cost with the leadless pacemaker, but I think it pays off in the long term, especially in the population of end-stage renal disease. There is this possibility of AV dysynchrony and pacing-induced cardiomyopathy, which again that can only be truly solved by either a dual chamber pacemaker for AV block and AV dyssynchrony, and CRT or a conduction system pacemaker for pacing induced cardiomyopathy. And I will present a slide on that to show why a leadless pacemaker may not be such a bad option for that. Extraction risks, again, once this leadless pacemaker goes in, especially the time-based system, extracting it, after 6 months to a year is hard, but do we really need to care about that in this population? That's also another point I'll try to talk about. In terms of safety, this was actually studied, in the Medicare population, which is more than 65 years old in the US. They compared patients undergoing single chamber pacemaker implants, whether leadless or the one with a lead, and they compared 6,000 patients versus 10,000 patients. 12% of the patients with leadless pacemakers were on dialysis versus 2.3%. Again, this is not a randomized trial, it's an observational study, but this reflects the practice patterns and the concerns that physicians have in putting traditional transvenous pacemakers in patients on dialysis. Also, the patients were more frail and had a higher frailty index when they had a leadless pacemaker implanted as opposed to a more traditional transvenous pacemaker. And the outcomes were actually a lot in favor of leadless pacemakers. When you look at re-intervention, whether it is revision or replacement or upgrades, it was 2.7% in the leadless pacemaker group and 4.9% in a traditional transvenous pacemaker. And again, this was mainly related to problems with the lead and the pocket, not so much upgrades. The overall upgrade rate in both groups were very low. As it relates to complications, it was again lower in the leadless pacemaker group as opposed to the traditional transvenous group, 4.6% versus 6.5%. And again, this was mostly related to lead issues, infection, and pocket issues. There was not much difference in mortality. It was very similar, the adjusted 2-year all-cause mortality. So we are looking at a high-risk population now that is probably going to live the same amount of time with either a leadless or a transvenous pacemaker, but with less complications, less re-interventions, and probably a better quality of life on account of that. We are very focused on safety, and I won't spend too much time on this, but we use some fluoroscopic techniques to confirm that this is the RAO space sign that we described in 2021 to make sure we are on the true septum. We are also strong believers in the use of echo. LAO may not tell the true story. LAO may tell us that we are septal, but we may still be on the free wall, and we are strong believers in using echo to readjust the position to make sure we are on the true septum to avoid perforation. Costs have also been a concern, and this was a French health study that looked at patients in 2015 that could have been candidates for a leadless pacemaker, those that underwent single chamber pacemaker or more than 80 years old with dual chamber, or those with CRT-P implants greater than 90 years old. They looked at the costs of these complications that happened in these patients, 5.3% risk of complications, mostly lead and pocket complications. Again, it was in France, so it's in euros, but again, a staggering cost, as you can see from the slide. And this I found very interesting, actually. I found a study where they looked at the cost in Poland of a patient that was actually quite similar to the patient in question. She was 80 years old, end-stage renal disease, on warfarin, that required a generator change, a very high risk of infection, obviously. And they ended up doing a generator change to save costs, but she ended up having an infection, multiple hospitalizations, finally had to undergo a high-risk extraction and then leadless pacemaker implantation. And they compared if they had done a leadless pacemaker up front, what would the cost difference be? And you can see that the cost difference is almost double. In terms of AV synchrony, again, in the era of when we only had pacemakers with leads in 1998, they actually looked at the pacing mode in patients with dual chamber pacemaker. And if you did DDD pacing, which is AV synchronous pacing, versus VVI pacing, there was actually no difference in the quality of life in patients with AV block, in patients that were more than 65 years old. And looking at cardiomyopathy from pacing, again, this was a recent study that compared transvenous versus leadless pacemaker. Maybe because we put the leadless pacemaker on the septum as opposed to the apex, which we often do with the transvenous pacemaker. I think we are a lot more careful with the leadless pacemaker to make sure on the we are on the septum. Maybe because of that, the risk of cardiomyopathy is lower, because on the septum we may have a slightly more synchronous contraction than when we are on the apex or the free wall. And does extracting leadless pacemakers matter in an 80-year-old? You know, the battery life is 10 to 24 years. The risk of infection is very low. In a lot of patients, these are destination devices that get them through, hopefully with a good quality of life. So in conclusion, transvenous devices and ESRD is a very high risk of infection and vascular issues. When we have to extract devices here, the risks of extraction are high. So we have to try to avoid leads in these patients if possible. Leadless pacemakers, on the other hand, very low risk of infection, no vascular issues, and it can be a safe and cost-effective strategy that can improve quality of life. And again, I am going to date myself to when I was in India in the 90s, but as my favorite actor would say in my favorite ad, that in this situation, the leadless pacemaker is the right choice. Thank you.
Thank you, Dr. Tamid. Over to chairpersons. Dr. Sharat Jain, I can see you. I think we can have Dr. Shomu present his side and then we can have a discussion.
Am I audible?
Yes, you are audible.
Okay. So should I go ahead?
Yes.
Yeah. A very good evening. Thanks, Dr. Kamal Sharma, for having me here to speak on this topic. And respected chairpersons, dear colleagues, I would present my side of the story. However, I would thank Dr. Tamid to have had this initial conversation regarding the leadless. So my point would be very clear. So you have this kind of case, or in an 80-year-old, you need to know so many other things like the weight, comorbidities, family status, and the acceptability. And you need to know whether the complete heart block has to be treated in an immediate or a planned basis, and whether this fistula that is there, what is the frequency of dialysis, what is the degree of renal dysfunction and present health regarding the same. Regarding the occlusion on the right side, you need to know whether it is external occlusion or it's due to fibrosis because of prior intervention, and what is the imaging technique used for that kind of diagnosis of a occlusion. And lastly, to know the ejection fraction at the time, we were not provided with that. However, I would say at the onset that there has to be no debate as such, because the topics that have been given are whether leadless pacemaker is best suited. Yes, it is best suited. However, from my side, I would say that venoplasty and endocardial pacing is cost effective, and that is what I am here to say. So going on to venous occlusions, we know that venous occlusions are not uncommon, and complete occlusion are there in around 2 to 6% of patients of the overall occlusion rates. However, if they had a prior intervention, definitely the rates are very high. They may be asymptomatic because of collateral circulation, and fibrosis or thrombosis are the most common causes. Venography prior to implantation is very important rather than relying on a CT image or a sonographic image, and that's very important. So my outline would be to see how to approach these patients. What are the alternatives for pacing in patients with hemodialysis, excluding the leadless as has been discussed? What is the approach to do a pacemaker after venoplasty, and comparing it with a leadless pacemaker? So as seen in this table, in patients who need a pacemaker or a device for that matter, you need to answer 2 more questions: whether the patient has a future access for hemodialysis or peritoneal dialysis option is there along with kidney transplant. In a elderly, obviously transplantation may not be there, but an option of a peritoneal dialysis may still be there. Then going on to venography, whether it is a stenotic lesion in which there is some flow or it is completely occluded. And if it is open, then definitely a venoplasty is as easy, in which a direct wiring can be done and a lead implantation is very easy. However, if it is an occluded, then comes the problem of doing a further intervention in which you need a balloon support or a venoplasty from either the antegrade approach or the femoral approach. And other options like getting an external jugular or a supraclavicular approach for subclavian vein can be considered. Rarely femoral or iliac axis can be considered. And if you don't have a leadless pacemaker, an epicardial lead as a bailout can be considered. So alternatives is what I'm going to discuss rather than just a venoplasty. And these are the three major. So ipsilateral implantation of pacing lead where you have an existing AV fistula is possible, though it increases the risk of bleeding, the risk of infection, as well as the stenosis, and as shown by the Dr. Tahmid, the hemi-hulk as he calls, can also be there because of the stenosis. But how can you still do it? You can do it safely if you have a cephalic axis. Least number of leads that you use smaller, fine leads, you use a smaller device, don't make a large pocket, make the pocket lower down. And to prevent further stenosis, or in fact intervene before the stenosis is complete, you need to do a regular evaluation of patency by venograms, and especially do a venoplasty if stenosis is detected before the occlusion occurs. So this was a study which showed that secondary interventions in patients with implantable cardiac devices and ipsilateral atriovenous access is not as bad, though the interventions are much earlier, but the rate of intervention is similar and the failure rate and infection rate were negligible in this study, showing that in patients in whom you have no other choice, you actually can do an ipsilateral side access also. Transjugular is not commonly used, but it may actually be a very useful alternative in elderly, though it has the problem of having the lead being superficial because you have to tunnel it through. However, it is an excellent alternative. These are out of the blue, out of the box thinking in which you use a long lead with femoral access or a transhepatic access, which we would normally not do. So coming to the core topic of contralateral implantation with or without venoplasty, and first and foremost, you need to do a venogram. If you see in adduction, you get a good flow, but in abduction, there is an apparent stenosis. Also, when you do a venogram, you should be clear that there is no spasm. Sometimes it is seen and you give NTG, you would find that it is a good vein. So it is good to do a NTG if you find some kind of narrowing. Sometimes cephalic access, in fact, in this patients with ESRD, patient cephalic vein, if it is prominent, it may be of great use. Even in a normal situation, you can use that so as to prevent stenosis at the site of punctures. But the cephalic vein can join after the stenotic line, or it can go supraclavicular itself from the stenosis area and provide you a good access to go through the cephalic vein and access to the RV to pace. Intrathoracic punctures, that is puncturing proximal to the block, wherein you do an intrathoracic peg puncture, but it has its own sets of risks, so you have to be careful. So the most commonly used would be a venoplasty or progressive dilatation using dilator. So you do an antegrade puncture, and once you have access to the vein, you pass in a wire. Mostly it is useful for stenotic lesions rather than occlusive lesion. You do a progressive dilatation with increased size of dilators, pass the sheath and position the lead. The advantage is no additional hardware except dilators, minimal cost, least amount of intervention, and the patient goes home as if the pacemaker is done in a normal person. The disadvantage is, or you should remember, is you cannot remove the sheath until the lead is fixed. Once the dilator is removed, it's difficult to manipulate as the sheath may kink. And it is very important to understand it doesn't make the vein patent. The vein is still blocked and multiple leads cannot be accommodated. So it's generally referred only for a single chamber. What about venoplasty? The advantage is it opens up the vessel and possibly maintains the patency later on also, improves symptomatology if the patient was symptomatic, easier implantation if especially multiple leads have to be implanted. The disadvantages being additional hardware like balloons especially are used and increases the cost. So antegrade only technique in which you just access from the subclavian area and you can just dilate and then complete the procedure, in which you do a balloon angioplasty with or without a stent. Both antegrade and retrograde is generally reserved for patients who have an occlusive disease, long segment, or central occlusion, in which you have to do a femoral as well as a subclavian angio and then get the bridge through a wire. Now, most of them would be a PTCA wire, and all PTCA techniques should be used for these patients. Progressive dilatation with balloons and additional stiff wire along with balloon dilatation can be used. You may use help of a snare also. Stenting is reserved in patients who have acute occlusion or with recall dissection or long stenosis, central stenosis, or recurrent stenosis after balloons. Choice can be self-expanding or a balloon expandable stent. So here is the one of the largest series by Worley et al., where they had shown that over 11 years, and that too, this was published in 2010. So after which the hardware has improved drastically, they have shown that most of the patients, they could do venoplasty. That is only 371 of 373 patients venoplasty could be done, and nearly no life-threatening complications with good success. No near-time infection was seen in these patients, and they could complete the desired procedure well. And they have given a list. They have given 22 steps how to do easily. And it's a very good paper to see how to do a venoplasty in patients who have CIDs. So what they have said is a peripheral vein venography, contrast injection is the best. You do see a better result with a venoplasty rather than dilators. It preserves venous access, and that's very important. You don't leave a closed vein. That's very important for the patient. It also, once you go step by step, you will be actually much better off doing these cases. So what are the pacing points that you should remember? Single chamber pacemaker is preferred. Smaller lead and sheath size is preferred. Double wire always to be given. Remove wire once the lead is positioned. Do not remove the sheath till the lead position is acceptable. Always use a long battery life pacemaker. Hemostasis should be proper, and antibiotic to prevent infection is very important. So comparing technically venoplasty versus a leadless pacemaker, the venoplasty treats venous occlusion as well as the related symptoms if they are there. It is the only way that you can do an AICD or a CRT rather than with a leadless. A single site access is generally used. No special training or support is required as what we need for a leadless pacemaker here in India. And it can be done emergently. You don't need the person to come the next day or the next within 2 days. Successful nearly in always, and complications are easy to manage as compared to some dangerous complications in a leadless pacemaker patient. And a long battery life devices can be used, and PG change is easy if required later on. Most important is cost effectiveness in the Indian scenario, where a venoplasty and a pacemaker implantation can be done as cheap as 1.3 lakhs to the maximum, including a stent, to be around 2.5 lakhs. And then a PG change cost, if the patient is there for long term, is minimal, and that is best for the Indian setup, while a leadless pacemaker cost here itself is around 7.5 to 8.5 lakhs. With implantation can go up to 12 lakhs. And recurrent cost of a new device at battery depletion is important. But yes, it is best for Western or reimbursement setup. Leadless pacemaker is not without complications, and as you can see, these are the complications. I would not enumerate them. But leadless pacemaker implantation in hemodialysis patients, the experience with Micra, as in this paper showed, that 98% though were successful, there were 2% mortalities. However, there were no infection as described. So these are the things that you need to remember. Embolization, you need to retrieve. There may be a vegetation even on a leadless pacemaker, though not seen very commonly, and vascular complications because of a large sheath. So summarizing, venoplasty with a standard pacemaker implantation is most cost effective, especially in a stenotic lesion, as described in this case. The Indian case scenario says that this is the most cost effective strategy rather than going into the costly leadless pacemaker of our times. Thank you.
Thank you very much to both the speakers for excellent talk, and they both have presented their topic very well. So there are pros and cons of leadless as well as the transvenous, but as far as the Indian subset, as Dr. Somu has said, the cost is very important factor. So with the experience like the Shomu, the transvenous plasty and pacemaker is equally, I think, equally effective with very low infection rate. Anything else? Any other ones to say?
Yeah, Sachin and Pramesh.
As sir said that in Indian setup, it is the best thing, but if one can afford, then leadless is the best. So both the speakers, I think, probably debated well on their front.
Right, sir. One is cost effectiveness. Hello.
Yes.
Yeah, one is cost effectiveness. Other is like if there are 20 complications, it's not like there are 20 complications with transvenous and there is only one complication with leadless pacemaker. So the complications are also somehow comparable.
Right. Do we have any points from Keyur, Manjunath, or Pinkesh? Do we have any counter from for the presentation from Dr. Tamid? Are you there?
Yeah, I'm here. You know, I agree that cost is a big thing, and it's obviously important in India, but it's also important in the US. You know, because there's obviously healthcare expenditure here is a big issue as well. I think one has to keep in mind the costs of infection and the quality of life issues that happen in patients with infection. There are very few extraction centers. A lot of these patients get an infection and they're just going from hospital to hospital, doctor to doctor for months on end. And you know, what cost does that add to the patient? And you know, you can't even put an explanation on quality of life when a patient keeps going to the hospital with bacteremia and the pocket, you know, the pocket has pus coming out, you know, continuously. You know, you have to keep that in mind. I just, unfortunately, there's no way to directly compare, you know, like if you had done this, what would have been the cost versus the other? And there's probably never going to be a randomized trial for that. But I just wanted everyone to be aware of the costs of infection, which is very, very high.
I would say one thing that yes, infection though high, we don't see it very means often. I would not say that it's not uncommon, but yes, with the T-Rex patch that is available, so you can be extra careful in such patients where you can give as suggested a smaller device with a smaller pocket. Just get things fast, get it done with the experienced operator. And once you do that, the chances of infection decrease quite a lot. Obviously, infection is, even in a normal person, is as bad as a renal dysfunction patient. But yes, the limitations with antibiotics and the problems associated with renal dysfunction itself can aggravate. However, on top of that, if you recommend that to everybody, the cost is exponential and most of them would not afford. So it might be a good choice to choose your patient. Don't go for the high risk patients. Maybe if it is a stenotic lesion, a venoplasty is done, you can get out and do it very fast. While for a large occlusion, you know that these patients are very bad, you might just wish them to get a leadless pacemaker. Yeah.
Yeah, I agree. The truth is always in the middle, right? In these things, and it's obviously you have to individualize, you know, decision making. And you know, the unfortunate reality about these patients is that despite the best operator, you know, I'm sure you're extremely experienced, and so are many. Besides the best technique, 6 months down the road, they could have a skin lesion and get MRSA in their system, and then boom, the device is infected. So it becomes very challenging to make the decision at the time. You know, I'm sorry about the background.
No, that's completely well positioned by both of you, and I think the truth is always in the middle, and that's why we have debates. We try to create a scenario where you can actually pitch in for both. If there was to be no bargain left, then there would not be a debate. So that was the whole idea, and I remember Dr. Somu actually speaking for a leadless last year, and this year I switched the role, so we wanted Tammy to speak on that. So, Dr. Sharajan, you have any closing comments to make? Any other panelists?
I think, as I said, the future is of the leadless pacemaker, but by being right now with the cost and all these things, we have to accept that.
True. So we were pretty much on time. Just the electrophysiologists are very precise. They know where to ablate, where not to. So they were pretty much on time. And I think the overshoot time that we today have is because of the previous sessions, because again, not being gender biased, but we had an overshoot session because I think they deserved, the women in cardiology deserved their longer overdue session in their pitching in what they need to pitch about a women patient. So thank you very much. And this is the question. So all of the following are contraindication for the implantation of leadless pacemaker, except, so if you have an IVC filter, or if it's because of post mechanical TV replacement, any device providing cardiac therapy that may be interfered with sensing of micra, or an SVC obstruction. So that's the question. This will remain live till the next question is propped up, which is going to be tomorrow morning. Until then, on the delegate link, you all can actually attend the quiz, play along, and there are top prizes for the top 3 winners. So on the delegate link, of course, we all know SVC obstruction should not be. And this is an indication safety warning from the website of the device itself. The other 3 are mentioned in the package insert of the micra model VR01. So thank you very much for a wonderful day. And this will end the session today. And I look forward to have you again in the next meeting, Dr. Tamim. It was a pleasure to have you here. And I look forward to have the rest of the panelists join us in physical meeting tomorrow as well, and for continued learning as we learn along, we debate along, discuss the case scenario, and increase our knowledge. As they say, knowledge is one wealth that you can neither steal nor inherit, nor the king can snatch it from you, nor the brothers can divide or claim a property to. This is a sloka in Sanskrit, na rajharyam, na bhratbhajyam, na brarachari, and neither it has weight, and it can percolate and it only grows as it is divided further. Thank you very much. Good night, everyone.
Thank you. Thank you. Good night.
Looking forward to have you tomorrow morning. Bye.